or satisfaction that is supported by early economic value of new interventions based on affordability and cost-effectiveness analysis. And of course, a new interest in the field is looking at dimensions that go beyond the life expectancy of interventions and look at the distribution effects. I mean, in this we mean that how many people are impacted by new interventions and in terms of their income and maybe age. And this is a quote: hand clapping for science is now inextricably linked to hand wringing over affordability. We can no longer say that let's scale up a project because it is clinically effective. We have to look at affordability and economic efficiency in terms of how much will it cost us if we can scale it up to other people in other settings. And the reason behind this is that many projects don't see the moon, in that we have pilot projects, maybe a pilot study running for 1 year, and after that, scaling it up or bring it to a bigger audience is still hard. And the focus of funding agencies, particularly I'm aware of NIH and Bill and Melinda Gates, they emphasize cost-effectiveness analysis in all the proposals and grant applications. And of course, advocacy for cost value analysis through health technology assessment called HTA. And in this case, HTA, let's look at HTA in brief. What does HTA or health technology assessment mean? It's a multidisciplinary process that uses explicit methods to determine the value of health technology at different points in its life cycle. The purpose is to inform decision-making in order to promote an equitable, efficient, and high-quality health system. And these are a few notes under HTA. And one is that all interventions should be able to demonstrate the spillover effects towards families, communities, and other stakeholders. And when talking about HTA, we think about different levels of HTA. And number one is a micro level, whereby you think about a healthcare system and you're trying to add maybe a new device or a new drug and look at the incremental effect of this and how many people will benefit if it is clearly delivered. And in terms of this, we look at an example of perhaps dolutegravir when it was introduced to Uganda 5 or thereabouts years ago. And this is aimed at helping us develop clinical guidelines in which individual technologies are combined within a delivery or healthcare system to manage patients efficiently. Then the second level is called macro level HTA. And in this one, we look at the broader picture of how systems work. That is a framework of health system in general, and such as the number of doctors we have in the system, nurses we have in the system, or even healthcare financing structures in the system. That is, should we go for private or public insurers? And in a common setting or in our language, this is traditionally known as health services research. And one of the terms we look at is called priority setting, whereby we look at the broader picture and state-of-the-art technology to look at the burden of disease and allocate resources efficiently. Both macro and micro shouldn't be separated. They work hand in hand. So what is the economical of thinking? And this is the book by folks called Who Shall Live. And in this way, we look at resources which are scarce in relation to human ones, and not forgetting that these resources have alternative uses, and people have different ones. So the basic economic problem is that how do we allocate these scarce resources so that we can get the best satisfaction for human ones? And we have two contrasting points of view, whereby life is good or all is well. That is, they don't know about scarcity. And then we have monotechnic, which looks at one way of doing things. And this is the way of looking at, this is the economic way of thinking, whereby to some people, scarcity is not a problem. To others, it's a big deal. I don't want to delve into examples given what is happening in the country, but particularly in some sectors of this country. But you know that in some people, giving them 1,000 UGX is a good deal. To others, 100 million is a small token. That is the economic way of thinking and looking at things. And when we look at healthcare, we look at it in the economic way in terms of the production function. And the general healthcare production function is complex. Economics and any other field look at it in a mathematical way, whereby output is as a result of input. And for health, we have hospital days, doctor visits, drugs, and others. And if you're looking at a population level, you look at the social determinants of health, such as diet, lifestyle, and the level of income. Poverty can't run out from this equation. That is the individual's trade of health versus other economic goods. And economic goods here, we mean that any tangible good that can command a price or a cost. Not forgetting that the physician acts on behalf of patients, much as there's always conflict of interest. And the demand for healthcare services is the live demand. That is, if you seek health, you go to seek for healthcare, maybe within a facility or visit a hospital that is closer to you. That is why we say that the demand for health is the live demand. And what is the difference between economics and health economics? Economics looks at, that is general economics, looks at how societies allocate their scarce resources to satisfy the demands of their citizens. And health economics focuses on how these scarce resources are allocated to produce health and well-being, and in particular the role of medical care, or that is healthcare and health insurance. General economics assumes that markets are efficient based on the law of demand and supply. That is, to get equilibrium price, you look at demand and supply and come to the equilibrium price. But for health economics, it's quite volatile in that we have different circumstances that require different interventions and adaptations to improve efficiency. And one of them is that it is full of uncertainties. We have a new intervention, we don't know whether it's going to work or it's not. And the demand for healthcare services is difficult to predict. That is why health economics is different from general economics. And this is a title whereby when healthcare is a lemon. A lemon means that outside it looks nice, but cut it out and see what is inside, or take some juice. It's bitter. And this is typically like a market for healthcare. And it's filled with information asymmetry, whereby one individual is more informed than another. In terms of insurance, we have patients who know that they have a given sickness, but they can't reveal it to insurers or even doctors. Then we have moral hazard, where people behave recklessly because they know they're insured. Perhaps you may look at the case of, sorry to use the case of Subaru drivers, driving knowing that their car is very comprehensively insured. Even if anything happens except death, it can be taken care of. That is moral hazard. And these are typical questions addressed by health economics. And on the left-hand side, we look at what goods and services shall we produce? How shall we produce them? Who shall receive them? That talks about scarcity and choices, efficiency and maximization, opportunity cost. If this money was invested elsewhere, what would be the output? That is the opportunity cost, or the second best alternative when choice is made. Then we have marginal analysis, that is incremental cost versus incremental benefit, as well as equity considerations. Who benefits more if we implement this project? On the right-hand side, we look at the production of health. That is, what is health and how do we put a value on it? Value is how much people are willing to pay to get an extra benefit of health. Then what influences the demand for healthcare and healthcare seeking behavior? We say that the demand for healthcare is the live demand. When we get sick, that's when we go to demand for health services. And what influences the supply of healthcare. We have what we call supplier-induced demand. And in health economics, we have a famous quote by Romer, which says that a built bed is a filled bed, in that some people may be triggered to be admitted just because someone wants to earn a living. And there are alternative ways of production and delivery of healthcare planning, and we need to plan, budget, and monitor healthcare. That is where economic evaluation comes in. So when we talk about economic evaluation, just to, as a preamble, we are all applied economists. We evaluate costs and effects every day. So we are all applied economists. We evaluate costs and effects every day. We prioritize our choices. We make resource allocation decisions with our limited budgets. And think about a scenario whereby a couple is seated at Cafe Javas or Yams Cafe, and they are presented with a menu and they're looking at what to take and what not to take. That is the economic way of thinking. You see on course we have an egg salad, a tuna salad, and among the risks, maybe one may think about their tummy if the food is going to backfire, and the benefits. This is a typical scenario of how we do economic evaluation. And when we look at the promise and implications of the economic perspective, there's a key behavior premise here, and individuals act to maximize their happiness. That is to say, well-being and welfare, by choosing among economic goods and allocating resources so as to best satisfy wants. Economists refer to this as utility or satisfaction. And the important implication of this is that health can be thought of an economic good. That is, you can buy it, and individuals have a demand for health, but the producers of this include both the individual and medical care services. That is to say that you must be on diet in order to be healthy, much as we have hospitals and health facilities. Health is not the only good, and people are willing to trade off some health for other pleasures. That is, a cake once in a week doesn't hurt, or a piece of meat once in a week doesn't hurt. This is all about premise and implications of the economic perspective. And the economic problem here is that because healthcare resources are scarce, while healthcare needs are unlimited, we have to make choices. And this is why economic evaluation looks at improving efficiency. Who should do what, to whom, with what healthcare resources, and with relation to other uses of healthcare resources. That is the opportunity cost. That could we have got better benefits if we invested these resources elsewhere? That is the cost, that is an answer from economic evaluation. And this is the background of the cost effectiveness ratio from microeconomics perspective. And this is derived from the law of diminishing marginal utility, whereby additional units of a good should be consumed as long as the marginal benefit is greater than the marginal cost, given the income or budget of an individual or society. This leads to the following decision rule, whereby if benefits are greater than cost, or marginal benefit is greater than marginal cost, then consume. To an individual, this is based on your budget, but to a society, we have to look at the opportunity cost of these resources if they had been applied or invested elsewhere. And we often try to balance between costs and outcomes. And these are hard to balance, but the value or how much we're willing to pay for the extra benefit is the answer to this balance. And decisions have to be made regardless. And Scarf and Drummond made this famous quote that the appropriate way to judge economic evaluations is not whether they embody some ultimate truth, but whether they lead to a better decision than would have been made in their absence. That is, can we improve the health care system with economic evaluation? If yes, then proceed. And what is economic evaluation? This is a comparative analysis of two or more interventions in terms of their costs and consequences. And in terms of consequences, here we look at health benefits and outcomes. And for all economic evaluations, we use what we call Cheers report, meaning that if you're interested in publishing a study or doing a study on economic evaluation, this is the guideline we use. It's a 28-item guideline that is used to do economic evaluation for decision making. Famously called as the Cheers report. And the nature of health economic assessments looks at the new intervention and the current intervention or standard of care. And we have different pathways or prognosis depending on the disease. We look at the impact on health status, as well as in terms of survival, quality of life, hospitalization, and if possible, if it's a drug, the side effects of the drug. That is the economic way of thinking. And because each pathway or prognosis has an impact on quality of life as well as the costs. And this is the incremental cost effectiveness ratio. Maybe you've read a paper and someone talked about the incremental cost effectiveness ratio, or ISA, as the main outcome of the economic evaluation. This is how we come about it, and it's usually the denominator over the denominator. And in this case, the denominator is the outcome, that is intervention 2 versus intervention 1, or a new intervention versus the standard of care. Then the cost of the new intervention minus the cost of the standard of care. You get what we call the ISA, or the incremental cost effectiveness ratio. And costs are measured in monetary units, while outcomes can be measured in a variety of ways. We may have natural outcomes. Perhaps if you're looking at a TB intervention, you are interested in looking at cases detected. If you're looking at high blood pressure, you're looking at HIV, you're looking at viral suppressed people, and many more. And if sometimes we go an extra mile to calculate composite outcomes, commonly known as QALYs for quality adjusted life years, and DALYs, meaning disability adjusted life years. And when do we say that an intervention is cost effective? We use what we call the threshold rule. And an intervention will be deemed highly cost effective if the ISA, or the incremental cost effectiveness ratio, is less than the country's GDP per capita. Meaning that if you calculate the ISA and it's less than $900 for Uganda's case, it means that the new intervention is cost effective. And sometimes it may be cost effective if it is less than 3 times the country's GDP per capita. And that was set by WHO choice. And choice, we mean choosing interventions that are cost effective. Then in 2016, Woods and colleagues came up with another idea of looking at thresholds. And they say that when an ISA lies between 1% to 51% of the country's GDP per capita, then we can boldly say that the new intervention is cost effective. And in some cases like the US, they do benchmarking. Like for dialysis, if an intervention is cost less than 50,000 per quarry gained, then we say that it is cost effective. And also we use what we call the incremental net monetary benefit, which is a summary statistic that indicates the monetary value of the new intervention when the willingness to pay threshold is known. And when the INMB is greater than 1, we say that the new intervention is cost effective. Then we have what we call, it's famously called the cost effectiveness plane. And in this, it's like a compass with different quadrants. We have the first quadrant, the second one, the third and fourth. When an intervention lies in the northeastern quadrant, that is where the ISA rule has to chip in. We use the threshold to determine if the intervention is cost effectiveness or not. or not. Then when the ISA lies in the southeast quadrant, we say that the new intervention is dominant. And here it means that it's a good deal. It improves effectiveness as well as reduces costs. When the ISA is on the northwestern quadrant, that means the new intervention is a bad deal. Thus, we need to stay with the standard of care. And when it's in the southwestern quadrant, the decision rule is left to the decision makers. That is, the new intervention does not improve effectiveness, but reduces costs. How much of those costs we can save is determined by the decision makers. And they can decide if we can implement it to save this money and maybe invest it elsewhere, or leave it out and stay with the standard of care. Then we have what we call costs, or the numerator in the incremental cost effectiveness ratio. And we have what we call direct medical costs, and these are resources involved in providing medical services to treat a condition and its side effects. One of them is days in a hospital, surgical procedures, clinic office visits, laboratory tests, nursing home days, and home health care. And sometimes we do add training of medical care personnel. Then we have direct non-medical costs, and these are resources used direct in conjunction with medical care consumption. You may look at transportation, lodging, modifications to a home, and sometimes administration costs. Then we have indirect costs, commonly known as lost productivity costs. This is how much someone loses in terms of productivity when they are sick or when a caretaker is looking after them. These are called indirect costs. And we use different approaches to determine these costs. Now, one of them is micro costing, whereby you look at item by item in the cost analysis. And the second one is called gross costing, whereby you look at costs in disaggregated manner. If you look at a patient, you look at a patient in admitted and count the cost per day. That is gross costing. But for micro, you look at item by item. How many doctors did see them? How many days did they stay in the hospital? Or how many procedures were conducted? That is micro costing. And in modeling and economic valuation, we look at treatment comparison, clinical or epidemiological events, and the ultimate economic outcomes. If you're looking at efficacy and safety in terms of adverse effects, these have implications on both costs and quality of life, as well as survival benefits. That is the way we look at economic evaluation. And we have what we call a perspective in economic evaluation, and it's an important aspect here. And this determines the type of cost to include in your analysis. That is to say that what is the point of view of doing this analysis? And we have the patient, the societal, in the literature it is called the modified societal perspective, meaning that they try as much as possible to calculate all costs to form the societal perspective. Then we have the patient perspective, the payer, and the provider perspective. But I should emphasize that the societal and payer perspective is the most common in the health economics and outcomes research literature. In some funders are interested in the payer perspective because they assume that the societal perspective is quite biased in that some people or patients may not be working. That is why they are going for the payer perspective, which deals with the costs incurred by the payer and doesn't or exclude all costs incurred by the patient, like travel or lodging costs. So when we look at the societal perspective, it looks at the true economic costs, not just charges. And this includes indirect costs and sometimes tangible or intangible costs. These are costs related to pain. Usually only 2 and 3 are met. And this is done by key clinical leaders and the government or even the society. The payer perspective is only interested in the short-run medical payments, and they are not concerned about non-medical costs, indirect costs, or intangible costs, or costs related to pain and shame. Then we have the provider perspective, and this is always physician or the hospital itself. And it's not like going to take all medical costs. They're interested in the cost to improve the healthcare system or delivering care to patients. And of course, they do have a conflict of interest here in that being a patient's agent as well as their financial interests. Then we have a patient's perspective, which looks at out-of-pocket expenditure and medical costs or co-payments, as well as transportation, indirect costs, and pain and suffering costs. This basically fits the patient's perspective, or how much a patient will be interested in if you were to do the economic evaluation. Then we delve into decision analysis in economic evaluation. This is also another important aspect in economic evaluation or health economics in general. And what is decision analysis? This is a set of analytic tools for informing decisions under conditions of uncertainty. It's complementary to and commonly used in health economic evaluations as well as other fields. Perhaps you're looking at buying a new car or a new phone. You list your different options, iPhone, maybe Samsung Ultra S4, and after listing all your options, you take a decision. That is decision analysis. And it's well developed for healthcare evaluation to inform clinical decisions at individual and population level, commonly known as clinical decision analysis. When is decision analysis appropriate? It's when we are uncertain about which strategy is optimal. Uncertainty is looking at the intervention in terms of if they are cost effective or not, or if we can save money or not. Then also the risk-benefit trade-off. When the risk-benefit trade-off is clear, we look at decision analysis. A drug may be reducing the viral load, but leads to weight gain and dropout rates. The case of dolutegravir when it had just been introduced. And decision analysis can combine all three outcomes, viral load, weight gain, and dropout, and look at patient characteristics. This would lead to a better policy and clinical decision than would have been made if you didn't decide correctly. Then when there is a presence of meaningful trade-off in costs, benefits, or both, that is comparison of two of at least two options or interventions, one may clearly dominate clinically but have high expected costs. That is when decision analysis is inevitable. And accuracy and simplicity in decision analysis. Decision models should be sufficiently complex to incorporate important events and values, yet sufficiently simple to be understandable. That is to say that we have a common term called parsimony, whereby a model should be as simple as possible, whereby anyone can be able to view and interpret it clinically or non-clinically. Because your results won't only inform clinical decision, they are looked at by everyone. And they are not real-world representations, but simplified representations. And they capture key issues to fully describe trade-offs. Sometimes a simpler model is better if one has data limitations. You shouldn't look at a complex model if you don't have data to parameterize it or populate it. Simple and complex versions of models have often similar answers. That is, the goal is one. We're interested in cost effectiveness estimates. That is why you'd rather look for a simple model than looking at complexities. And include only important clinical and policy comparators. It's not good to include many comparators or iterations of comparators because they are data heavy and complex. You may look at A versus B or B versus C, but not A versus B versus C. The model will be complex and hard to interpret. Models allow explicit viewing of assumptions and inputs. That is, transparency is critical in decision analysis. If you're talking about a model and parameters, you need to highlight, set all costs and outcomes clearly so that anyone can see what you did within the model. Don't hide anything within the model in terms of parameters. But anyway, it will bounce back because a reviewer will bounce your paper. And assumptions and inputs should be in line with the disease epidemiology. That is, when we're doing this kind of work, we sit with epidemiologists and clinicians. If I'm interested in a TB project or a study, I don't do it from the economic perspective. I have to sit with a TB expert to see that what I'm trying to do makes clinical sense. That is what we do in decision analysis. Then another key aspect is time horizon, and this depends on the clinical problems. Acute diseases like malaria have a short time horizon, even flu. Chronic diseases like HIV, acute coronary syndrome have a long time horizon. That is, someone may get effects or their quality of life may deteriorate as time goes on. And the choice of time horizon may depend on the trade-off between completeness and data. Don't look at a longer time horizon if you don't have data to parameterize your model. And there is often a need to extrapolate trial results or short-time results into longer results. That is, you may use surrogate outcomes to go deeper into clinical outcomes. That is extrapolation of data using a short time horizon to look at a lifetime horizon, whereby you follow up someone until they die using the country's life expectancy statistics. And we have a few steps in decision analysis. Number one is identify and bound the problem, whereby if you're looking at a new disease in Zamunda, a country called Zamunda, you may need to look at the interventions available. How can I come out of this? If it's an epidemic, how do I come out of this? That is identifying and binding the problem. Then structure the problem. We often start by sketching these models on a paper or even on a screen. We sit with as a group and see, does this make sense? If it does, then let's proceed. Then gather the data to populate your model. You shouldn't draw a nice model without data to parameterize it. And then after that, you analyze the tree and perform sensitivity analysis. We are going to look at sensitivity analysis in the upcoming slides. And an example of decision tree modeling in public health, this is the paper my colleagues and I published last year, and it was looking at the cost effectiveness of increased contraceptive coverage using a family planning benefits card compared with the standard of care among urban slum dwellers in Kampala. The oval-shaped look shows that we use the decision tree model to assess this, to do this cost effectiveness analysis. And an example of a decision tree we used is right here. In decision trees, the first square implicates or means a decision node. The circle means a chance node, and the red triangle means the terminal node. That is at the point where your outcome should be clearly stated. At the chance node, these are different events when a different intervention, a drug is administered, the prognosis of the disease. And the square, like I said, is the decision node. Should we go with a new intervention? Should we go with the standard of care? That is the decision node, the chance node, and the terminal node. These are key concepts in decision trees. Others. That is when sensitivity analysis is inevitable. We also do have structural uncertainties. Some models don't make clinical. That the structure of the model does make sense. So we have the model. The structure of the model may have an impact on your analysis or may render your analysis non-generalizable. Then sensitivity analysis is a powerful tool for evaluating the correctness of the model as well as assumptions within the model. It also contributes to data uncertainty and overall uncertainty as well as validating your conclusions. If you're familiar with cost effectiveness study, you often see that we performed a one-way sensitivity or deterministic sensitivity analysis to assess the implication of model parameters on cost effectiveness estimates. And we come to the famous or two types of sensitivity analysis we have. That is the one-way sensitivity analysis and the probabilistic sensitivity analysis. The one-way sensitivity analysis looks at adjusting or varying parameters within the model one by one. You increase, if it's a probability, we look at the 95% confidence interval, and if it's a cost, we often use 20 to negative 20% to positive 20%, or 50% to plus or minus 50%. And in the economics literature, this is often called deterministic or univariate sensitivity analysis, and is always presented as a tornado diagram. The second one is called the probabilistic sensitivity analysis, or PSA, and this is based on random draws for probability distributions using the first order Monte Carlo simulation, reflecting uncertainty about specific parameters. Like you run a model 10,000 times to see that you get similar results or different results. That is the PSA. And it's often presented as the cost effectiveness plane or the cost effectiveness acceptability curve. So what tools do we have for economic evaluation? And this is the gist of the matter, in that maybe at the end of this presentation, you may identify a few of them that fit into your study. And as a recap, we have two main models in economic evaluation. And all this we're doing is called decision analytic modeling. We have decision trees like I showed you in the previous slide. And these look at short-term or acute illnesses such as malaria, influenza, and some cases TB, if you're looking at a one-year project similar to a pilot study. And they often depend on surrogate outcomes. Then we have what we call Markov models, which look at chronic diseases with possible relapses and recurrence, such as cancer, acute coronary syndrome, HIV, and stroke. We have Markov models and decision trees. And how do we select a model? This is an important stage of decision modeling, and it depends on the overall objective of your study. Why are you doing this study, as well as the disease, epidemiology, or prognosis? And all models are simplifications of reality, and as much as possible, keep your models as simple as possible. Complexity does not always translate into the best cost estimate or cost effectiveness estimates. So it depends on the disease epidemiology and the main goal of the main objective of the economic evaluation you're doing. And economic evaluation in brief can be looked at as in terms of two questions. On the vertical axis, we have a question: is the comparison of two or more interventions, is it a comparison of two or more interventions, alternatives? That is the vertical axis. On the upper end or horizontal axis are both costs and outcomes of alternatives assessed. If it's a no, then it examines only outcomes, and that is called partial evaluation or outcome description. If it examines only costs, that is partial evaluation, commonly known as the cost of illness or burden of disease analysis. In the TB arena and in Uganda, we have a study done by Mutamba and colleagues. That is the cost of illness study we have regarding TB in Uganda. It has been cited quite often and is a good study. This is a typical example of a burden of disease analysis study for TB. Then if you're looking at, you're only looking at costs, you're looking at outcomes rather, and among two interventions alternatives, then that is the traditional EPI study, an RCT or a quasi-experimental study design. If you're only looking at costs of two interventions, that is a cost analysis study. And if you're looking at both costs and outcomes, but of a single intervention, that is a cost outcome description. For this presentation specifically, we're interested in the purple end, which is a full economic evaluation. Like I said, is the comparative analysis of two or more interventions in terms of costs and outcomes. That is the purple end we are looking at, and we're going to look at one by one. we have a consequences analysis, a cost minimization analysis, a cost effectiveness analysis, a cost utility analysis, as well as a cost benefit analysis. And this was adapted from the book by Drummond et al., which is among the Gospels of Health Economics. And looking at different types of economic evaluations, we have a cost consequences analysis. On the left-hand side, we look at the method of analysis or the analytics tool. In the middle is the cost measurement, and sometimes in almost all settings, we look at US dollars as the standard currency. If you're doing a study perhaps in Malawi, you may be interested in Malawi kwachas. If it's in Sudan, Juba, you may be looking at South Sudanese pounds. And on the right-hand side, we look at outcomes. For the cost consequences analysis, or CCA, we look at a multidimensional listing of all outcomes. And for the cost minimization analysis, we assume that the outcomes are equivalent and we're interested in the cheapest intervention. For the cost effectiveness analysis, which is quite common, we look at natural unit measures such as life years, cases of TB detected, millimeters of mercury, and maybe the number of women screened if it's a cervical cancer screening program. And for cost utility analysis, we look at multiple outcomes and commonly known as composite outcomes, QALYs or quality adjusted life years, and DALYs or disability adjusted life years. For the cost benefit analysis, we look at costs and outcomes in monetary terms. Then we have other economic evaluation methods. We have the extended cost effectiveness analysis, or ECA, whereby multiple outcomes are listed, and this looks at the distribution effect of different interventions. Then a budget impact analysis, which looks at natural outcomes as well as the costs. What does a cost consequences analysis look at? This is a systematic description and measurement of a set of intervention attributes that should be considered when making a decision, and it does not prescribe a decision rule. All you do in a cost consequences analysis, you list outcomes and costs of different interventions and leave it for the decision maker to pick the cheapest or what they're interested in. And this is akin to everyday life, whereby, like I use an example of a phone. If you're interested in a phone, you look at the best options and list all attributes of different types of phones. And the advantage is that it is simple to interpret, but the problem here is that we leave all our welfare into decision makers, and sometimes they have conflict of interest, which is not a good thing. And ultimately, this increases the welfare of a decision maker instead of the patients or the beneficiary. That is a cost consequences analysis. The second one is a cost minimization analysis. And here we assume that different or the assessed interventions have similar outcomes, and the objective is to assess or get the cheapest. And historically recommended for economic evaluation of trials with no statistical significance in effectiveness. That is, if there is no significant comparative effectiveness, a cost minimization analysis is inevitable. And it's rare. One of the disadvantages of this is that it's rare to find interventions with similar outcomes. That is why it's rare to find a cost minimization analysis in the current era of health economics, because different scholars have said that as much as possible, go ahead to conduct a cost effectiveness analysis, whereby you look at different outcomes and, if possible, surrogate outcomes and costs of different interventions. This is a cost minimization analysis. Then we have what we call a cost benefit analysis. And here we place monetary values on both inputs and outcomes, thereby allowing comparison of projects or interventions across the entire economy. This is often called the comprehensive economic evaluation because we can compare interventions in the health sector with interventions in other sectors like environment or even education, because both outcomes and costs are expressed in monetary terms. The problem here is that in healthcare is that it's hard to put a monetary value. It's not recommended ethically to put a monetary value on life. That is one of the limitations of doing a cost-benefit analysis in healthcare. And this, it also allows the intrinsic value assessment, whereby you look at if an intervention's benefits are greater than costs, then we assume that it is cost-effective and should be implemented elsewhere. That is generalizability or transferability in health economics. And the beauty about CBA is that it can be done even on a single project, whereby if you're looking at a cervical cancer screening program, you may look at it in a certain way that it doesn't have a comparator, and you come out with costs in monetary terms as well as outcomes, and to see if that intervention is efficient or viable. That is the beauty about a CBA in comparison with other analytic tools in economic evaluation. Then the gist of the matter is the cost effectiveness analysis, which is common in the literature and sometimes interchanged with a cost utility analysis. You may meet a study that talks about, that is typically a cost utility analysis, but says the cost effectiveness analysis of intervention B or A versus A. And here, with the cost effectiveness analysis, outcomes are measured in natural units, in that if it's a TB screening program, we are looking at cases detected or correctly detected or averted. The outcomes are usually clinically relevant. For example, life years, TB cases detected, pregnancies averted. And it is useful for the decision maker who is considering options within a certain field, e.g. TB screening. It can be used to compare intervention to achieve same outcomes. The advantage here is that it is easy to communicate and enjoys a lot of specificity. But the disadvantage is that it does not allow comparison of mortality-heavy interventions versus morbidity-heavy interventions. An example is road traffic injuries in our setting, which are mortality-heavy compared to antidepressants or for depression, which are morbidity-heavy. So one of the limitations of a CEA is that it does not give us the ability to compare different types of interventions across disease areas. And an example of a cost-effectiveness analysis in regards to TB programming. This is a study I'm currently doing with my colleagues at IDI. Stella is one of them, and Rita Makabai. And we're looking at the cost-effectiveness of a community-based, directly observed therapy for the treatment of multi-drug-resistant TB in Uganda, CB dot versus HF or health facility dot. And these are preliminary findings from our study. As a background, health facility-based direct observed or HF dot has been the main strategy for managing patients with MDR TB, though associated with suboptimal health outcomes like survival and treatment success. So the CB dot or community-based dot is any interventions with favorable health outcomes, treatment success rate, low adverse effects of TB treatment, and survival. However, no study has been done to assess its cost effectiveness or if there is value for money if it implemented on a large scale. Therefore, the objective of this study was to assess the cost effectiveness of the CB dot compared to the HF dot in managing MDR TB patients in Uganda or in a low-income setting. This is an example of a cost effectiveness analysis. And in terms of methods, this was a cost effectiveness analysis that was interested in survival and life years gain. We did this study from the societal and payer perspective, and we used a decision tree model to estimate costs and outcomes. And primary and published literature were used to parameterize the model. and as much as possible, we followed the chair statement. The comparators were the CB dot and the HF dot. And our main outcome of this analysis was the incremental cost effectiveness ratio, or ISA, in terms of cost per life year gained. And this is a simple decision tree we sketched to answer this question on the cost effectiveness of on if the CB dot is cost effectiveness or not compared to the health facility dot. This is the sketch of a decision tree we used. And in terms of parameters, we used these parameters. And if you look at this, the cost parameters, most of them were obtained from the burden of this study by Mutamba et al. In 2020. And for probabilities, they are derived from the quasi-experimental study design by Makaboy et al., or the primary study, or the extensive study of this, the original study. In terms of our results, which are common in the best case analysis results, we see that the CB dot is associated with a survival of 83%, while the HF dot is associated with survival of 76%, and the incremental survival is now 7%. In terms of life years gained, which we estimated using the median age of a patient living with MDR-TB, we see that the SCB dot provides 29 life years, while the HF dot 27 years, a difference of 2 years, which is a huge difference. And the cost, in terms of cost, the CB dot is led to $1,000 or $1,200, while the HF dot was associated with $1,600, leading to the incremental cost of $366. And in the economics literature, we don't mention names when we have a negative cost or a decremental cost. Rather, we say that it is that all the standard of care is dominated. And from the payer perspective, it was the same story. The old interventional standard of care was dominated. So what was the conclusion here? In this study, we say that in addition to being clinically effective in terms of favorable treatment outcome, the CB dot is both cost-saving and cost-effective compared to the HF dot in MDR-TB patients. That is to say that for every per person life year gained, the society will save $170, and the payer or Minister of Health in this case will save $100. We now go to a cost utility analysis. And here, this uses a non-financial common metric that allows comparisons across the health sector. That is, we can compare different drugs and technologies within the health sector. And in this case, because we are heavily hinged on quality and quantity of life, we can able compare mortality-heavy interventions like road traffic injuries in Uganda with morbidity-heavy interventions like for depression or antidepressants. It transforms the disease-specific measures into generic outcomes by combining the quality of life and life expectancy into one outcome measure. And the common metrics we used here are DALYs and QALYs. And it should be noted that CUAs, or cost utility analysis, may not capture the inter-health sector comparison completely, because some parameters may be difficult to include in some models. And CUAs require studies to estimate utility or satisfaction for quality measurement and disability weights for DALY measurements. And for DALY weights, we have a study, Salomon and colleagues did a burden of disease analysis study of over 200 diseases, and they estimated DALY weights for each disease. That is what we use in economic evaluation. Or if we are looking at DALYs, DALY is averted as the main outcome of the economic evaluation. A typical example of a CUA study is a study I did at the IDI. And we are looking at dolutegravir versus efavirenz. among third trimester mothers. And the title of this study was Dolutegravir compared to efavirenz for prevention of perinatal or vertical transmission in women presenting with HIV in late pregnancy in Uganda. That is a cost-effectiveness analysis study alongside a randomized clinical trial or RCT. And this was part of the Dolphin team, and the results of this study were presented at AIS in Australia last year. So in terms of background, efavirenz at that time was the standard of care, like 10 years ago, and dolutegravir was recommended into and integrated into Uganda's HIV test and treat policy guideline as the first-line treatment for all people living with HIV, including breastfeeding mothers and their children in 2020. So our RCTs showed that dolutegravir or DTG was more effective, tolerable, and safer than efavirenz in third trimester pregnant women and their neonates. However, no study had been conducted to see the cost effectiveness of DTG compared to efavirenz. In this study, the objective was to assess the cost effectiveness of DTG-based ART in late presenting women, in late presenting pregnant women compared to the efavirenz-based ART for preventing perinatal transmission in Uganda. And in terms of methods, this was typically a cost-utility analysis study whereby we looked at DALYs averted as the main outcomes. And we did this study from the Ugandan public payer perspective, which is the Ministry of Health in Uganda. And in this study, we combined a decision tree and a Markov model. A decision tree was used to estimate short-term outcomes, which were then used to populate a Markov model or a three-state Markov model. And we used both primary data from the Dolphin clinical trial and the published literature. And we used a lifetime horizon whereby an infected pediatric was followed up until they died, using Uganda's life expectancy of 64 years. And the main comparators here were the DTG-based ART versus the efavirenz-based ART. And our main outcome of this evaluation was the incremental cost-effectiveness ratio in terms of cost per DALY averted. And these are some examples of the model structures. The first one is a decision tree to estimate perinatal transmission across both arms because it was not estimated in the clinical trial. So we used a decision tree to estimate vertical transmission among pregnant women. And this decision tree estimated that perinatal transmission rate was 1.8% in the DTG arm compared to 3% in the efavirenz arm. Then we used the perinatal transmission rate to populate a Markov model, which is on the lower side or the right-hand side. And this was used to estimate long-term costs and outcomes using a lifetime horizon. And this is a three-state Markov model. And the states were HIV, advanced HIV, and dead. And these different probabilities were estimated from the literature as well as from the clinical trial. Then we used the country's life tables by the WHO to estimate age-specific or non-disease specific or background mortality. This is mortality may be caused by an accident. Someone is on the bypass and they're hit by a car. This is not related to the disease itself, and it's often called background mortality. And in this study, we did not account for adverse events to avoid double counting of treatment effects as well as costs related to treating adverse events of each regimen. And these are some of the parameters we used in the model for the decision tree on the first side. Then the cost from the Dolphin books or accounting books, we see that the annual cost of ART during pregnancy for DTG was around $2,300, while the annual cost in the efavirenz arm was $2,200. This is from the accounts records at IDI, just to emphasize that in whatever we are doing, all professions are important. we need cost data from the grants team, we need outcomes data from the clinicians and experts, and of course, statisticians if an economist is not well conversant with statistics. Then there's still parameters in the model, and our outcomes, daily weights, were derived from a study by Salomon et al., and this was the global burden of disease analysis in 2015. And we used the discount rate of 3% to account for time preference for health and better, maybe money. And these are our results. Our main results here, discounted at 3%, indicated that the cost per person per annum was 43.58 in the DTG arm compared to $68 in the efavirenz arm, leading to an incremental or decremental cost of -24 or -25. And the DALYs in the DTG arm were quite lower, 0.33 compared to 0.56 in the efavirenz arm, leading to an incremental DALY of 0.23. And the interpretation of this that DTG is a good strategy. It saves money and is cost effective. Then someone may be wondering, how do we do sensitivity analysis like I mentioned at the beginning? This is an example of a one-way sensitivity analysis whereby different parameters are put in the model to assess the impact on cost effectiveness estimates. And this tornado diagram on the left-hand side shows that the discount rate was the largest influencing parameter in this model. Maybe people have time preference for health. That is to say, health now is better than future health. And also the annual cost of treating and caring for a pregnant mother. Then in terms of the probabilistic sensitivity analysis, we see that and in terms of probabilistic or PSA, we mean that best case results or the first results are run 10,000 times or sometimes 1,000 times to see if similar results will be got. And in this case, we see that these pairs were largely distributed in the southeastern quadrant, meaning that there is a great deal of certainty that DTG is a good deal. It is both cost effective and cost saving. That is why all pairs are lying in the southeastern quadrant of the cost effectiveness scatter plot or cost effectiveness plan. And in terms of conclusion, we conclude by saying that from the Ugandan payer perspective, public payer perspective, the two-part cost effectiveness model showed that DTG is less costly and more effective than efavirenz and lead to cost savings of $110 per disability adjusted life year. In other words, it is both cost saving and cost effective. And at that time, there was a discussion on whether to confirm that DTG is recommendable or not. And we can see that given favorable health benefits and cost savings associated with the DTG-based ART, these results support the WHO's stance on using DTG as the first-line treatment for people living HIV, including pregnant women and their infants. That is where health economics chipped in informing health policy decisions. At that time, DTG was effective, but the economic question hadn't been answered. That's why we came in to do this and confirm that indeed it's recommended and can be taken up as the first-line treatment for all people living with HIV. Then lastly, we look at what we call the budget impact analysis. And many policymakers, including funders, are always interested in this. If I pilot an intervention for 1 year, how much will it cost me if a similar intervention is scaled up and implemented in 5 years? This is often called the budget impact analysis. And it is useful for budget planning and forecasting and estimating the budget holder's affordability. That is, in other words, it answers the questions of affordability, or if a policymaker or a payer, in this case, Ministry of Health, can identify more funds to scale up the new intervention at large or to other populations or other regions. If you're looking at health facilities and your pilot was based in Kampala, the question to be answered is that, can I scale it up to other regions? And that question can not only be answered by clinical comparative effectiveness, but rather budget impacts or affordability and clinical efficiency or cost effectiveness analysis. And as a recap, cost effectiveness analysis answers the question of, is it good value for money? I mean, does it make sense if I scale it up or if I implement this project? That is resource allocation, or less inputs, more output. That is clinical or economic efficiency. But the budget impact analysis, or BIA, answers the question of, is it affordable? That is budgeting and forecasting. And a BIA is often performed alongside a CEA. That is, when you've proved that a new intervention is economically efficient or does represent value for money, can we afford it? Or can we scale it up to other population groups? That is why it is done alongside the CEA. And it indicates the fiscal implication of scaling up the new intervention to the budget holder. And a budget impact analysis is done if the new intervention is cost effective or is adopted irrespective of whether it is cost effective or not. That is, someone may randomly say that, I want to know the implication of implementing this project at scale, much as it is not cost effective, and maybe it has been adopted into the healthcare system. And in conducting a BIA, these are the few steps. Number one is that you characterize the population to see how many people are likely to be affected by the scaled up intervention. Then select a plausible time horizon, which shouldn't exceed 5 years or 6, otherwise it won't make a lot of sense to decision makers. And then document the current state of the disease area or the intervention you're looking at. Then estimate the cost of the new intervention at scale. Present results to different audience or stakeholders, including a group of people who are seated here. And this is derived from the task force report on guidelines of conducting budget impact analysis by ISPO. And ISPO, we mean the Professional Society for Health Economics and Outcomes Research. And this is an example of a BIA study we've conducted. My colleagues and I have conducted at the IDI. And here we are looking at the budget impact analysis of an enhanced retention strategy for PMTCD programs in Uganda. And the findings of this study were presented at the beginning of this month at CROI 2024 in Colorado. And in this study, as a background, the retention rates in the Dolphin clinical trial was 92%, meaning that loss to follow-up was only 8%, compared to the national rate of 63%, translating into 37% of loss to follow-up among people taking HIV regimens or HIV drugs. And in our study, or the Dolphin trial, we estimated that the perinatal transmission rate was at 1.5% compared to the national rate of 2.8%. And why a lower PT or perinatal transmission rate in the Dolphin clinical trial? The game changer was the enhanced retention strategy. That is, there's the way we did things different to what MOH is doing. And the objective of this study was to estimate the budget impact of the enhanced retention strategy compared to the standard of care approach for preventing vertical transmission among women initiating RRT in late pregnancy in Uganda. And this slide specifically shows the different strategies, and we see that the Dolphin clinical trial had many options, whereby to the extent that people were visited in their homes, and couples, we had couple counseling, and there was a strong connection between our workers at IDI as well together with the women and their infants. And the methods here, we adopted the PEPFAR model, PMTCT model, which is an Excel-based model for PMTC programs, and allows follow-up of women receiving PMTC services over 5 years. New patients were added into the model every quarter, while others are removed as they are lost to follow-up or even die. We use data on HIV epidemiology and expenditure from the literature, as well as the Dolphin clinical trial. That is the HIV epidemiology data for Uganda. And cost projections accounted for a variety of programmatic inputs, disease progression, differences in mortality based on treatment status, subsequent pregnancies, and other factors. And we did this study from the Ugandan public payer perspective. And as much as possible, we conservatively assumed a 50-50 market share, meaning that these two interventions are competing favorably. The main outcomes of this analysis were the incremental budget costs as well as infections averted over 5 years. And these are some of the parameters we used in the model. And they're derived from the clinical trial, that is Dolphin clinical trial, as well as the national HIV epidemiology data. In our results, we see that adopting the ERS would lead to a net cost increase of $64 million over 5 years, which is a net cost increase of $13.8 million per year. And newly enrolled patients account for over 40%, 40 million of these marginal costs, while insisting patients account for only $24 million. Direct programmatic costs of the ARS or the enhanced retention strategy only account for 3% of this additional cost, with 97% of the marginal increase coming from the cost of providing ART for women who would otherwise be lost to follow-up. That is, much as it's quite costly, 97% of these costs were incurred for following up people who would otherwise be lost or would die. Then the ERS, or the enhanced retention strategy, would avert an additional 6,000 infant infections compared to the standard of care, and more than double the probability that women would be retained on ART at the start of subsequent pregnancies. That is 24% versus 11% versus 25% for ARS versus the standard of care. And in our conclusion, we say that implementing the enhanced retention strategy would have a significant budget impact on the Ministry of Health budget, but most of the additional costs derive from the resulting expansion of outpatient volume. That is to say that most of the additional costs come from following up mothers who would otherwise be lost to follow-up, and it's a good thing. The ERS itself is a relatively low-cost intervention, or cost-effective, to reduce loss to follow-up rates among marginalized and hard-to-reach populations. And what is the potential contribution of economic evaluation as I wrap up? It's a pathway to universal health coverage. In other words, it reduces wastage of resources and helps prioritization. When I was at the health metrics unit at the University of Gothenburg, there came a question. The city of Gothenburg wanted to implement a national program on flu vaccination among the elderly in Sweden, but they were wondering if it is worth doing it or not. They came up with a question on how to do this. And when we did the economic evaluation study, that is looking at the cost effectiveness of mass flu or influenza vaccination among the Swedes aged 60 and above, our study results indicated that it was not worth doing. That is, the new intervention at that time, which was flu vaccination, was not cost effective. And Sweden, being Sweden, had to stop that massive or mass influenza vaccination because of the cost effectiveness results. Another study was also looking at initiating ticagrelor compared to clopidogrel among acute coronary syndrome patients in Sweden. And one of them, I think, which is clopidogrel, maybe I may be corrected, showed that it was indeed cost-effective in this population. That is why it was initiated or started on in the treatment guidelines of acute coronary syndrome in Sweden and in general Europe or Scandinavian countries, Denmark and Norway. So it's a pathway to universal health coverage in that it gives you that this intervention is worth taking care of or worth putting on the package, and also reduces wastage of resources. Now assume that the influenza vaccination was initiated or was implemented without thorough studies. It would have been wastage of resources because the benefits were less than the costs. And also, as much as possible in our studies, let's embrace clinical effectiveness alongside cost effectiveness studies. This will beef up our studies and will help decision makers not only depend on comparative clinical effectiveness, but also look at clinical economic efficiency and affordability of our new interventions. And this can be applied to different disease areas. In whatever study you're looking at, it may be leprosy or TB or cancer. Cost effectiveness is applied anywhere. And let's differentiate between cost effective and cost saving. Cost effective means that it is worth doing, there is value for money. Cost saving means that there is what we save money by implementing this strategy, like I showed in the examples. And the major goal of any healthcare system is to maximize health benefits for the resources consumed. That is, to get value for money spent, thereby achieving economic efficiency. And if you're interested in this field, these are the gospels we have. One book by Drummond et al. Called Methods for Economic Evaluation of Healthcare Programs, and Cost Effectiveness in Health and Medicine by Gold et al. In 2006. The second one, these are practical guides to performing analysis, and these are key books if you're interested in performing economic analysis or decision analytic modeling, decision trees and Markov modeling, as well as dynamic transition modeling, or in some cases, discrete event simulation models. Thank you for your attention and interest.
Thank you, Eli. We will now take some questions. We already have one from the chat that we will read out to you. But if we have any questions, please raise your hands and we will get a mic to you. Let us get our second and third mics. Oh, okay. Take them. Okay, so if you have a question for our presenter, there's one online, Eli. It says, excellent presentation on cost effectiveness. Thank you very much. Now, related to your work on DTG and efavirenz, you clearly show the benefits and recommend DTG over efavirenz. But do your analysis take into account the risk of clients developing DTG-associated weight gain and subsequent insulin resistance and potential type 2 diabetes? Did you do a sensitivity analysis? Actually, he suggests that perhaps a sensitivity analysis would help if previously not done. Would you please respond? Back to the presentation. While we get your presentation, there's another question.
Yes, thank you for the presentation. I am interested in how do you quantify the cost of pain and suffering? I saw that in your presentations and I was amazed. How do we quantify that cost?
Okay. Thank you, Dr. Waluku. All right, any other question? Oh, two more questions.
Thank you, Eli. That was a great presentation. I would like your insight into how one would approach TB interventions, because it's approached from various aspects. Prevention, we know there's vaccines which are somehow effective, diagnosis and treatment, and the social support. We know TB is a disease of poverty. Where will you put your money?
Thank you, Eli, for the great presentation. During your talk, you did mention that patients generally are more concerned about out-of-pocket expenditure on health. A few months ago, the Ministry of Health was pushing for an insurance policy that probably would play into what you're discussing. What's your take on that?
Stella, you may forgive my sins. If I forget, maybe remind me.
Okay. So perhaps you can start with the first question.
Yeah, the first
online.
question to my presentation. Yes. So, just as a recap, in this study, it's a typical cost-utility analysis study, and we're looking at dolutegravir compared to efavirenz for preventing perinatal transmission rates among women presenting with HIV in late pregnancy in Uganda. And this cost-effectiveness study was done alongside the RCT, or the Dolphin clinical trial. To answer his question, in one of the assumptions, which is clear stated here, before doing this study, another study looked at the quality of life between these two groups. And this was a study done by Perez Ochanda Itar and colleagues. It showed that there was no significant difference in the quality of life. That is why we assume that the adverse effects, if we included them in the model, they would simply lead to double counting of treatment effects and costs. That is the assumption we took, which was, of course, proved in the sensitivity analysis. So to answer his questions, we assume that accounting for adverse events would lead to double counting of both effects, treatment effects, and costs. And in the sensitivity analysis, we see that the main parameters which influenced our ISA or incremental cost effectiveness estimates were discount rate, annual cost of ART during pregnancy. Of course, it involved a lot of things, follow-up of patients in their homes, then also the transitional probabilities, and none of the costs were related to the treatment of adverse events. So whoever asked the question, yes, we did a sensitivity analysis, particularly a one-way sensitivity analysis, and it showed that treatment of adverse events was none of the most influential parameters in the model. The second question came about estimating the cost of pain and suffering. We use what we call the willingness to pay threshold, or the willingness to pay amount. Sometimes this a hypothetical amount that an individual or society is willing to pay in order to gain an extra health benefit. We use what we call willingness to pay amounts. And this can be done using different tools. You may use a visual analog scale, a standard Gamble, or a rating scale. So that's how we estimate costs related to and suffering. And in some cases, we use what we call the revealed preference approach, whereby you go for high-end people. Perhaps you look at high grass cleaners. You're like, okay, if you clean, which one is the tallest building in Uganda currently? Help me. Okay, you tell them, like, if you were to clean that grass, how much would I pay you? That's how you estimate the pain. Or for female workers, we have what we call the wage differential estimate, where, of course, we've heard about these stories that if someone is not going to use a condom, how much would you be willing to take up? That's called the wage differential estimate. The third question is about TB interventions for regarding vaccination, and I'm getting closer to you. Part of my work as being a student teaching assistant. And we use different approaches. Number one is that if you're looking at interventions, perhaps like a CB dot, which I presented in my presentation. That is the first study, which was the cost effectiveness analysis of this one here. Here we are looking at the cost effectiveness analysis of a community-based CB dot compared to the health facility dot for treating multi-drug resistant TB in Uganda. This was an intervention, and that's why we used a simpler model, which was a decision tree. This approach may not come into vaccination. For a vaccine, it has implications. We have different things that happen. We have recurrences, relapses, and all manner of things. That is why we would use a different approach. Perhaps I've seen colleagues use Markov models, whereby, and with the Markov model, I mean, this is a typical example of Markov model, whereby people move from state to state. That is what we use for vaccination. But for prevention and maybe treatment access programs, I would recommend decision tree modeling. If you're looking at vaccination, yes, go for Markov modeling, or sometimes others use compartmental models, that is susceptible, infective, and recurrence models. That is the approach. Then the fourth question was about universal health coverage. For universal health coverage, that is why I started with the definition of technology assessment and different levels of health technology assessment. You can't, we need to set the ball rolling in that we set different units. Like what kind of intervention am I going to put in the universal health coverage package? That is the first question I would start with. And this can only be informed by economic evaluation. If an intervention or a new drug represents value for money, add it on the package, universal health coverage. And the second question is that is often called heterogeneity in economic evaluation or health economics, meaning that how is the distribution effect of this intervention, or how many people or which kind of group of people will benefit more from this intervention. If an intervention shows that it is cost effective, maybe among low-income earners, then roll it out. If it's among high-end earners or the rich gang, please think about it. That is the approach I would take. First of all, develop an HTA body, which is independent of Ministry of Health, but working closely with Ministry of Health to see that all interventions suggested to be implemented or added to the package are cost-effective, or they present value for money and are benefiting low-income earners. Thank you.
I think we have just, we are right on time, so thank you, Ellie, for keeping time. We are supposed to go for break in 1 minute, but in that final minute, we have a question online from one of our listeners online. He says, thank you very much for your presentation, Ellie. Any highlights on sampling, especially sample size estimation in a cost utility analysis?
Nice question. And regarding sample size in economic evaluation or cost effectiveness studies, this largely depends on the statistical sample sizes. We don't do things different. We are always working collaboratively. That if a study if the RCT was strong enough, for instance, like an example of the dolphin clinical trial, the sample size is well enough to estimate the costs and outcomes. So in most cases, that's why we use different methods. That if the sample size is not clear, or the estimate of the sample were not clear, we use what we call bootstrapping to account for missing data. So it can be catered for in economic evaluation. Bootstrapping, or sometimes Monte Carlo, first order Monte Carlo simulation.
All right, thank you, Eli. Thank you very much for giving us your time. Please, members, if you want to know more about bootstrapping and cost utility analysis and everything that Eli has talked about, please have a cup of tea with him and get to know more about economic evaluation of health interventions. We will now have our tea break. Our tea break is 30 minutes long, and we will come back. Okay. Yeah, so we will come back. We'll start coming back in a little bit earlier, maybe after 20 minutes. Yes. Since we are keeping time, we don't want to start to fall behind. And then we will have a session on TB vaccines, immunology, and post-TB lung disease. Thank you. So a round of applause for Eli, please, as he goes. A round of applause. Break tea is just right outside that door in the free space area. That is where break tea is being served. Please, 20 minutes. Now we have 18 because it's 2 minutes past 10.
My name is Dr. Tria Westavia, the Assistant Commissioner in charge of tuberculosis and leprosy control at the Ministry of Health, Uganda. TB is one of the infectious diseases that our country is dealing with. High burden country as classified by the World Health Organization with an estimated incidence of 196. This is a drop from 200 that we have had over the last 3 years. It is this year that we have had a drop of 2.7% in our TB incidence, which translates to about 90,000 Ugandans falling ill with TB every year. As a country, we are able to identify a good number of these people that fall ill with TB. The most recent financial year that we concluded in June, we were able to reach over 84% of all those who were ill with TB, the highest also that this country has ever achieved, which is very good progress that the country is making in reducing the burden of those people that fall ill with TB that are not identified and started on treatment. We had a shock in the first lockdown, and the access to TB services was affected because of restrictions in movement and so many things that were put in place for the control of COVID-19. Following the gradual release of the lockdowns in March, starting July, we started to see recovery of TB services with an improvement in the number of people that were getting onto treatment. The quarter April-June 2020 was the worst hit period in terms of people not accessing TB services. with a coverage of around 64% among those whom we expected to find. But in the quarter starting July 2020 up to the quarter of April-June 2021, we see the coverage has gradually improved among those that we expected to see to now the highest that we saw by the end of the financial year of 84%. So there's been progress, and thanks to the health workers out there who have been resilient in terms of making sure that they keep screening people who come to the health system. But also as a program, we put in place interventions and guidance to enable the health workers to offer the quality services and make it more accessible to the people during the pandemic. We realized that it was not easy for people to move from the communities to the health facilities given the transport hikes and restrictions in movement. So interventions to integrate activities at community level, screening and treatment delivery were instituted, and these have helped us to recover in terms of reaching more people with TB. But also in keeping the people with TB on treatment. We see also steady progress in this area despite the COVID-19 pandemic, and our treatment success has risen to now over 85%, which is great success. This has not been achieved even before the era of COVID. So we think really that we have improved in terms of offering our quality TB services in line with our mandate and our mission, which is ensuring that every Ugandan gets accessible, affordable, and quality TB services. This year, we are organizing the National Stakeholders Conference. It is the fourth conference that we are organizing. What is special this year is that we are organizing it in the era of COVID-19, but also organizing it as the first accountability era or forum during the the 5 years of the new strategic plan that started 2020-2021. So we are going to look at our progress during this conference, and we see whether we are in line with our targets that we set. We set ourselves to reduce the TB incidence by 20% by 2025, and set a 90% targets in terms of creating awareness about TB and leprosy, preventing tuberculosis among people who need to receive prevention, identifying people who fall ill with TB to the tune of over 90%, and also keeping people who are ill with TB on treatment to the tune of over 90%. So this is the first conference or stakeholder engagement that we are having to review our progress and see whether we are on track with our 90% targets for awareness, prevention, diagnosis, and treatment success. The theme for our conference is accelerating progress towards the UNHRM high-level meeting targets, United Nations high-level meeting targets that were set in 2018. This was the first time tuberculosis was getting on the global agenda at the UN General Assembly, and global leaders agreed to certain targets, and Uganda had set targets in the areas of identifying people with TB, in the areas of identifying people with drug-resistant TB prevention, and also investing in TB to make sure that we are able to reach all people with TB services. So we want to accelerate progress towards attaining the national targets in those areas, so that by 2022 we are able to account to the UN Assembly what the country has done. And we hope that by the end of this conference we'll be able to agree on what key interventions need to be put in place for us to achieve on the targets that we seem not to be on track with. There are some targets we have met, like providing preventive therapy to people living with HIV, We ran a campaign in 2019, and this, by the time we ended the campaign, we had achieved that target. So we want to see whether we can do similar activities to identify people with TB so that we can hit our set target, but also to put on prevention children and who are in contact with TB patients and adults. We are thinking of at least having 3 people in each household with a TB patient that has confirmed TB started on preventive therapy. That way we'll be reducing on the number of people developing TB annually. So let's all come out and seek services that are available in the whole country, from the community level to the highest level of health service level.
I think we are not tapping enough out of this TBcast program.
I'm wondering whether they have translated material that can be able to guide the audiences that is actually live TB free, not live TB free.
The number of clients we identify are reduced. There is no, you start them on treatment before you realize the next time you are going to check on them, they know where it is.
So we still have that challenge of these people.
If you have very good results, could it be extensive?
We are strengthening community disease surveillance on all the borders. We are not only targeting TB and rainbows, but we are all identifying diseases.
at the NTLP Summit to present her work on the incidence of acute kidney injury and associated mortality among individuals with drug-susceptible tuberculosis in Uganda. So, tuberculosis is associated with significant mortality and morbidity.
Kimanyere rero nti, whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health. Kimanyere rero nti, whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health.
My name is Dr. Tuya Westavia, the Assistant Commissioner in charge of tuberculosis and leprosy control at the Ministry of Health, Uganda. TB is one of the infectious diseases that our country is dealing with. High burden country as specified by the World Health Organization with an estimated incidence of 196. This is a drop from 200 that we have had over the last 3 years. It is this year that we have had a drop of 2.7% in our TB incidence, which translates to about 90,000 Ugandans falling ill with TB every year. As a country, we are able to identify a good number of these people that fall ill with TB. The most recent financial year that we concluded in June, we were able to reach over 84% of all those who were ill with TB, the highest also that this country has ever achieved, which is very good progress that the country is making in reducing the burden of those people that fall ill with TB that are not identified and started on treatment. We had a shock in the first lockdown, and the access to TB services was affected because of restrictions in movement and so many things that were put in place for the control of COVID-19. Following the gradual release of the lockdowns in the month starting July, we started to see recovery of TB services with an improvement in the number of people that were getting onto treatment. The quarter April-June 2020 was the worst hit period in terms of people not accessing TB services, with a coverage of around 64% among those whom we expected to find. But in the quarter starting July 2020 up to the quarter of April-June 2021, we see the coverage has gradually improved among those that we expected to see, to now the highest that we saw by the end of the financial year of 84%. So there's been progress, and thanks to the health workers out there who have been resilient in terms of making sure that they keep screening people who come to the health system. But also as a program, we put in place interventions and guidance to enable the health workers to offer the quality services and make it more accessible to the people during the pandemic. We realized that it was not easy for people to move from the communities to the health facilities, given the transport hikes and restrictions in movement. So interventions to integrate activities at community level, screening, and treatment delivery were instituted, and these have helped us to recover in terms of reaching more people with TB, but also in keeping the people with TB on treatment. We see also steady progress in this area despite the COVID-19 pandemic, and our treatment success has risen to now over 85%. Which is great success. This has not been achieved even before the era of COVID. So we think really that we have improved in terms of offering our quality TB, which is ensuring that every Ugandan gets accessible, affordable, and quality TB services. This year, we are organizing the National Stakeholders Conference. It is the fourth conference that we are organizing. What is special this year is that we are organizing it in the era of COVID-19, but also organizing it as the first accountability era or forum during the first.
Good morning to you all. If we can return from our break tea, so that we start our first session of the day.
And we see whether we are in line with our targets that we set. We set ourselves to reduce the TB incidence by 20% by 2025, and set a 90% targets in terms of creating
So we'd like to
awareness
just
about
be a
TB
little bit ahead of schedule so that we can keep time better today. So if we can come back from our break tea so that we can start.
People who fall ill with TB to the tune of over 90%, and also keeping people who are ill with TB on treatment to the tune of over 90%. So this is the first conference or stakeholder engagement that we are having to review our progress and see whether we are on track with our 90% targets for awareness, prevention, diagnosis, and treatment success. The theme for our conference is accelerating progress towards the UNHRM high-level meeting targets, uniting.
So we are going to have our first session or abstracts for today. And the session theme is TB vaccines, immunology, and post-TB lung disease. Our chair is Professor William Orodria. Professor, welcome. Professor William Orodria is an honorary professor of Makerere University and a senior consultant chest physician under the Ministry of Health, Mulago National Referral Hospital. He's the head of the pulmonology clinic, and in 2023, he received the Philip Hopewell Prize for Leaders in Global Respiratory Health. He was the second recipient of this prize. Welcome, Professor. Our co-chair is Dan Nyehagane. Dan is a biologist with interest in molecular epidemiology and pathogens, vaccinology, and post-disease sequelae. He works with MSF Epicenter in Mbarara, with Mbarara University and Karolinska Institutet, Sweden. So, Dan, that makes you my alumni. Welcome.
Thank you, and good morning, colleagues, ladies and gentlemen. We will proceed with the next session, and this indeed is an exciting session on TB vaccines, immunology, and post-TB lung disease. This session symbolizes what is referred to as the holy grail in tuberculosis. It's extremely complex, and if we understand it, I think all our problems of TB will be solved. I would like to welcome the speakers for this session to come up front. Dr. Anne Waja, Ludovic Zimenya, all welcome to the front. And okay, I'm informed that Ludovic's presentation will be done by Professor Alison Elliott. You're most welcome. So each presentation will take 6 minutes, and I would like somebody to help us with timekeeping and notify that. Thank you. So the first presenter will be Dr. Anne Waja from MRC. Please do introduce yourself briefly as you start your session, since I don't have all the bios here. And we are going to have a presentation of the current landscape of TB vaccine development. Dr. Anne, you're most welcome.
Thank you very much, Dr. William. My name is Dr. Ann Waja. I'm a senior scientist at the Medical Research Council, UVRI, and LSHTM Uganda Research Unit in Entebbe. And I'm a principal investigator in a number of trials, mostly for TB vaccines and other vaccines. So I'm just going to give a summary of the current landscape of TB vaccine development worldwide. Okay, so the vaccine that we know that's available to us is BCG, which was developed by those two gentlemen there many, many years ago. It's the only licensed TB vaccine, and it protects children against severe forms of disease like TB meningitis and disseminated forms of TB. So it also has other beneficial non-specific effects, so it actually works. We have a working vaccine. However, the protection, protection from the most transmissible form of TB, which is the pulmonary TB, is lowest near the equator. So as you look at that graph, you show that there are different things which affect how well BCG works. And what they have found is that as you get closer to the equator, which is where most of the TB is anyway, the BCG doesn't work as well as it works in the Western world. So that means we need to get a better vaccine which works better. Sorry. So what is the WHO Global Strategy to End TB? This is Professor Jolova spoke about this yesterday, and it shows that if you look at the graph here, the current global trend is that every year the incidence rate is reducing by 2%. And if we continue this way, we'll never be able to hit the 2035 plan. However, if we optimize the current tools we have and then pursue universal health coverage and social protection, we'll be able to reduce this to 10% reduction every year. But even then, that will not be able to hit the 2035 target. So in order to hit the 2035 target, there are other things that needs to be done. And one of them is to introduce a new vaccine, a new prophylaxis. In that way, we'll be able to reduce the rate by 17% every year. Dr. Jolova talked about this 95-90-0, 95% reduction in TB deaths, 90% reduction in TB patients, TB incidence, and reducing the catastrophic costs of care for TB. I have to get used to how to do this. Okay. Yeah, also the SDG had a target by 2030, but I think that's been overrun by the 2035 target NTB. So what is the TB development pathway? It really takes a long time, and up here we have the preclinical phase in the upper part, where we have discovery, proof of concept studies, then we have preclinical evaluation, and then we prepare the portals for the new vaccine. So that takes quite a long time, and it requires a lot of money. Wherever you see the red ring, there's a need for injection of money. Then we have on the lower line, you have the different phases of trials, from phase 1 up to phase 4. And then once we see it's efficacious, then it's registered, and then we have the launch. So the development pathway is quite long. And who are the people that we have as target populations for new vaccines? When you look at this is a graph of the incidence rate of TB, and we know that the rate goes up in early childhood and 2 years of age, and then as you come down, it starts coming down, and then at adolescence, we see the rate going up, and then into adulthood, as we know. So the two main target populations for these new vaccines is adolescents and adults, and then also infants. So WHO has decided on 3 goals for development of new vaccines. The first one is to find a vaccine that is safe and effective and also affordable to be used in adolescents and adults, which is new. We don't have many vaccines which we give to adolescents and adults. So this would be able to prevent infection and progression to disease, especially pulmonary infection and reactivation. Then the second goal is to have an affordable TB vaccines for neonates and infants. This is mostly to improve safety and efficacy compared to BCG. This is mostly because we know that there's adverse event, for example, in immunocompromised babies who may have reactions to BCG. Then the third goal is to find a therapeutic vaccine to improve treatment outcomes. So this is the landscape. I'm going to have to move here because my screen is here, sorry. This is a landscape of the TB infection. So we want to see who should be vaccinated and when. So we know infection happens it either cleared or through the innate immune responses or the acquired immune responses. So then after that, you may continue. Once that's before people are infected with the bacilli, then they're not infectious. Then afterwards, they move on to latent TB when they get exposed to MTB. We know that most of us have been at least we have latent TB. But then a small proportion continues on to subclinical disease and then finally to active disease. So when should we give these vaccines? So the first time is pre-exposure. I want to get a vaccine that prevents infection. And this would be it would have a big public health impact because infections there are more infections than disease. So because there are more people who get latent TB, so then if you can prevent more people, then it will have a really big public health impact. And even then, those trials would require smaller numbers of people and a shorter follow-up. Then the next group would be post-exposure, when somebody already has been exposed to infection, and this would be to prevent them from progressing to disease. You know that progress to disease takes about 2 years, and only 5% actually progress to disease. But the trials for the progression to disease would be required to be very large and with a large sample size and very long follow-up. And the endpoints for those trials would be clinical TB or subclinical TB and microbiological TB endpoints. Then the last group would be the therapeutic vaccines. These are vaccines which could be given during or at the end of treatment, mostly to reduce recurrency, morbidity, and also improve outcomes, reduce mortality. And the endpoints there would be looking at a mycobacterial culture, pulmonary function tests, and PET or CT endpoints. So this is really the main point of my presentation, which is the current global TB vaccine pipeline. I'll try and maybe here, point from here. So the pipeline has 16 candidate vaccines, and 12 of them are in active trials. And the trials are different types of vaccine, different platforms. We have live vaccines like BCG. Then we have live attenuated vaccines. And then we have viral vectored vaccines. We have subunit vaccines. And then recently we got an addition of the RNA vaccine. This is the first time that we're having RNA vaccines following COVID. I think also in now TB we've had 2 vaccines which are RNA vaccines. So, and the vaccines are targeted at different populations, at elderly, adults, infants, and also different groups of people with HIV, people who have never had MTB infection, those who have been exposed to MTB. So the different groups of populations are target. And then we have different vaccines, as I mentioned, either preventing infection or preventing disease or preventing recurrency or therapeutic vaccines. So these are the different phases of the clinical vaccines that we have. We have those in phase 1, in phase 2A, phase 2B, and phase 3. And these are few compared to other diseases, but 10 years ago, this pipeline had very, very few candidates. So now there's been, okay. So I just highlighted those vaccines which are we have black boxes around them. Those are vaccines that we have been involved with, we as a unit at the MRC. Our team has been involved with ChAdOx 85A, and we also currently on the part of the VPM trial, which is a multi-site trial in 5 African countries, and we recently got that trial extended for another 3 years, which is very good. We've also been involved with some of the other trials, like the MTBVAC and the M72. For the M72, were one of the sites which were being considered for selection, but unfortunately, Uganda has not been selected as a country to do both this MTBVAC and M72 trial. But we also have a footprint there. So there's also a big population, which is important, the people living with HIV. We need an effective vaccine to prevent HIV-associated TB, and also RT, virus suppression, CD4 recovery, and completion of TPT. And we, because we have live vaccines like BCG, it may not be as safe for people with HIV. So in the trials that we do, we want to include persons living with HIV to be sure that we can at least know what happens with them. So the inactivated vaccines like M72 might probably be safer for HIV, people living with HIV. So in summary, there are 16 TB vaccine candidates in the pipeline with 12 inactive trials. And these late phase trials, phase 2B, phase 3, will need large numbers, and so they'll be needed to be done in countries where there's a high burden of TB. So we need to do capacity building, vaccine preparedness activities, and community engagement. We also need to be innovative in the trial designs. There are new innovative things of doing controlled human infection models of BCG. I don't know, Alison will talk about that, because it's one of those innovations. Looking at aerosol delivery of vaccines directly into the lungs, looking at combining antigens in more than one antigen in a vaccine. And of course, I mentioned the RNA platform, which is new in the TB pipeline. And we need more basic research to understand BCG better, because it works and it's the mainstay of the vaccines that are being developed, but it has its challenges. So we need to see how to improve it. And most of all, we also need to identify correlates of protection for TB, because we don't have them, and so developing a vaccine when we don't know whether it actually works is a challenge. And of course, funding, more collaboration is important to support this expensive venture when there is really sometimes no business case for the funders. Yeah, so what are the implications for the program? We need to continue with work with UNEPI to ensure good BCG coverage, because we've said BCG is the mainstay of our vaccines. And then we need to support research and capacity building in TB vaccine development and preparedness, strengthen collaborations and network with local and global TB vaccine researchers, and also collect and share accurate epidemiological data, because when selecting a site, we need to know what the epidemiology of TB is in those sites. Thank you. I think I'd like to acknowledge so many people are involved in the TB vaccine world, and those are some of them. Thank you.
Thank you very much, Dr. Anne Waja, for the presentation. Please note any questions. We shall have a Q&A session at the end of all the presentations. So next, I would like to invite Professor Alson to present on the population differences in vaccine responses, results of 3 linked randomized control trials. Professor Alson, you're most welcome.
Thank you very much. It's a real pleasure to be back here with the TB gang after some time, but I've been still here and interested in this issue of why BCG is less effective in the tropics than it is in temperate countries. So I lead the vaccine theme at the MRC UVRI and LSHTM Uganda Research Unit at UVRI. And I'm here with Dr. Ludo Ziramenya, who has been a key person in this project that I'm going to talk about. So I'll talk about the background to this issue about BCG and 3 hypotheses that are current about why BCG doesn't work so well in the tropics. And then I'll tell you about the design of the POPVAC studies. PopVac stands for Population Differences in Vaccine Responses. And then I'll tell you a little bit about the results, conclusions, and next questions. So I got interested in this because of the big challenge that I'm sure you're all conscious of effectively controlling TB by case finding and treatment, and the need to find an effective vaccine. And so, as Anne has highlighted, it's a big challenge that BCG is less effective as you get nearer the equator for controlling adult pulmonary disease, and especially in rural places. So those green stars are rural settings. So the problem that we're addressing is that BCG is the only licensed vaccine against TB, as Anne pointed out. BCG protects against severe disease in infants and young children, but the efficacy against adult pulmonary disease, which is the source of transmission, is lower in studies nearer to the equator. And the big question is, will new TB vaccines be similarly affected? So there are three hypotheses around this topic as to why this might be the case. So the first one is that there's protection already, or there are some effects of exposure to environmental mycobacteria. After all, BCG is a live mycobacterium, and in this environment we're exposed to many other non-pathogenic mycobacteria. So might they be having some effect? And there are theories that they might block if you've been exposed already to environmental mycobacteria, that might block you from responding to BCG. Or alternatively, it might be that the environmental mycobacteria give you quite a lot of protection, so it's like you've had a BCG already. So then it would look as if the BCG is less effective, because even the control arm of a vaccine trial would be already protected. Oh, I think this isn't I had cut down on the slides, but somehow it didn't get saved. So the second area is about worms. So some of you may be aware of this hypothesis, that worm infections tend to induce a strong T helper 2 type response, and this can suppress the T helper 1 response, which is generally thought to be beneficial in protecting against TB. So because people in tropical countries tend to be more exposed to worm infections, especially in rural settings, maybe this would interfere with the way people respond to BCG. And then there's a third area, which is one way of talking about it is as immune endotypes. And here the idea is that because in different environments we're all exposed to very different things, this models our immune system, so that people who grow up in a rural African setting would end up with an immune system that's quite different from somebody who grows up in maybe France or the US or somewhere like that. And so as well as so we know that things like allergy are much more common in people from urban settings and people from high-income countries, and autoimmune diseases. But also there are a number of different vaccines where responses seem to be higher in those kind of countries than they are in the rural tropical settings. And so that the idea is just a sort of non-specific difference in our immune systems. So we set up the PopVac trials to try and investigate this, looking at urban and rural Uganda. So PopVac A was undertaken in the Kome Islands in Mukono district, which are very highly endemic for schistosomiasis. And PopVac B was undertaken in a sort of upcountry part of Jinja district where a lot of people have malaria. And then PopVac C was in Entebbe, which is a more urban setting. And we looked at school children aged 9 to 17, because this is an age group that's old enough to have been sensitized to any environmental mycobacteria or other environmental exposures, and it's also the target age group for vaccines which would protect against adult pulmonary TB. So we gave the children 6 different vaccines, but I'll focus on BCG. And in the schistosomiasis trial, we gave half of them intensive treatment with praziquantel, that's the red stars. In the malaria trial, we gave half of them monthly treatment for malaria. And in Entebbe, we gave half of them BCG before the other vaccines. And then we can focus on the control arms to compare the responses to BCG in the different settings. So the primary response for BCG was the BCG-specific gamma interferon ELISpot assay, which we don't know what it means in relation to protection, but we know that gamma interferon is important. And we're also particularly interested in parasite clearance. So I'm going to tell you about the comparison between the settings and some of the factors that mediate differences and the trial analyses. So this is the comparison between the settings. So blue is the islands with lots of schistosomiasis. Green is the malaria endemic rural place, and orange is the urban setting. So what you can see there is that in the green rural setting, so the first panel is the baseline, and then the second panel is week 8 after the vaccine, BCG vaccine, and then week 52. So what you can see is that in the green rural setting, the baseline response to BCG was already higher than in the orange urban setting or in the blue island setting. And then in the middle panel, you can see that the green rural setting actually had the highest peak response. So we looked to see what might be the reason for the high baseline. It wasn't higher BCG coverage because the urban children had all had BCG. And it wasn't higher TB exposure because that was actually highest in the urban setting. So it's likely this was exposure to environmental mycobacteria. And this could feed into the idea that differences in the overall vaccine response picture are related to masking or blocking by environmental mycobacteria. So we did a mediation analysis, and what we showed was that the higher peaks in the rural malaria endemic setting were related to the higher baseline. And then the difference between the islands and ginger was related to the presence of schistosomiasis in the islands. So going over to the islands, this is the trial in the islands, where we treated half of them intensively for schistosomiasis. And here in the pink columns are the schistosomiasis level in the intensively treated people. And you can see that it dropped very quickly with the intensive treatment. So we got rid of a lot of the infection. And then in terms of the response to BCG, again, the pink ones are the intensively treated ones. And in the middle panel at week 8, you can see that they had a higher response to BCG. So that just emphasizes that. This is the malaria trial. At the beginning, 60% of the children had malaria parasites, and the treatment got rid of that, but there was no effect on the BCG response. So in conclusion, the response to BCG revaccination in adolescents in Uganda varies between different settings. The PopVac data indicate that exposure to both environmental mycobacteria and helminths may have a role in these differences. And the next questions are how the ELISpot responses that we measure actually relate to protective immunity. So are people in some settings actually already protected through the environmental exposures? In which case, the question about why responses are different closer to the equator might actually be not so much of a worry, in that people actually do have some protection. And we want to investigate this using the stored samples in growth inhibition assays. and then maybe in future, as Anne mentioned, go on to the controlled human infection models. And then how does the exposure to the helminths interact with exposure to the environmental mycobacteria? Is there also an endotype effect? And will new TB vaccines be similarly infected? So working with colleagues in the UK, we would like to set up some model of how we can test vaccines early in different settings to see which vaccines are going to be most useful. So this is a very big team involved in POPVAC, and some of the lead people up in the corner there, including Ludo. Thank you.
Thank you, Professor Allison, for those exciting findings. We will proceed to the next presentation. Diana, from Diana on babies born to mothers with active tuberculosis, having reduced BCG, tetanus, and diphtheria responses. So, Diana, you're welcome.
Thank you, Chair. My name is Diana Sitenda. I work with the Tuberculosis and Comorbidity Research Consortium that is headed by Associate Professor Rinandi Abiralo. I'm also affiliated to HEPI, and today I'm going to be sharing results of a study that was conducted by the TARC Research Consortium team in the year 2021 and 2022. The title we have is Babies Born to Mothers with Active TB Have Reduced BCG, Tetanus, and Diphtheria IgG responses, in addition to heightened IL-17 responses. The TB burden in Africa was reported to be even highest in the reproductive age of females, and we see this from the World Health Organization Global TB Report of 2022. Pregnancy alone increases or predisposes pregnant women to many other infections, including TB. And this is, because of the shift in immunity, like Prof. Allison had just hinted on the T helper 2 immunity being, more observed as compared to the T helper 1 immunity. And in instances where the babies are exposed to TB from their mothers, if it happens in utero, then they would have poor outcomes. For example, low birth weights, preterm births are expected, and also, distresses in being able to breathe. And so we were hypothesizing that indeed babies that are exposed to TB will have reduced responses to vaccines as compared to the babies that are not exposed to TB. And to be able to achieve that, we had objectives. Generally, we wanted to compare vaccine responses in children born of mothers that are diagnosed with TB in pregnancy. But specifically, we wanted to determine IgG titers to these different expand program on immunization vaccines. For example, the BCG, diphtheria, tetanus, and measles vaccines. And we did this longitudinally at baseline. We had another visit of 3 months, 6 months, and then 9 months of follow-up. But also we wanted to look at the MTB-specific cytokine responses, and these we only evaluated at baseline. So it was a longitudinal study that recruited participants from health centers of Kisenyi Health Center 4, Kasangati Health Center 4, and Mulago Kawempe National Referral Hospital. And upon their birth, the babies were assented, and we collected heparin blood from them, which was used to harvest plasma, which plasma was used to perform the enzyme-linked immunosorbent assays for the different vaccines. We also collected quantiferon blood, and this was incubated, and were able to collect the supernatant, which was used to perform the Luminex assay. In our analysis, we used GraphPad Prism version 9.5.1, and in there, if for our categorical data, for example, the gender of our babies, we employed chi-squares. And then for data like for our hemoglobin concentrations of the mothers, we employed the Manit-New test. And for IgG responses, for example, we used the mixed effects analysis using 2-case multiple comparisons. And our statistical significance was estimated to be at a p-value of less than 0.05. And some of our data were expressed as median and interquartile ranges. So among our key results, one, just like literature has it, our cases had low birth weights, and also the TB mothers had lower hemoglobin concentrations. The other key findings that are also key that we found are, one, the BCG titers were reduced at baseline among the babies that were exposed to TB. And then tetanus titers were reduced at baseline and also 3 months. Then for the DPT, the titers were reduced at 3 months of follow-up. Now, much as literature talks about the exposed babies having low birth weights, even when we analyzed the normal weights, or the babies that had normal weight, and looking at their responses to vaccines versus the babies that were not exposed, we did find that their responses were actually lower. And looking at the Luminex data, we looked at several cytokines, IL-2, GM-CSF, TNF-alpha, interferon gamma, and IL-17A. And this is what we found to be significant. So our cases had heightened levels of IL-17A. And the take-home message we have from this presentation, one, we are thinking perhaps these infants may require a booster dose. And also the heightened IL-17A cytokine response unfolds a possibility of ongoing infection in these exposed babies. But also this scenario is similar to the Dohard theory, because if exposure is occurring in utero, and then even after 6 months, you're able to see a response or something different, something showing a defect that might have happened, following the exposure, then we suggest the scenarios are similar to the Dohard theory. The other challenge we've really faced in writing up a manuscript is the fact that statistics for TB in pregnancy really require updating. I think that's a message that should go to the NTLP. And out of the results of our study, we are recommending a large cohort study to further explore the effect of maternal active TB among exposed babies. In conclusion, infant in utero and postnatal TB exposure reduces vaccine-specific IgG responses to BCG, DPT, and tetanus vaccines, in addition to increasing IL-17A responses. This is part of the TAC team, and I'd like to appreciate my mentors, Associate Professor Nandi Abiraro, who was actually the study PI, Dr. Rose Nabatanzi, Associate Professor Stephen Kos, Philip Sekamati, the work teams, and other institutions. Thank you so much.
Thank you, Diana. I will hand you over to my co-chair for the subsequent presentation.
Thank you very much, Chair, and thank you for the speakers that just made very fantastic presentations already. So we'll move on to the next talk that will be given by Martha Nakaye, titled Diagnostic Accuracy of Plasma LAM Antibodies in combination with urine LAM detection in high TB burden settings. Welcome, Martha.
Thank you so much, Chair. In addition to the available TB diagnostic tests available, there is need for rapid, easy to use, affordable, and sensitive diagnostic tests, which are applicable in all populations and in all settings with minimum infrastructure. So we did evaluate diagnostic accuracy of plasma LAM antibodies in combination with urine LAM for TB detection in a high TB burden setting. LAM is a component. LAM is a component of the cell wall of Mycobacterium tuberculosis that is usually shared by dying mycobacteria and can serve as a potential biomarker for TB. WHO recommends LAM for TB diagnosis among people living with HIV. However, its limitation, it has a low sensitivity among people living with HIV. Combining urine LAM with blood-specific antibodies has been reported to improve TB detection among people living in HIV in a South African paper in 2019. Therefore, there was need to explore the above approach, including populations without HIV. Our objective was to determine diagnostic accuracy of anti-LAM IgG and IgM alone, and in combination with urine LAM for TB detection among adults with presumed TB. The population included stored plasma samples from a parent study that had enrolled adults 18 years above with presumed TB, enrolled at 2 outpatient clinics, that was Kisenyi and Molago. We were able to measure anti-LAM IgG alone and IgM separately using ELISA, and urine LAM testing was done using the earlier determined TB LAM assay. We defined our microbiologic reference standard as a TB positive, one that had a positive expert ultra or MIGIT, and a TB negative as one that had a negative sputum expert ultra. From the data obtained, we performed a ROC analysis with a combined logistic regression model that included earlier LAM and the LAM antibodies, and were able to calculate sensitivity and specificity at 2 cutoff points. One that maximized specificity and sensitivity, that is Jordan's J statistic, and one that maximized specificity when the sensitivity is 90%, the goal for a TB triage test. I'd love to share our findings. When you look at our findings, overall anti-IgG demonstrated a higher accuracy compared to anti-IgM and earlier LAM alone. Furthermore, I would love to share our findings. The combined model gave a better or an improved diagnostic accuracy for TB detection as compared to earlier LAM alone and the antibodies alone, that is anti-IgG alone. When you look at the ROC curve, overall, the area under the curve was 0.80. When stratified by HIV status, among people living with HIV, it was 0.77, and among people living without HIV, 0.81. When you look at the performance of Alialam alone, overall it gave us a sensitivity of 25%, but slightly improved among people living with HIV, giving us a sensitivity of 35%. Interestingly, when you look at the combined model of the antibodies with Alialam, we see the specificity at a cutoff that achieves the 90% sensitivity. The goal for TB at triage test as having a specificity of 51%. In conclusion, anti-IgG had a better performance than anti-IgM in TB detection, and this is usually a reflection of what happens in our clinics. Patients report to the clinic when disease has progressed. Combining anti-IgG with Alialam improved diagnostic accuracy for TB compared to Alialam alone, but neither did Alialam alone nor the combination achieve the WHO product target profile accuracy thresholds for a TB triage test, which is 90% sensitivity and 70% specificity. So none of them proved to be a screening test. I would love to acknowledge Walimu with my mentors in the audience, Dr. Andama, Professor William, Global Health Labs, UCSF, University of California, Alvin, NIH funding, and to you, the audience, thank you so much for listening.
Thank you very much, Martha. Quite interesting to see the power of LAM and the thoughts that are going around it. We know how much we need it, especially in children and people living with HIV. So next, we will listen to Geoffrey Amanya, who will talk to us about notification trends of post-TB lung disease among TB survivors. You're welcome, Geoffrey.
Yes, so good morning. Please join us as we transition into the post-TB lung disease. Geoffrey Amanya is my name. I work as an epidemiologist with the TB program. So we shall basically be looking at evidence through the surveillance data on what we are seeing concerning the post-TB lung disease. So we know worldwide there was a modeling study which was done, and it showed that around 155 million tuberculosis survivors are still there globally. In the same modeling study, they showed that 18% will have been diagnosed with post-TB lung disease in the last 5 years. So then, but we also know the current roadmap from our the NTLP or the guidance we see globally usually looks at or focuses on diagnosis, treatment and care for patients of TB, but it doesn't go beyond the post-treatment care. Several studies have highlighted, some studies 50%, others 38.6%. Yesterday I was reading an article where they said 16% actually here in Mulago of the patients attended with post-TB lung diseases were attended a chest X-ray clinic just here in Mulago. So we know that post-TB lung disease is also associated with mortality rate almost 3 times when compared to the general population. So with that brief background, we thought that we use the surveillance data, provide or focus the implementing partners, whoever is implementing, health workers and everyone, to focus onto the growing problem of the post-TB lung disease. So basically, this was a review of our tools, retrospective surveillance data on key priority indicators for a 3-year period. We extracted data on age, sex, and we also looked at of course, we used the Mann Kando test to see if the trends are significant. So from the analysis, since 2020, we have seen a growing trend in post-TB lung disease, as reported in our surveillance systems. Around 2,300 patients, mortality of around 9.5%. And around 98% of those reporting to have PTLD above 5 years, around 98%. Yeah, so the mortality is also growing as we see the curve is concerning the post-TB lung disease. When we did a Mann Kando test, the trends were significant with a p-value of less than 0.001. So this is evidence enough to show that, yes, there is a growing problem of post-TB lung disease within our day-to-day data set. So where are the reports coming in from? From the regions, we look at Kampala having the highest patients reported with post-TB lung disease. We also look at South Central, Bunyoro, Acholi. They are reporting more of these patients having post-TB lung disease. The highest mortality being reported in Karamoja and Bukedi. This is evidence from our routine HMIS data. So these are, I think, the points of focus. Yeah, so what are the implications for this? So we have seen the burden of post-TB lung diseases still largely remains unrecognized. The burden still remains unrecognized, even when the routine surveillance systems cater for reporting. There is need to ensure we have routine monitoring for patients. And this brings me to a case where we know from the session we had in the morning, we know DALYs, they help us understand the years lived in disability, but also those who live with disabilities, and rather those who lose life prematurely. So just in line with this, the WHO is also, the guidance is also thin on what are the DALYs that happen after TB. The guidance stops on TB patients but doesn't cover the post-TB lung disease period. So there is need to also look at that. Then the other implication is there is plenty of missed opportunity from our surveillance systems to capture the associated factors for post-TB lung disease. Diagnosis and treatment, so this is an area that we may need to look at as well. Then a call for monitoring and treatment of post-TB lung disease must be implemented within the programmatic settings. We have seen the mortality is around 9.5%. As a country, last quarter we achieved a TSR of 91%. Last quarter, I must reiterate and say that alone is not enough. We need to see how we can monitor for the post-TB lung disease. Already, TB is among the high the diseases which are causing burden to the inpatient, among the top 10 diseases causing mortality at inpatient units. So it's very important that the 9.5 I talked about by PTLD, we improve monitoring to ensure that we don't cause further burden to our health systems. Then we also know that when you have recurrent, when you have post-TB lung diseases, you most likely are going to have recurrent hospital administration, rather admissions, but also longer stay in health units. So there is need to continue monitoring beyond TB care. Lastly, robust national and regional estimates for post-TB lung disease are sorely needed to drive advocacy and policy. We need to have the estimates from all these regions for us to be able to appreciate the problem of post-TB lung disease. I want to acknowledge the Ministry of Health, the funding bodies, academia, and the bodies which are taking interest in post-TB lung disease and our TB survivors. Thank you.
Thank you, Geoffrey. Quite interesting. I think there is a lot of interest coming up with regard to post-TB sequelae. Yesterday we talked a lot about what happens to people when they've actually recovered from TB. So I think after then we'll need to be thinking about a holistic approach to cover all these things all together. Now let's hear from Mudashiru Boye, who will talk to us about post-TB lung disease. He will give us an interval analysis of risk factors and characteristics in a cohort here in Uganda. You're welcome.
Thank you, Chair. I'm here to continue the song on post-TB lung disease. The album is not yet over because we need all partners and Ministry of Health to understand the burden that we are facing. The effort is immense with prevention and control. But what happens to those that skip that and skip into the treatment cascade, get cured or complete treatment, we have a burden there. So to start with, just to share preliminary results from a study that we are conducting at Mackay University Lung Institute, the PI, one of the PIs in the house, Dr. Stella Zawede, what we are seeing is that everyone knows that over 10 million people yearly develop TB, with over 50 having ongoing pulmonary dysfunction after cure. Majority of this dysfunction is not detected, with evidence of some being chronic respiratory abnormality and with or without symptoms. For some of these patients come with the symptoms, others they don't present with any symptoms. So over 76 million people may be living with PTLD currently. The phenotypes of this PTLD include COPD, about 15 to 45%, fibrosis, all interstitial lung disease of about 25 to 70%, and also bronchiectasis, which is about 35 to 86%. We don't have a current medication that is known for this issue or problem, but we need to have a consensus on pathophysiology, but also the risk factors, such that we can develop some preventive measures. So this was a prospective study within a network of 3 TB clinics in Uganda. We conducted a baseline assessment, but also 6 months post-TB treatment and 1 year visits. We collected a few demographic variables, socioeconomic, medical, TB treatment, and neurological data. And at 6 months, we conducted pulmonary functional tests, mainly the diffusion lung capacity test, and also total lung capacity test data was collected. So PTLD was defined in this case as any person with diffusion lung capacity volume or total lung capacity of less than 80% predicted, or a ratio of forced expiration volume of in 1 second to forced vital capacity. So we utilize chi-square and invariant logistic regression to evaluate risk factors and impact of PTLD. So what we see is that people that come at diagnosis, mainly males, like how TB is more prevalent amongst those, people that come from far the facilities, that means they have taken long to come to the facilities for diagnosis, have a high risk of post-TB lung disease. And also people that report disruption during the TB treatment cascade have a high risk for post-TB lung disease. Possibly what I forgot to let you know is that, as others have said, in this preliminary analysis out of the 87 participants, post-TB lung disease was prevalent amongst 44% of these patients. But also fibrosis was present at 6 months using a chest X-ray among 57% of the subjects. That means there is underlying destruction of the lungs that is not presenting in form of PTLD, all the symptoms, but it is growing that would lead to post-TB lung disease. But also subjects that had a worse respiratory quality of life at diagnosis using the St. Joseph's Respiratory Questionnaire were highly at risk of post-TB lung disease. To provide more insight on the St. Joseph's Respiratory Questionnaire, as we see, and patients that had a quality of life score 43 that was worse at diagnosis were highly at risk of post-TB lung disease 6 months after completion of treatment. That means that at the beginning of treatment, these patients are already bad off with their lungs, and the treatment worsens the healthy symptoms. So also, in conclusion to this is that there is a high burden of PTLD in our cohort, lack of access to care and severe symptoms at diagnosis associated with PTLD development, but also 57 of subjects had fibrosis noted on chest X-ray after TB microbiological cure. I would want to go ahead and say that after all of this is presented, what are we working on? On behalf of the Ministry of Health, Makerere University is supporting the scale-up of post-TB lung disease, a low-cost post-TB lung disease assessment and care package in Uganda. And we are working with support from Global Fund and the seed funding. So what we are doing is that we are establishing a delivery of low-cost post-TB lung disease care to survivors attending TB diagnostic and treatment units in Uganda. And here we want to assess the feasibility, effectiveness, and scalability of providing this care. As you've seen, the burden is there. I'll not go through the objectives because of time, but what we are doing is that we are piloting the screening of these post-TB patients. And what we have to first do is to rule out TB. And what we are doing is that we screen them using the TB national algorithm, rule out TB, conduct a syndromic diagnosis, but also manage these PTLD symptoms. As you've heard since yesterday, people have cardiovascular diseases, people have other complications. Then we conduct a disability assessment using the quality of life tools, including the PHQ-9, the CCQ, the MRC score, but also a designed syndromic assessment form. So what we are also doing after conducting that is that we are treating this disability with low-cost pulmonary rehabilitation. And here what we are doing is that we are utilizing exercise that is non-medical, non-pharmaceutical, to strengthen the upper limb muscles of these people, to strengthen the lower limb muscles of these people, but also to ensure endurance, to have endurance training amongst these people. The purpose of this is to improve their quality of life, but also to ensure efficient use of the little oxygen these people breathe in, because at this moment their muscles weight is reduced. But also we are coming up with the MEMO and E tools at patient and program level. So what we so far done so far, this is the cascade so far, as of 16th March, over 378 at these 6 health facilities under this pilot project to understand scalability, feasibility of providing post-TB lung disease care to these people. Over 378 post-TB patients have been assessed, but we found that over 30% of these have chronic respiratory symptoms at assessment. That means the burden of post-TB lung disease is at 30%. The results could be similar to results presented here from many people. But also, we've enrolled these to pulmonary rehabilitation. And we shall be presenting in due course results of how they are better. But if, what I can say is that a number of patients are gaining, their quality of life is improving. That's an action photo of a few of the patients, so I don't blow the identity of these patients undergoing pulmonary rehabilitation. And so what the implications of these results? First is to add on the existing knowledge that has been presented in this summit on the burden of post-TB lung disease and the need to monitor patients reporting with sequelae attributed to post-TB lung previous TB infection. But also we need to understand the drivers of PTLD development and biological signatures to such that we can understand this prevalent chronic disease. This PTLD care package implementation will facilitate reduction in the risk to mortality and morbidity due to post-TB impairment following TB completion, but also we are supporting the instituting formal structures to lead in the development and implementation of post-TB care program in Uganda, but also, main importantly, to decrease the catastrophic cost that patients face while seeking for care due to post-TB lung disease. I want to acknowledge for the research, the PIs and the funding from Virginia Commonwealth University in USA, but also for the care implementation, funding from Global Fund and the team from Mackay University Lung Institute and also team from NTLP that are part of this early implementation phase of post-TB lung disease care in Uganda. Thank you.
Okay, thank you, Mudashiru, for the wonderful presentation. And now I will hand over back to the chair to take us through the Q&A session.
Thank you. So you are welcome to the Q&A session. It will run thus. Please mention your name and institution and mention clearly to whom the question is addressed and keep it brief. Somebody please help us to monitor questions online. Can somebody help me with movement of the microphone?
Thank you. Thank you, Chairperson, and thank you, presenters, for those brilliant presentations. I have two questions, one to Professor Alson and the other one to Dr. Anne Wajja. So, the TB vaccines research has been going on for long, and Prof, the stories we had 10 years ago are the ones we are hearing today. Basic science research is lacking. We don't know what happens during latency. Now we don't know what happens why the BCG doesn't work properly towards the equator. Are we then surprised that when we are in that kind of confusion, even the funders who would fund the vaccines development would be doubting us? And then for me, my question is, how far have we gone? Because 10 years ago, I used to listen to those. Today, how far have we gone in that basic science research so that we say we can now point a finger and say we are moving closer, and we are going to achieve the TB vaccines, the new vaccine by 2035. For me, I would like to know that. To you, Dr. Ann, it was not very clear when you were talking about the young girls and adults. You will have to clarify that. Why are we targeting that? Why don't you say adults? Young, adolescents, and adults? You will need to explain that. But for me, that graph that you normally put, the one that shows the decline of 2% if we are using the existing tools, vis-a-vis when we combine it with the vaccine, which we don't have, you say we have 16, 12 in the pipeline that are in clinical trial. It means that unless we get that sorted out, both the basic science research sorted out and the vaccine candidates that are in the pipeline to make it to the phase 3 and registration, then all of us know that we are going to fail on achieving that global goal. So please help us and clarify that. And the other question for you was, which of those candidates is most likely to give us good results by 2030 or 2035? Thank you.
Thank you.
Hello. Thank you, Chair. My name is Lucy Asege, and I'm working with Walimu. My question goes to Dr. Ann. You spoke about the BCG vaccines, and maybe this cuts across the vaccines if you look at also the COVID vaccine. One thing about BCG vaccine, it does not prevent actually primary infection, and more importantly, it doesn't prevent also reactivation of latent pulmonary TB. So are there any steps that have been taken to bridge this challenge so that we know the next vaccine that we are receiving is actually more efficient than what we've been having all throughout? And also, if I remember the presentation by Dr. Zirimaya, she talked about like some vaccines may not actually work for certain populations. So does it, during this manufacturing, can that be put into place to test these vaccines in different populations so that we have an efficient, effective vaccine to use? Thank you. I submit.
Thank you. That was Professor Allison, actually. Yes, next.
There was a hand right there, and online, so far there are no questions, but if they come in, we shall pass them on. Okay.
Thank you, Chair. My question is a bit, it's to the MRC team and vaccines. What does it take, or what will it take for Uganda to participate in these vaccine trials, if there are any? And two, what do we need to do to prepare ourselves to receive the vaccines? Are there any steps that we need to start talking about, taking on? Because from the COVID vaccine, we got some bit of challenges in acceptance of the COVID vaccine. So if we are to prepare ourselves for the TB vaccine, which is, I believe and hope is going to be the change maker in ending TB, what is it going to take for a country like Uganda to prepare to be ready to receive it? Thank you.
Thank you.
Thank you.
Please,
I think.
Can you take some questions?
Thank you very much for this opportunity. My question goes to Diana Sitenda. You highlighted that all the mothers had low HB, and is there any connection to the heightened IL-17 responses? Because these two tend to go hand in hand. And how did you control, or did it have any effect to your results? Thank you.
Yeah. Please introduce yourself
sorry.
as you ask the questions so that they can be answered appropriately.
Sorry, my name is Justine Nachwala from Mount May, Uganda. Thank you.
Thank you.
Okay, thank you. My name is Alphonse Kwizera, and I am from the USAID Local Partner Health Services Ankole and Acholi activity. Yes, the discussion around PTLD has been very interesting, and it has intrigued me somehow, and I wanted to inquire from Jeff and Mudashiru, what cohorts, if I wanted to look at my TB survivors in the Ankole region, what cohorts would you recommend that I look at? In other words, I mean, how long ago should someone have completed treatment for TB and declared cured that we can look at for possible symptoms of PTLD? Thank you.
Thank you very much. Dr. Henry Luze from the TB program. This goes to Dr. Waja. I think that's very good to know what's in pipeline as far as the vaccine for TB is concerned. And I was so much impressed to see that the number of types of categories of the vaccine, the pre-exposure, I think post-exposure, and then post-treatment, something like that. So my question would be whether there are considerations for booster doses. If, for instance, you give a pre-exposure dose or vaccine, and we know that there is a possibility of that would be like BCG in the circumstances, but we know that still, even with the pre-exposure, you can still go and develop TB. So is there a possibility of judging somewhere along the way a booster dose post-exposure, and what do we think would be the appropriate time for that intervention of the post-exposure? Thank you.
Yeah, please let Professor Koma ask, and then we can take that batch.
We have about 6 more audience members who want to ask questions, so just to seek your guidance, should we get all the 6 that are up right now?
Let him ask, and then respond first. If we have time, then we can take the next batch.
Thank you, Chair. Because I am not professor, first of all. My first question is to you, Chair, actually, that since this is a science summit, it is bringing out the wisdom of the Ministry of Health combining TB with leprosy. Chair, I hope maybe I will know from you if the scientists have looked at this wisdom at all. This was conceived more than 20 years ago. Is it still worthwhile keeping TB and leprosy in the same docket? Going from there, then I have my questions with this bias to the team from MRC. Professor Ellison or Dr. Waja, whoever would like to respond. MRC is the owner of the science behind BCG and leprosy in Uganda. Yeah? That it surprised the world, that it had a beneficial effect, and they showed even years later that that effect had continued more than 10, 12 years later after the first trial. I wonder what the situation is now. My other one is going to the person who was, sorry, I won't remember your names, talking about TB lung disease. There have been presentations about TB lung disease and all these initiatives. I'm still waiting to hear in more clear terms the engagement of the coming organizations of TB survivors in all these initiatives. There are organizations of TB survivors. And for those organizations hearing this mortality rate, I wonder whether they should even call themselves survivors. Thank you, Chair.
Thank you very much. I think we'll pause and respond to those questions. We could probably start from the extreme end and proceed in this direction.
Thank you, Chair. Someone asked about whether there was any connection of IL-17A to the low HB concentrations that we found. Just to re-echo, the low HB concentrations were found in mothers that had TB. And also on performing the sub-analysis, where we wanted to find whether there is an association of HB and IL-17A, we did not find any association there. And so I do not think that two really influenced each other in any way. Yeah, thank you.
Thank you. Yeah, thank you so much for the lot of interest in the TB vaccine world. We are learning. It's been many years, but I'll start with Robert's questions about the fact that 10 years ago we were here and things are not any better. I wish, Robert, you could just go back and look at some of the presentations that were made then. You'll see that there's significant progress. It's not been as fast as probably would have wanted, but mostly because of funding, because of seeing that TB is not lucrative. So it's very hard to attract funding to TB. So that has been a challenge. But in terms of the candidates, there's definitely been improvement in terms of the number of candidates. Even in the later phases of the trials, you've asked about which one we think has the most promise. I think it's very hard for me to tell which one it has the most promise because we have to wait for results. But what I know is that there are some which are in later phases, like VPM 1002. I think it's already, the trial is almost, I think, 3 years in. We have M72 just starting this year. We have MTBVAC, which is also planning to start later this year. So we have to wait. And also, if you looked at this pipeline last year, you'll find that there are some vaccines which fell off. So because of the challenges, so as you're doing the results, you do an interim analysis and you find that vaccine that you thought was going to do very well, I think the biggest shock was with the MVA-85A, which everybody thought at the time, I think 10 or so years ago, that this was going to be the magic bullet. And then the big trial in South Africa, and there was no efficacy. It was not, there wasn't anything that, we didn't meet our expectations in the TB vaccine world. So actually, that particular vaccine was now moved to be combined with one of the vaccines I talked about, ChAdOx, MVA-85, one of the regimens which we as actually a team at MRC have been working with from the University of Oxford, where we have that MVA-85, which was quite good, which was combined with another vaccine as a regimen. So ChAdOx, a viral vector vaccine with a chimpanzee adenovirus being combined with the MVA-85. And that regimen, from the work that we did, shows that it was actually a lot better. It gives better responses. So I think we cannot, we're not where we should be, but I think we are a lot better than where we are. And maybe we should also compare ourselves with the HIV field, which has been looking for a vaccine. And right now, HIV doesn't even have any trial that's active. So this whole, there are many reasons why we are where we are. It's the science of the disease itself, and also the vaccines that we've seen that has worked. We are discovering new things about BCG as we continue to do basic science. So we will continue looking for those things which work. But I think we are better than where we were years back. So we have more candidates. We now have the RNA virus vaccines which have entered the pipeline for the first time. Hopefully, they've just in phase 1, but hopefully we'll be able to get results coming out of those quite soon. We also have more innovative ways of how things are going to be done. For example, looking at the controlled human infection models, because I think the TB world agrees that it's not useful to take ahead too many vaccines into the larger phases of the trials. So because it's expensive to run these large trials. And so there has to be a consensus as to which vaccine they'll go with to the next stage. So when we have innovative methods like using a controlled human infection model, which can quickly tell whether a vaccine is actually efficacious, using smaller numbers and being really quick follow-up, then we'll be able to decide on which vaccine to move ahead with. But the TB vaccine world is still scratching their heads, but they're not sleeping, they're working. And I think there's more work that's going on and a lot of progress in the field. There was a question about why the different age groups, the adolescents and adults, because we know that when we're vaccinating different groups of people, we find them in different places. So when we do vaccines for adolescents, we'll expect to probably do school-based programs, school-based vaccinations. And adults are not normally vaccinated. So we have to look at those different groups separately. But as I showed in the graph, the reason why they are important populations is that the incidence of BCG and the incidence rate of TB starts going up around adolescents. And then adults, of course we have HIV coming into the picture and affecting how things work. So we really need to have those differences, looking at neonates and infants differently, looking at adolescents and adults, because we're also going to use different ways of finding how to give them vaccines. And then also their immune system also is different. So we have to look at those different populations. I think there was a question from Lucy about primary infections, and I think that's what I talked about. That's why we have to have different vaccines working at different points in the whole spectrum of the TB disease. So we're looking at vaccines which are trying to prevent infection, preventing primary infection, and that would be the most efficacious vaccine because it would be impacting a bigger group of people because there are more people. If we prevent infection, then we'll really have a big public health impact. So then we have the vaccines which prevent disease, progression to disease, and then vaccines which which improve treatment outcomes or prevent recurrence. So that's why all the vaccines are distributed that way. And you find that some of the regimens are maybe affecting different aspects. There may be a combination of prevention of infection and also prevention of disease. Then there was a question about what will it take from Dr. Raymond about what will it take to Uganda to participate. I thought that was a clear sign that we are actually participating. As I showed you on the pipeline, there are about 5 different trials that as a site we have been involved with. And it's not just MRC. I know there's a team at Makerere University School of Public Health who are also participating in some of these vaccine trials. I know VPM is one of theirs, one of the ones we participate together with our team from Makerere. Many years ago when I was at IDI, we were part of the vaccine preparedness trials which were funded at that time by EDCTP and ERAS. And I believe there was the lab at Dr. Sengoba leads here in Mulago was one of the fruits of that collaboration. We set up cohort studies that we did in Iganga in the demographic surveillance site. Maybe it wasn't the right site to do that, which is why I mentioned that NTLP would be helpful in providing good data and saying, okay, these are the sites where we should go to do the vaccine trials, because we know that the TB incidence in there, we know the different things about the epidemiology in those areas. So yes, we are already participating, and what I was calling on NTLP to continue supporting us, and we continue to be on the lookout, because the TB vaccine world is small, but it's also big, so many people are invited to join the team. And the preparatory studies, at that time, what we did, we were doing cohort studies to determine TB incidence in adolescents, in infants, and then there was also capacity building where there was a lot of training. I think many of us were trained through that program. We also had setting up various labs in the districts where we were working were actually improved. And of course the TB lab which was set up was also one of the big outcomes of that project. But we'll definitely need more work. Community sensitization, we need to prepare communities. How would they want a TB vaccine to be? Would they take it? Would adults be willing to be vaccinated against TB? So all those are questions which we need to prepare. And I was very encouraged when Professor Jolova yesterday talked about PRISM TB and mentioned that there's actually one area for vaccine preparedness. Though I was a little taken aback when I saw that in the NTLP plan, there was nothing to do with vaccines. So maybe we could also add that to some of the priorities for NTLP, vaccine preparedness. There was a question about booster doses. I think Dr. Luze, yes, most of these vaccine regimens are actually boosters for BCG. Because, as we said, BCG works in infants. So everyone will still continue to get BCG. And then probably do what? Have a booster later. And most of them are during adolescence, which is when the BCG effect starts to wane. And so that's probably the stage when some of these will be boosted. For example, MVA85 is initially set up as a booster. We gave BCG at birth, and then in adolescence, then they would get I believe 2 years, they would get the booster doses. So yes, that's really the plan that's being done, combining different vaccines, different platforms, putting more than one antigen. I know that MVA85 right now, the creator, Professor Helen McShane at the University of Oxford is working on adding, I think, 5 different antigens into that, so that to see if it's better. So the TB world is going on. And I think I'll let Professor Allison answer that question about the BCG story from MRC. Thank you.
Thank you very much, Anne. Very comprehensive, so I have not much to add. I would like to just comment on the issue of how people responded on vaccines in the COVID pandemic. Because I think the challenge of whether people will take up vaccines if we have them is quite broad, especially for people who are used to the vaccines for babies, but vaccines like the HPV vaccine, the COVID vaccine, the Ebola vaccine, these new ones or ones that come in at different ages, people have a lot of concerns about them. So I think it needs a concerted effort by all the stakeholders to try and make sure that people understand properly what vaccines really do, and also to consistently address the conspiracy theories and the sort of social media pressure of incorrect information, which is not specific to TB vaccines. One area maybe we can also think about is I think there was also a feeling that these vaccines came from outside Africa, and how did they suddenly, actually in contrast to the first question, how did we suddenly get all these COVID vaccines, whereas despite decades of work we haven't got an HIV or well, now we have a malaria vaccine, but we haven't got a TB vaccine or an HIV vaccine. So I think the presidential initiative to start developing vaccines in Uganda is a very positive thing, and to try and then even if vaccines come from outside Uganda, to tell people the stories about the work we do in Uganda, to test them to see if they work here. I think that's a very important contribution. So on the issue of MRC as the owner of the science, it's certainly the UK Medical Research Council certainly does have a very special historical record, both in the development of BCG and the trials that tested it, and also in the development of TB treatment. And Uganda was a big contributor to that. But I think the vaccine trial that you mentioned with 80% protection was in the UK. And and then subsequent vaccine trials showed different efficacy in different places. And what we really need is a vaccine that works in the places where the TB pandemic is still still a huge problem. So that's what we're working to with the new studies.
Thank you. I did have one question too from Dr. Kauma, whether TB and leprosy should still be in the same consort. I think so, because I know you have the expertise in leprosy. That should be, you should be more informed. But these are all mycobacterial diseases. Mostly, they are only diseases which are called, where the treatment is called short course, and you are treating them for 6 months. You are treating with many drugs, and they uniquely interact with the immune system. I may be wrong, but I would be keen to know your opinion. Let me pass on to the next.
Yes, thank you all for the questions. It's good that the interest in post-TB lung disease, as Professor Allison and group are trying to prevent both infection but also disease through vaccination. We're also trying to see among those that get out of that basket, what can we do about them because of the high mortality. Ms. Alfonso asked what cohorts could they target. We are recommending that immediately after discharge, after someone is discharged following TB completion, please, you need to assess for post-TB lung disease symptoms there and then. The results that I've presented have shown that at 6 months following treatment, at this month, 6 months or at discharge, over 30% of patients had post-TB lung disease, and over 57% had fibrosis. That means that at the discharge, you need to continue. Let PTLD be a TB continuum. Let there TB continuum from TB cure to completion to PTLD care. The other question from Mr. Patrick Azoba from Reach Out to Mbuya asked how could we provide insights surrounding the high mortality rate attributable to PTLD in Karamoja and the high prevalence of PTLD in Kampala South, Central, and Bunyolo. I think one of the things that I highlighted in our presentation is that we need to understand the risk factors more, the drivers of PTLD, but also I presented that diagnosis, by the time our patients come to be diagnosed, their lung, they already have lung impairment due to delayed all the time they take to seek care at diagnosis. And this worsens along the way during treatment. And this was a good risk factor for PTLD at completion of treatment all cure. So that means that majority of people in Karamoja, despite recent efforts from different partners, mainly IDI in that region, still a proportion of people delay to come for care, to be diagnosed, and also the adherence to treatment is still a challenge despite recent improvements. This is the same with the Kampala South and Bunyolo, but also there are other confounding factors. Biomass smoke causing COPD, could have air pollution. We see in Kampala Central, we have a lot of dust and all of that. These all disrupt functional lung health. So there is an issue here. The issue of post-TB patient care remains a challenge, particularly regarding tracing mechanisms. What measures can be implemented to address this gap? This is from Fred Ebila Fellowship of TB Survivors. I think what we are recommending in this pilot project on the scalability, the feasibility, and acceptability of PTLD care as a package following TB completion. We are trying to see that we engage different stakeholders. We are at the beginning, I can tell you. We've just started at the beginning of this year, and with the time we are going to provide the results on what we can do to make sure that as we catch these that are discharged, that are being discharged, and we enroll them to PTLD care, mainly those with PTLD symptoms, How about these that completed long time ago and are in the villages or communities languishing with a problem? We know if you come at our inpatient departments and outpatient departments, we need to refer these to more care with our physicians. And one of the things we're going to be doing with the support of the different partners is to train healthcare workers at regional referral hospitals, but as well as work on a cascade of PTLD care capacity down to the health center 3.
Okay, I will just take one question. The others have been answered. So the question from Dr. Kauma is, how are we engaging the TB survivors because of what we have seen? Yeah, so I can say that as the program, we have already started mapping out, attracting the academia. I think last week there was a meeting concerning what is the strategic direction towards post-TB lung disease care. So MLI is supporting to ensure they map out all stakeholders, engage the stakeholders, and also utilize and see how we can use the surveillance data to inform where the burden lies. I think every month nationally we share out the burden, which health facility has reported a patient on PTLD, how many deaths have occurred from each facility for each region and each district. So efforts are still ongoing from the programmatic side, but in the short run, we have a strong community component. They are doing advocacy, there is awareness, we are engaging CSOs, and in this meeting, we also have a TB survivor representation here. So quite a lot is ongoing, still learning about PTLD, but we'll get there. Thank you.
Thank you. Before we come to the end of this session, we have one last question from Martin, and I've been co-opted by the post-TB lung group to get involved. The question says, he got cured of TB in 2018 and then recently got an accident. An X-ray was done and one of the doctors commented that one lung has shrunken. The question is, can one live on one lung and for how long? What should I do to reverse the condition? So I think it's in the docket of post-TB lung disease, and we do know there are several people who live on one lung. However, we know there are other complications that follow TB, and there's no single answer one can give, but I think I would like to encourage you to be optimistic, because there are even several very high-profile people who live on one lung since childhood, so it is possible. So join me, please, to thank the panel for a very exciting session and the audience for your insightful questions. Thank you very much. We come to the end of this session.
Thank you. Thank you for this very exciting session. We should probably have given you more time because it looks like the whole audience was still full of questions. But please join the panelists for lunch or for a break and ask your questions. Panelists, we also have questions online. I would please ask you to come and engage the online audience. You can type answers to them. And these questions are specifically to Geoffrey and Mudashiru. So please spare some time and come and type answers into the chat because there are some questions for you on the chat. Thank you. Thank you so much. So the next session is Lab Diagnostics and Imaging. Our chair is Dr. Richard Katuramu from Busitema University, Faculty of Medicine, and our co-chair is Dr. Willie Sengoba from Makerere University. Please, over to you. Thank you very much.
Yes, good afternoon to you all. Welcome to this interesting session. As we know that the diagnostics have always been a challenge in TB, but there has been a lot of improvement in the current research, as we're going to hear from these researchers. Once again, I'm Dr. Richard Katuram. I'm a physician working in Mbale Regional Referral Hospital and affiliated to Busitema University. Let me give a chance to my colleague to also introduce himself.
Welcome to this session. As introduced, I'm Willie Sengova from Makerere University. I'm a diagnostics expert with more than 17 years in TB lab work. And it very much, it is a pleasure co-chairing this session, because it's the field which I understand best, where we are, where we have been, and where we are planning to go. So you are welcome to this session. Can I invite with permission from my chair, I would like to invite the presenters. I will start with Dr. Andama Alfred. Please come and take the seat. Ms. Lucy Asege from Walimu, Okot Amos, Peter Kitonsa. We'll listen from Dr. Aldo Brewer, and we'll also listen from Mona Muhammad, and we have one presenter replacing George Kasure, Kakanyero John Paul.
Thank you, my co-chair. Let's wait as our presenters take their seats. I think it has been in a practice that presentation is 6 minutes. We have 7 presentations, so 6 minutes, that's almost close to 40 minutes. And I ask all the presenters to keep time. Without wasting time, I think all the presenters are on there. Thank you, Chairperson of Organizing Committee. I've been advised that we allow the first person to take 15 minutes because it's going to be an overview of the current and future landscape of TB diagnostics. Andama Alfred, please take the floor. You can introduce yourself first so that as you go to the podium.
Good morning or good afternoon. My name is Alfred Andama. I'm from the College of Health Sciences and work in TB diagnostics. So my talk this morning is about TB diagnostic pipeline, and I'm going to talk briefly about the current status and future landscape. Right. We all know the COVID pandemic disrupted a lot of TB work. In fact, during that time, when we were doing our activities on TB diagnostics, the prevalence within Kampala looked a little high. And we realized that actually that was possibly because of the lockdown and also patients being unable to go to the hospital because of transport challenges and all that. But we also know that TB is curable, is preventable, but the biggest gap is in the diagnostics. So in this talk, I'm going to give a highlight on the current status of TB diagnostics. I will emphasize more about the oral swab testing, a principle that aims at having many more people to get to the test such that we have an incremental yield. What we also know is that despite the fact that there are a lot of TB diagnostics around the country or in clinical care, there has not been any single one that is sputum-free and that is deployable at the lowest health center facility level. But however, as you will see as we go into what are in the pipeline and what are being evaluated, there's hope that something comes out in the long run. So generally, the most recent Treatment Action Group recommendation categorized diagnostics into TB diagnostics into 4. These include tests that are considered screening, then those that are diagnosis, those that need that are used for monitoring treatment and disease progression, and finally those that test active infection. So among the screening tests, we have the chest X-ray with the computer-aided detection. We have, for people living with HIV, we have those rapid molecular tests, including CRP that was also recommended by WHO. Then there's a point-of-care ultrasound that has mainly been used in children in some settings. Then there are a couple of artificial intelligence-based diagnostics that are also, some of them have been recommended. Others, a couple of them are still under evaluation, including here in Kampala. So just to go back to what we have currently in this country. We're still with the smear microscopy, where a microscopy was developed a couple of centuries back. We know its performance, we know its cost, and we know how we have been able to roll it out as a program of national TB. If you moved around the country, you'll find that at least every center that has a lab has a microscope, and the method that they use is the Zell-Nielsen. We know also for those immune suppressed, previously there was the Aliyah lamb, urine lamb. And WHO had restrictions on how to use it. But the good news is that now there's a new, that was the Aliyah lamb, but now there's Abbott, which has a better performance, and the cost is more or less similar, and it is able to detect TB regardless of HIV status, although it might not be really available on the market, especially in our market right now. We still have the GeneXpert, which has really done tremendous work in the countryside, even in Kampala, in urban settings as well. It detects up to at least 70% of TB. We know the initial cost of the instrument is high. Even the cost per test is still high. I think they've reduced to about like 7. Last year in November in Paris, there was an announcement that they were reducing. I think it should be around $7 now. But the challenge is that it requires, steady electricity. You need some kind of setup infrastructure in order to support it. Of course, the gold standard has remained the liquid culture, or the culture for that matter. Although we know the delays in producing results, definite results, we know the cost of testing TB by culture is somehow prohibitive, more so to the ordinary person. I think most tests that are done probably in the Willis lab are done by the research teams. Recently, in India, there's MolBio that produced the TrueNut platform, which are still being somehow evaluated in some protocol modifications. They are relatively cheaper compared to Expert. They use smaller volume of sample, and generally the instrumentation is friendly, especially if you have limited bench space. But since 2020, when WHO endorsed it, the rollout has still been a little slow. So this brings me to tank swab testing. For several years now, we have been working on tank swab testing. We started by demonstrating that people who have TB actually carry over live mycobacteria that is able to grow on culture media. And we picked this initially after the patients had produced sputum. But later on, we decided to reverse. We picked samples before the patients produced sputum. Either way, there was a difference in the detection of about 10%. After sputum was about 72, then before sputum reduced by about 10%. Now, the question has remained that if we can make sure everybody gives us the sample, will that increase detection? So we are not talking about accuracy, we are talking about yield. So if we had 10 people, all of them gave us they gave us tank swab, and we detect, say, about 8 of them. But those who produce sputum were probably about 7, and were able to detect only 5 of them. So the difference in percentage might look similar, but in terms of actual numbers, we think tank swab will be more appropriate. Therefore, in last year's treatment action group, they cautioned about restricting or thinking more about accurate studies than incremental yield. So, in order to prove how this would work, like I mentioned, we started these earlier studies trying to demonstrate that actually we can pick TB from the tank swabs. We did this among people living with HIV, people who had confirmed TB using Expert, and also those who were confirmed, but we did not. In terms of age, we were mainly recruiting the adults. And we did this from Mulago Hospital, a TB ward, and Kisenyi Health Center 4. We have a lab in the Mulago pharmacology lab where we have been doing all this work. So what we found was that there was a high concordance between tank swabs that were processed for TB testing. We were using 2 methods, the GeneXpert, and we're also using the MolBio. So the 2 tank swab and sputum on Expert Ultra and MolBio compared so highly. The other thing we also observed was that, as we know, Expert Ultra usually gives semi-quantitative grading from high to trace. So as you go down the grading, the performance of tank swab also reduces. We also went ahead to compare to, there are so many swabs on the market. Initially, there was a publication that the Copan swab performed better than the Steripack. So we wanted to confirm that if that's still true. We found that there was no difference between these 2 swabs. We didn't compare others, but these 2 which are common on the market did not have any difference. The other thing we did, like I mentioned, was to see the difference in the yield depending on what Expert on sputum produces. Still, the trend was the same. For higher, swab detected higher, and where it was very low in sputum, still sometimes we were not even able to pick it. Then the other thing we also did was to see, since we are talking about swab and transportation and processing conditions, was to see if we did swabbing in the field, far away from the testing facility, how stable would it be? So we did this over a week, and we got some of the samples, put them in a dry tube, others were put in a buffer, and delayed the processing for over time, and still tested. And we found that actually carrying the dry swab to the lab did not affect the yield. And so we are saying that, you know, even if the patients are far away from the testing lab, you can still collect a sample, keep it safe, transport it. It can still yield the amount of TB that is present in there. One of the processes that we did for TB testing, we needed to establish a reference standard. And in doing so, we looked at some quantitative PCR method that is in-house built at GHL, Global Health Labs. And this, we needed to modify the processing method by trying to agitate and lyse the mycobacteria by mechanical means, either by shaking. You know, lab techs would hold the tube and shake, or there are some bead beaters that then there was heating, and there was where we didn't have any action at all. So we found that bead beating or rupture by any mechanical means yielded much more than heating and no action at all. So this picture shows exactly the processes that we did in the lab: collect the swab, put it in the buffer, and what we realized here after testing this, there were a couple of errors that we noticed, especially with the GeneXpert. And these errors were maybe you can see it in the next slide. Yeah, error 208. And this error seems to be due to pressure within the cartridge that exceeds what is allowed. So, although there were variations across sites, there are now modifications to see how we can adapt since we want to use the existing platform. Maybe what I want to say that even the GeneXpert itself was initially primed to test sputum. So these are the innovations of other specimens, just trying to see if it can pick. But now, we think if you modified the processing, especially the ratio of the sample reagent, add some saline buffer in some agreed volumes, you are able to reduce actually on that error. Those are some of the experiments we are doing at the moment. Now, I took time to look into what is actually in that pipeline of diagnostics. AI is real. Actually, right now, we are trying to do some work with guys from computing in Makerere to see how we can leverage the existing microscopes. We have realized that, we have known that most of the labs in Uganda under National TB program have the Olympus microscope. They have some standards, especially in the objectives, in the eyepieces. So we have worked together to develop an application which we attach, we load on a smartphone, attach to an adapter, and load that adapter onto the eyepiece of the microscope. Then you start on the application. It's able to scan and display. Unfortunately, I didn't bring that to demonstrate here. We are doing a couple of infectious diseases, including malaria. And maybe in the next meeting like this, we'll be able to show some results, which we're going to collect from the countryside. So we got like, according to the categories that I showed at the beginning, there are several, like you can see highlighted red. These are different diagnostic kits that have been developed. Now they're under evaluation. So as we think through how future of TB diagnosis will be, there's a lot that's being evaluated. In Kampala alone, as far as I know, in the lab where we work, the Rapid Research for Diagnostic Development, we have close to 10 of those kinds of instruments that we're evaluating for TB. And I'm sure many of you who are working in the TB world should be having others. And so the future looks bright in terms of diagnostics, But on the other side, if you look to the far right, we have those diagnostics under development. You can hardly see anything there. So supposing all these others HIF evaluation fail, we go back to the drawing board. So it calls for innovation, deep thinking, and see how new ideas can come onto the table to ensure we have a series of diagnostics in the pipeline. So therefore, I conclude that there are several TB diagnoses, as you might have seen just a few moments ago, majority still being evaluated. And we need to expand this evaluation to include the different groups. Somebody talked here about adolescents and children. So we need to have all these considered as we think about diagnostics development. And trunk swabs are promising. They are safe. Anybody can give you a trunk swab, unlike other specimens, less painful. And we think if we go that direction and optimize some of the diagnostics using trunk swab, we should be able to address and increase detection. And all these you saw on the previous slide where different devices are being evaluated. These are derivatives from the COVID-19 attempts. If you go back and check, all the tests that we have right now are in that kind of category. I thank you so much for listening. I wait to hear from you when the right time comes. Thank you.
Thank you, Dr. Andama, for that interesting presentation. I know we're going to listen to other samples for testing TB, but that's quite a good innovation. So our next presenter, Lucy Asege from Walimu. She's going to be talking about continuous cough monitoring with an AI-enabled mobile phone app for TB evaluation and treatment response. Please take the podium.
Thank you, Chair. Once again, Lucy Asege is my name, and I'm working with Walimu. I'm here to take us through our study that was on continuous cough monitoring with an artificial intelligence-enabled mobile phone app for TB evaluation and treatment response. Okay, cough is a symptom of TB, a key symptom of TB and other respiratory diseases. But we also know that cough evolves throughout TB treatment. You're going to find that when cough reduces or increases with these participants, it's presumed that either the patient is responding to treatment or the patient is not responding to treatment. But until recently, you'll find that cough data has always been collected through and limited to soft response, whereby the doctors, the health workers have to rely on what the patient remembers. Either they are still coughing, how often they are coughing, and when they are coughing. But I'm happy to tell us today that we have a smartphone artificial intelligence enabled app that allows continuous quantitative cough monitoring and analysis. This app is able to quantify cough in minutes, in seconds, time, day, or night. And also the cough artificial intelligence could serve as a novel TB diagnostic and treatment response tool. We want to see if we can use cough actually to diagnose TB and tell this participant through their cough they have TB and the others do not have TB. Now, to answer the latter, we came up with two main objectives. That is to assess if changes in continuous cough patterns can distinguish people with TB versus those with other respiratory diseases, conditions. Then secondly, we also wanted to assess if cough patterns are associated with TB treatment response. To answer our objectives, we did a prospective cohort study where our study population were people with presumptive TB, assessing TB diagnostic evaluation at participating study sites. Our sample size was 565 participants. We worked with TB clinics participating in ARA2D2, TB network study at outpatient health centers in India, Philippines, South Africa, Uganda, and Vietnam. We collected cough from these participants for 14 days using the artificial enabled smartphone recording by Hive Research application. And we did our analysis whereby the cough frequencies were summarized as medium coughs per hour. We did categorize our participants into 3 categories. The first category was the confirmed TB participants. These were participants who were microbiologically confirmed with TB, and that was by GeneXpert, culture, or microscopy. These were 144 out of the 565 participants. Then the second group of participants were the clinical TB participants, and these were participants who were clinically confirmed for TB. This was done by chest X-ray and symptom history taking. Then the last group, those are participants, we categorize them as participants with other respiratory diseases. These were the majority. These participants had cough, but they didn't have underlying TB symptoms. Now, sorry about that. Now, if we look at our key findings, our graph here shows the medium coughs per hour and the days of recording, whereby ideally, if you look at the 3 sections, the red one, those are the confirmed TB microbiologically. The green one, those are the clinical TB participants. Then the blue line represents the participants with other respiratory diseases. Now, there is a unique cough frequency trajectory with participants who were confirmed with the TB, whereby this particular graph answers our objective, which was stating to assess if cough pattern can be associated with TB infection. You're going to find that at early treatment for these participants, there was a great decline in coughs, where the medium coughs pattern reduced drastically from day 2 up to day 6. And the largest decline occurred with people actually with confirmed TB, unlike the other 2 participants groups. So to continue with our results to answer our other objective, which is to assess if changes in cough pattern can distinguish people with TB versus those with other respiratory diseases. We are going to find that we looked at the medium coughs per hour and also the days. On day 1, we realized that people with microbiologically confirmed TB had a medium coughs per hour that was actually very high. All of them, the medium coughs per hour were around 8. Unlike those with clinical TB and other respiratory diseases. Then when we go to day 4, we realized that across all these groups, they had a significant reduction in medium coughs per hour. There was no significant difference between the reduction in all the groups. But then the key point take home was we're able to classify that the people with those with microbiologically confirmed TB had high medium coughs per hour at 8. So in conclusion, an AI-enabled smartphone was able to characterize distinct cough patterns, and also the cough patterns demonstrated treatment response in people with confirmed and clinical TB. For future work, we suggest an objective cough monitoring should be further assessed for TB evaluation and treatment response monitoring, and no time to quantify these coughs depending on the microbiological status of the patient. I would like to acknowledge all the parties that have been listed on this slide, and also thank my mentors who are present, Professor Orodia, Dr. Alfred Andama. Thank you so much for mentoring us and for enabling this to be a success. Thank you. I appreciate it.
Thank you, Lucy. Please take your seat, as probably we have questions for you. And thank you for keeping time. The next presenter, Okot Amos from KCL Kawala, is going to be presenting comparative evaluation of GeneXpert urine LAM and also conventional sputum test. Over to you.
Thank you very much for the warm introduction. My name is Amos Okot. I'm a laboratory scientist. I work with Kampala Capital City Authority as a laboratory technician attached to Kawala Health Center 4. I'm going to be presenting a study that I did there called Advancing TB Diagnosis, a comparative evaluation of GeneXpert urine, urine lamp, and conventional sputum testing. So maybe before we begin, just to bring people, put people in perspective, for example, how many people live in Africa today? Total number of population in Africa today. How many people? Well, excluding abortion, of course. 1.4 billion, around 1.4 billion. So in 2019, both the CDC and WHO reported that cumulative TB infection has already reached 1.5 billion infections by 2019. That's like the total population of Africa infected with TB. And then we're also seeing that 10 million infections happen every year, and then 1.5 million deaths, and 24% of the deaths are in children. And so this shows that the threat to TB is still real, and it requires a more precise diagnostic approach. Of recent, we have been seeing, as Dr. Adam was saying, breakthroughs in TB diagnosis, but gaps still persist in the pediatric drug-resistant TB diagnosis, TB HIV co-infection diagnosis, high burden region such as ours in screening. That's why for us we set to try to address this pressing need for to improve TB diagnosis. So our objective was to assess the three diagnostic methods, which is GeneXpert urine, TB lamp, and then GeneXpert sputum. And our study design was a prospective cohort approach where we enrolled 100 individuals across pediatric, adult, and geriatric population with TB suspicion. Where TB signs, we were talking of the night sweat, loss of weight, cough lasting more than 2 weeks, things like that. And then we also included the people who have just enrolled for treatment within 48 hours in the study, but we excluded ladies who are going through active mental flow and those whose clinical condition could not allow them to produce urine or produce blood-stained urine. Our method was simple. We recorded the signs, like I said, and then we administered the three diagnostic tests across all the different populations, and we analyzed the data in subgroups by age and the clinical manifestation and other clinical conditions. We evaluated and compared the three diagnostic methods, and our results are this one. We found that the sensitivity of GeneXpert urine was higher compared to all the other tests at 85.2, compared to urine lamp at 76.8, and GeneXpert sputum at 82.5. The specificity was a bit lower at 93.4 for GeneXpert urine testing, and the urine lamp was 91, and sputum GeneXpert was 96. But this still shows that the diagnostic parity of GeneXpert urine. The results were consistent across different HIV negative, HIV positive, and all the age bracket. The results were consistent, so it did not significantly impact the findings of the study. The children particularly showed high acceptance rates in producing the samples that prove that this study should be. So, what are the implications for the NTRLP, the Ministry of Health? We could validate these studies, enroll it across the country to begin benefiting our people, especially the children who are unable to produce sputum, those whose clinical condition compromises their respiratory tract and are unable to produce sputum. This test could work on them. We could also tailor this for screening initiative and reinforce surveillance in tracking TB system. we need to further this research so that, because now we have detected quantifiable amount of the RPGB gene in the urine, and we could now use that to produce a rapid test kit for testing TB in urine. This was me, I'm the one in the middle there. That one is Ronald, this one is Ruth, that's us there. So this was a self-funded study, but I would like to thank my research mentor, Dr. Yohana from Bar University, the medical and laboratory staff from Kampala Capital City Authority, and IDI, the KHP project that ended, TASO and KC Community Linkage team, participants for their valuable contribution, and the caregivers for helping us with the children. Thank you very much.
Thank you, Amos, for that interesting study. Can hand over to my co-chair to continue.
Thank you very much. We keep the speed, and the previous presenters have kept time. We welcome Dr. Kitonsa Peter to present to us performance evaluation of the Uganda National TB Program algorithm for diagnosis of childhood tuberculosis. Dr. Kitonsa, the floor is yours.
Thank you. Good afternoon, team. I'm Kitonsa Peter James, pediatrician, very enthusiastic about children. So I want to talk about tuberculosis in children. All of us, or some of us, have children. Just imagine your child has been on treatment for TB for the last 6 months, but later they tell you, actually, this wasn't TB, it's cancer. Or your child has been on treatment for cancer, and later they tell you, this was actually TB, you missed it. So it's what I want to talk about here today. Okay, so there are challenges in diagnosing tuberculosis in children, like we all know, yes? So the NTLP came up with a diagnostic algorithm to help, especially low-card physicians, and including us, to diagnose TB in children and to start them on treatment because of those challenges. And interestingly, the WHO updated its algorithm in 2022. But we've been using our NTLP algorithm since 2017. So we wondered, is it still doing the same? Why did the WHO improve its algorithm? So in this study, we sought to evaluate the performance of our algorithm, compare it to the WHO algorithm, but using the NIH consensus definition as a reference, and we'll see why. So what we did is we secondarily analyzed data for 4 years. This is under the End Childhood TB study. So in the End Childhood TB study, they screen children from 0 to 8 years. 0 to 14 years is located in Mulago. For pulmonary TB, so physical examination, they do chest x-ray, tuberculin skin testing, all those tests, and also test for sputum. So sputum is got by those who can expectorate, by induction, by nasopharyngeal aspiration, but also gastric aspiration. So you can see all these are invasive for our children. So here we calculated the TB treatment decision basing on the NTLP and WHO algorithm with or without chest x-ray, and determined their performance or accuracy, sensitivity, specificity. And these were the results. In summary, we enrolled 875 children were included in this analysis. Majority were less than 5 years, and they were male, and they had a history of TB contact. So in the findings, to summarize the findings, is we considered 3 scenarios. We considered our Ugandan scenario, for example, in settings where you have expert and chest x-ray, or in scenarios where you have chest x-ray but no expert, and in scenarios where you don't have either of them. But we saw that our NTLP algorithm, its performance was similar to the WHO and it actually remained stable without expert. However, the WHO performance declined when expert was taken away. But on the whole, both algorithms' specificity was low. So the implications of this are that we are either overdiagnosing TB in children when we use these algorithms. And the take home for us here today is to improve the algorithm. We have already started on that, and we shall present that data maybe in the next meeting on how we can improve this algorithm so that we don't over-diagnose TB in children. Thank you.
Thank you, Dr. Chitonsa. We have a change in the program. The next speaker is going to be Dr. Kakanyero. Please, Dr. Kakanyero, you are welcome from Yumbe, and he's going to present on contrasting the GeneXpert ultra results of stool and sputum samples among presumptive TB patients. Dr. Kakanyero, please take it away.
Good afternoon, everyone. I think, God willingly, I'll be a doctor. I'm a medical lab technician at the moment, working with the International Rescue Committee in Bidibidi Refugee Settlement and attached to Kolekolenga GeneXpert site. So for us, today we shall be presenting how we compared results from a stool sample and from a sputum sample in children in Kolekolenga GeneXpert site in Yumbe district. Sorry for that. So as we are quite aware, currently we are struggling so that we end TB by 2030 with the key goal of 95, 90, and 0 by 2035. And according to WHO in 2018, 69% of the children miss being diagnosed with TB. And in Uganda, currently, we have around 91,000 people that get infected with TB. And out of that, 2% are drug-resistant TB. And approximately 15% of the TB that we have in Uganda are with children below 14 years. Therefore, in 2021, Ministry of Health introduced for us a simple one-step stool processing method to diagnose TB in children. And our study was to compare the results, targeting negative results for GeneXpert, then the positive. The positive we are concentrating the quantity which is there in stool and the quantity which is there in sputum. Are they the same, or what is the differences? And we shall know today. Secondly, we also compared the rifampicin resistance status of the stool sample and of the sputum sample. Sorry for that. Then we use a cross-sectional study design and retrospective record reviews of the results obtained from both samples. We did this study, as I said earlier, at Kolekolenga GeneXpert site in Yumbe district. Kolekolenga is Center 3, and we were targeting children but below 14 years. And this study period was from April to December 2023. Now, what we did was we processed this sample from 90 children. We processed the stool sample and the sputum sample from one particular client using the GeneXpert technology. Then afterward, we collected the data and analyzed it using SPPS version 20, comparing the agreement and evaluations, looking at the negative results and the positive results. As I said earlier, positive results were looking at the quantity and the rifampicin status. Now, this is our key findings. Out of the 90 people we enrolled, 70 were negative, while 20 were positive. Now, out of the negative, we realized that all the 70 had the same results, both in sputum and in stool. Then on the quantity, we realized that there was higher quantity of MTB in sputum compared to the quantity in stool. Then sample that the results in sputum that are either low in quantity or trace tend to show a negative results in stool. And on the rifampicin status, we realized that stool and sputum have comparative rifampicin status results. However, when it is traced low or very low, it doesn't indicate the rifampicin status in stool. Now, our recommendations or what we require the Minister of Health to do is, number one, we need to roll out this simple one-step tool processing method to all the gene expert sites within the country so that we bring the point of care TB diagnosis closer to children. And as I talk right now, we got a rifampicin resistant in Nebi, that is in West Nile, using the stool, meaning it is working very, very well. That is undercast TB of this current situation. And then two, we also request that we integrate this simple one-step tool processing method in the new childhood TB management guideline in Uganda. And lastly, we recommend further research such that we assess the magnitude of transmission risk between stool and sputum sample, and also comparing MDR multi-drug resistance risk on stool and sputum sample. And I need to acknowledge the following. Okay, that is me. When we did this research in Kolokolenga Gene Expert site, with the help of IDI Koboko Field Office, they supported us. We did mentorships in all the gene expert sites within Yumbe. Yumbe has 4 gene expert sites. At the last part there, you see that one that was doing mentorship at Yumbe Health Center for, in order to ensure that the whole district uptake the use of SOS tool processing method. Then this side, before we started the study, we had a CME, and that is my supervisor doing it. And then I need to acknowledge IRC that I worked for, UNHCR and IGAD, those are our donors. Yumbe District Local Government, Ministry of Health, and IDI, not forgetting Umlata that I subscribe for. That is my association. Thank you so much.
Thank you, John Paul. Thank you for the good findings and actually emphasizing that stool is the best alternative currently to respiratory samples in childhood TB diagnosis. We move to the next presenter, Dr. Aldo Brewer. Dr. Aldo Brewer is going to present outcomes and lessons from programmatic implementation of chest X-ray plus CAD technology to improve TB case detection in Uganda. Dr. Aldo, you're welcome.
Yeah, thank you so much. Good afternoon to you all. Yeah, so I'm going to share with you. I'm glad the first speaker gave background to the diagnostic test. I was a bit worried that where does X-ray fit in this diagnostic system? Yeah, but it's a screening tool, and that's why I'm here to share our experience as the national program, how we have rolled out this tool to facilitate screening and diagnosis of tuberculosis. So I want to acknowledge the colleagues that have worked with on this work. So as a background to X-ray, we know that the WHO recommends systematic screening for tuberculosis in high burden settings, and Uganda is one of these settings. Normally, in the recommendation, they talk about screening using either symptoms or chest X-ray with the computer-assisted diagnosis or use of rapid molecular diagnostic tests. But for purpose of this presentation, I refer to the use of chest X-ray for screening and triage of tuberculosis. We also know that our current data for TB screening, which is mainly based on symptom screening, national data reported in our national system, shows suboptimal screening. We actually report about 3% presumption rate, and the I wanted to go back just there. Yeah, and the 0.5% diagnostic rate for tuberculosis if you look at our routine data. So we want to share our experience in use of chest X-ray to improve screening and tuberculosis case detection. So in our design, the Ministry of Health, through support from partners, and Global Fund as one of the partners mainly, procured portable digital X-ray equipment, which are fitted with the computer-assisted detection technology. This image is actually what I'm referring to. So this equipment were distributed in selected health facilities. At the moment, we have about 12 health facilities that have these systems there. And the healthcare workers were basically trained to use the equipment, and we actually targeted mainly the clinicians and the radiographers from these health facilities, but also the laboratory team. And we also mentored them on a diagnostic algorithm that to use to facilitate diagnosis. And all individuals that were diagnosed with TB, basing on confirmatory test, which is GeneXpert, were started on standard first-line treatment. It seems the version which was posted is the old one. That's why I'm a bit, I don't know if it's possible to find the session which I sent earlier. Okay, I'll keep talking. If it is possible to find the version that I sent, the updated one, I will be glad. Yeah, so these are the findings from the data from the current, over the 2 years of implementation in 2022 and 2023. We've screened up to about 20,000 individuals with chest X-ray. And out of these who are screened, about 3,000 have abnormal chest X-ray, which is about 17% of those who are screened. But normally, we collect samples from those who have abnormal chest X-ray and other individuals who are able to provide sputum sample, whether based on symptoms and other screening, because we still use symptoms as part of the evaluation of the people whom we are screening. So samples were collected from about 7,000 individuals. Now, the results show that about 632 were confirmed bacteriological with TB, and also about 620 were clinically diagnosed. These are based on abnormal chest X-ray with initial negative tests. So they're the ones who end up, whom the clinicians make a decision to treat based on chest X-ray abnormalities. The other thing I also wanted to share with you is that of those who were screened, about 9,000 had a documented risk factor for TB. And among those who are documented, the highest yield of TB was among the tobacco users. You can see it's about 15%, and then 12% among the HIV infected individuals, and then contacts and diabetic clients had about 7% rate, and then the refugees and prisoners had about 2%. So those are lessons for us to determine who to prioritize for screening purposes. So what are the implications for this work? We know that the presumption rate and yield of TB from X-ray screening is high. It's actually more than 10% compared to, I mean, it's 10 times more than what we see from symptom screening. So it is a superior tool, and really where it's available, we should be able to optimize its use for tuberculosis case detection. We also know that if we are to prioritize the populations for screening, because we know that we cannot screen everybody due to limited resources, then we should prioritize people with high risk for TB. And for this particular data set, tobacco users and people living with HIV have a higher diagnostic yield of TB from X-ray screening. And already we have started the process of updating our screening algorithm to prioritize these populations for X-ray screening. So we want to recommend for the National TB Program and the partners to scale up the use of for screening and computer-assisted detection, targeting the high-risk individuals to optimize TB case detection. So this action photo just try to communicate a message that the demand for services is high in our setting. Once people are mobilized, they will come to seek services. So these are people who had been mobilized for screening, and they come numbers. And the other second message I wanted to pass is that X-ray system facilitates screening all kinds of situations. You can imagine this lower picture is a screening done in a church premise. So it doesn't need we don't need the standard infrastructure to offer screening for tuberculosis. Yeah, so in a community where you find a convenient space, you can offer the service to the people in need. And also, this particular client was disabled, but was able to access screening service by adjusting the system to cope for that. Then the last picture also shows the distribution of the X-ray systems. The ones which are highlighted yellow are the facilities where these systems are. There is some coverage in the country, so we want to encourage our partners and our district local governments to support the uptake of these systems to facilitate case detection. I will end here. I would like to thank you all, and also want to acknowledge the different partners who supported this, starting from the Ministry of Health, the Global Fund, Stop TB Partnership, and all the other partners listed here. I end here. Thank you.
Thank you, Dr. Aldo. Thank you for keeping time and for the interesting presentation. Our last oral presentation is from Mona. Mona is going to present 15,000 samples in less than 7 days, laboratory experience and strategies during the CAST campaign in Kampala Metropolitan, Uganda. Mona, you are welcome.
Thank you so much, Chair. Good afternoon, ladies and gentlemen. My name is Mona Muhammad, and I work with the USAID Local Partner Health Services TB activity as a laboratory specialist. Today, I will be sharing with you our lessons that we learned, the different laboratory experiences that we had, and the different strategies that we've been implementing over the CAST campaign period. CAST campaign is a campaign that happens biannually, and it is championed by the National TB and Leprosy Program. During the CAST campaign, it aims at community awareness, screening, sensitization, treatment, and prevention of TB, so that we identify the missing TB cases in our communities. And this campaign leverages the available resources. So we use that usual equipment that we have in our health facilities, as well as the health workers that we have available. So in March 2022, when we implemented the CAST campaign, USAID LPHS supports this campaign's implementation in 3 districts directly. That is Kampala, Mukono, and Wakiso, which constitute the metropolitan area. So during that time, we learned a few lessons. We had an influx of samples, and we had laboratories that were quite overwhelmed with these samples. Then, in addition to that, we had about 12% of our samples being rejected, and a very long turnaround time. Now, in the subsequent CAST campaign in September 2022, we didn't want to succumb to the same problems, and we had to re-strategize. We had to plan prior to the CAST campaign. We engaged the different stakeholders. while prioritizing sample management. And from these, we had activities that we agreed upon that were categorized as those to be implemented before, during, and after the TB CAST campaign. So during the campaign, So before the campaign, like I said, we engaged the different stakeholders, and this enabled us to pool resources. We pooled resources that could support us to optimize our hub system. For example, we had additional backup riders that were engaged. We had facilitation of health workers to do 24-hour sample runs, and very many other resources. Now, in addition to that, the stakeholders included the district teams, the district local government, and these ones are very crucial because they helped us to actually commit personnel at the sites and delegate them roles towards the CAST campaign. Then we also managed to do capacity building activities for our VHTs and health workers in regards to sample collection, the kind of quality of samples required, and the documentation to accompany it. We also went ahead in the 3 districts to look at our logistics. We took an inventory, and where needed, we redistributed to replenish the facilities that had less. We went ahead and also engaged the engineers from Karoga by then to come and service and maintain our machines ahead of the campaign so that they would be efficient. Now, during the campaign, we ensured that we had daily coordination and updates. And these persons from the laboratories had to report every day directly on the challenges and what their experiences were. And this guided the following day what we were going to do, whether we had to distribute the samples or they needed some more supplies. We also went ahead and optimized our hub system. We designed a small sample tracking log that enabled us to be accountable and know how many samples are being generated and how many results are being returned back. We went ahead and also implemented the flexi hour testing, that is 24 hours of operation of our machines. And after that, at the end of the campaign, we reviewed this process and we documented further the lessons that we learned, and we encouraged the documentation in the different HMIS tools. Now, what happened was, by the end of September 2022, CAST campaign, we had generated about 15,000 samples. And these were processed at 32 GeneXpert sites with 134 modules. And realized if we had maintained our status quo, it would have taken us about 29 days to process this volume of samples across the districts. We had a reduction in rejection rates to about 1.4% across, and the CAST campaign yielded 376 TB cases with 12 rifampicin-resistant cases. This showed us that it was actually possible to optimize our system. So what is the implication for this for the National TB and Leprosy Program? We see that WHO recommends us to handle our surge capacity. Number one, we need a boost. We need some more machines to be procured and installed in the different facilities that we have. Number two, in the subsequent campaigns, we could as well engage more stakeholders. I like that we have CAST Plus coming up, where we are having very many different implementing partners joining hands to do this, so that we can engage and pull as many resources as possible that prioritize sample management during this CAST campaign. Additionally, if we have CAST campaigns, we could actually optimize our systems to make sure that we use what we have available. Even though we do not have the machine capacity that we need, we can actually use what is available to handle this surge demand. In the picture there, you see the different teams at the facilities doing what I have explained. I would like to acknowledge the different authors, co-authors that supported this and the different institutions, my employers, the USAID and Infectious Diseases Institute, and the teams at large in the facilities. Thank you so much for listening to me. Please take 3 or 4.
Thank you, Mona, and thank you for the good presentation. There has been very, very positive findings and positive results around CAS-TB. And I think from the laboratory perspective, diagnostic perspective, we need to embrace the WHO-endorsed moderate and high complex platforms. For example, Roche has platforms and Abbott, which can process samples about 1,500 per day. You can have, at least the program can think through staggering these platforms in areas where they can be utilized during campaigns like CAS-TB. So thank you very much for that. And with permission from my chair, we are going to entertain questions, but I had some few questions to ask. One is for Kakanyero. Please note this. You said where the gene expert said low or very low, you had no rifampicin status. You need to clarify on that, because as far as I know, it is only a trace that doesn't give rifampicin status. But also thank you for showing that with this tool, actually you can increase the cases of diagnosing rifampicin resistance. Dr. Aldo, what happened to those individuals who could not cough, yet they had chest X-ray suggestive of TB? And what are the plans for the program to make sure that at least we get a bacteriological test done? I think, the one who presented about urine LAM and Gene Expert, what was your reference standard? Gene Expert urine and LAM testing. I think I leave the others in the interest of time. Thank you.
Thank you, my co-chair, for those burning questions. I've been advised by the organizer that we shall entertain only 3 questions, but we shall have to answer questions which have been asked on the what? On WhatsApp. So please, let's go ahead with the questions.
Yeah, thank you, Chair. We have a question from Dr. Fred Semitala going to Dr. Aldo. He says, thank you, Aldo, for the interesting piece of work to identify more TB cases in the community. What proportion of those diagnosed via chest X-ray abnormalities had sputum tests done, and what was the yield?
Okay, so let's entertain at least 3 questions so that we can be able to answer them at once. Please, the mic.
Good afternoon. My name is Javira Queen. I'm a lab technician. So I would like to ask the first question to Dr. Alfred. He talked about the Abbott strip that is being used for TB testing, but there are quite a number of different brands on market. So my question is, are there any measures being taken to make sure we have a uniform kind of testing, like people are different, using different brands, so are they uniform results? And then I would like to understand from Ms. Lucy how the app, the AI-enabled app works. How is the data collected? Like, is it collected by the patient, by tapping somewhere? How is it exactly collected? Thank you.
Thank you very much. We have a question here, I think. Okay, please. Okay, please also have one from Dr. Kauma. Go ahead.
Thank you so much, presenters. And apologies, because I was not as good as how to get the names, but I will just address to the presentation you made. Dr. Evelyn from WHO. I have one comment and one question. I will start with the question. It goes to the gentleman who presented about the treatment decision algorithm. I'm just interested in knowing whether you also categorized these children to 0 to 9 years, or it was general from 0 to 14 years? Because for the scenarios in WHO recommendations, they have those ones for 0 to 9 years and then 10 to 14. Then the comment we go to, it's a comment and appreciation to the gentleman from Bidibidi who presented about stool for TB diagnosis in children. He did mention about the low TB in stool and compared it to sputum. I would comment that that is expected, because for the stool we are looking into the swallowed sputum. So since the sputum is the primary source, there it is not. But thank you so much and for the advocacy of use of stool for diagnosing pediatric TB.
Thank you. I think we have one more question here.
Thank you, Chair. My name is Joseph Kaumba. I'm directing my question to Lucy. Lucy was talking about cough monitoring. And in her concluding remarks, she was talking about looking at roll-up of this cough monitoring as part of the care package for TB patients, I imagine. That I want to ask her to be more, to say a bit more, what can be added to our present day practices for looking after TB patients in order to make this possible. I don't know if my question is clear. What can be added to what we have now in the program or in the health facilities in order to make use of your finding regarding the value of objective cough monitoring?
Thank you. Martha, please go ahead with your question. Sorry, Chair, I've overruled you.
Thank you. My first question goes to Dr. Alfred, and I just wanted to know what the recent prospects for diagnosis of TB in children are, and whether we have, what does the future look like in terms of the landscape for diagnosing TB in children? And the second question goes to Okot. And
thank you so much, Okot. Other studies have reported urine LAM and urine expert being low in terms of sensitivity. What could have caused the differences? Because I can see you have quite a high sensitivity for urine LAM and urine expert. Thank you.
Okay, thank you very much for all those questions, and I think we can start answering them from my left as we move towards this side. Thank you.
Thank you, Chair. The first question addressed to me was, why was the rifampicin status not known in one of the results? Yes. As I said earlier, out of the test that we did, the one that had low or very low or trace, they turned negative. Now, when it turns negative, automatically you will not know the rifampicin status of that particular sample in stool. Yeah. Then I need to appreciate the staff of MOH, Minister of World Organization. Yes, in my previous, in other presentation, I concluded that this test yields very good results. However, there were restrictions in this other presentation, doesn't give a conclusion part so much. However, SOX tool processing method is really very good, and if we take it up, we shall really get a lot of positives, especially in children below 14 years. Thank you so much.
Okay, thank you. I had two questions. Dr. Willie, you asked about the individuals without cough but have abnormal chest X-ray, how they were managed. First of all, the data analysis, we not do it by presence or absence of symptoms, but this information is available, so we can do that sub-analysis. However, we recognize that there are individuals who may have no symptoms, but have abnormal chest X-ray. So our algorithm for X-ray screening, we say that we prioritize the high-risk populations irrespective of presence of symptoms. So as long as someone has a risk factor for TB and is accessing services, we prioritize those ones for X-ray screening. So definitely they are there. We can analyze the data by symptom screening and see what to do. And then regarding the management, I think once they are confirmed with TB, we manage based on the standard guidelines. So they are all started on treatment. Maybe the question will be on those who are not bacteriologically confirmed but have abnormal chest X-ray. They could be contributing to the PCDs that we are seeing, the high PCDs that are reported from X-ray data. And that's an area of concern which is a limitation for our implementation, and it's being addressed through capacity building of the health facilities. And then the second question, Dr. Alfred Semitala, the proportion of those diagnosed with TB with abnormal X-ray who are confirmed with TB. That was the data I wanted to show from my updated presentation, but I have it here. It shows that out of the 21,000 who were screened with the X-ray, 3,500 had the abnormal chest X-ray. Then we further looked at among the people who were confirmed with TB, there were a total of 629 who were bacteriologically confirmed with TB. But when you stratify the proportion of those who had abnormal chest X-ray, we see that 559 of those were actually having abnormal chest X-ray, which is a yield of about 32%, compared to those who had a what? From our definition of abnormal chest X-ray, we use a threshold score. At the moment, we use 50% as our what? Cutoff to say you're abnormal or abnormal X-ray or normal X-ray. But already we are seeing from the lessons here is that even those who have who are confirmed with TB with the lower scores. So it's now a cause for us to adjust our threshold so that we can be able to take in more people. And that justifies why we need to calibrate our card in our local setting based on the data available. And those are already plans underway to do that. Thank you.
Thank you very much, my sister, for the question about the urine lamp and GeneXpert urine sensitivity. I'll begin with the urine lamp. So our study participant, the one who were HIV positive, because we subjected all the study participants to HIV tests, and the one who were HIV positive were the one which were administered lamp tests in compliance with the WHO recommendation and TB testing algorithm. And the 76.8 sensitivity is comparable to other studies that are done. But if all were submitted to urine lamp, because urine lamp is currently recommended for only HIV positive people, so it will go to around 36 something sensitivity, but we have subject only HIV positive to urine lamp. So there are many school of thoughts in the literature, as I was reading, about the pathophysiology, why the Arab. This was not possible before if you read earlier literatures because of the introduction to Sulfit for their robust machine, the introduction of the GeneXpert Ultra. Because GeneXpert before used to detect above 116 coliforms of TB in a sample, but with GeneXpert Ultra, the sensitivity has improved. It detects as low as 16 coliform. Other studies say almost 6, which is comparable to sputum culture now. So it's because of the Gene Expert Ultra cartridge, which now detects lower level of Gene Expert TB coliforms in urine. Thank you very much.
Yeah, thank you for the questions. I got one question from about different brands of Abbott on the market for lung testing. My thinking is that, you know, when products become available on the market, they can easily cross into the country. But we have the National Drug Authority, the National TB Program in conjunction, to be able to regulate that. But I'm assuming that by the time a test crosses into the country, it will have been scrutinized at all these. NDA has an office at Entebbe, and we import kits, especially for our kind of studies. What we go through makes me feel it is a little difficult for products to cross into the country before they have been fully certified, because we usually have to get performance documents, documents from the industry, from other partners, where they have been tested, evaluated from elsewhere. We have all that documentation submitted to NDA before they allow us import. So I'm under the assumption that the kits that you find on the market have gone through that process. And if you find they perform differently, I don't know how you have compared them, this information can be useful to NDA. You had recently them withdrawing some drugs from the market. So I think if that information has evidence, I think it will be useful to the country, especially to the regulatory team. About the landscape for diagnosing TB in children. That has been the most challenging area. I've learned from the pediatricians with the interest in pediatric TB that their diagnosis is made primarily clinically and also based on chest x-rays. But in terms of specimen processing and how that performs using the current platforms, the Gene Expert, the microscopy, and all those standard known tests actually perform relatively poorly in children as well as in people living with HIV. And so specimen like, you know, they can't expectorate. You have to induce them. You have to do triangle aspirates, you know, all those kinds of relatively invasive procedures. But the good news is that the platforms that I showed earlier on in my presentation and evaluation, a couple of them are AI-based and they're actually targeting children, including Stethi. Stethi is one of them, level 42. The cough sound recordings that Lucy is making is working on part of that. And a couple of other molecular tests. Let's just pray that there's a breath analysis. We have found that actually breath biomarkers for children tend to differ a little from those in adults. But what this means in the context of clinical management of TB in children is yet another question. So right now the landscape is basically what I've mentioned. And I think in the next couple of years, with these molecular tests that are in the offing and the adoption of AI, including the ultrasound, the POCUS platform, I think those are good directions in diagnosis of TB in children. Thank you so much. As far as I know.
Thank you so much, Dr. Ndama. Maybe to answer the question from a representative from the WHO about the children stratifying by their band 0 to 9, then 10 and above. Yes, so what we showed there was cutting across 0 to 14 years. But in the manuscript that is about to be submitted, all that will be there. Thank you.
Thank you so much. I got 2 questions. One of the questions was, how was cough data collected? Okay, one of the things is we gave our participants smartphones and installed in this app, the Hive app, whereby these participants went home with a phone, also escorted by our health workers to ascertain the place of residence. We taught these participants how to use the phone. And also we provided them with pouches. They wore the pouches around their chests, whereby the smartphone was placed, so that the distance between the phone and when they're coughing is not very far. So ideally, these coughs, the app would identify these sounds and cough and store it in a server. And when this person maybe had internet connected on the phone, would be able to download. The beauty is, even when there is no internet on the smartphone, these coughs were still being captured. Then after 2 weeks, when we call these participants back, we would pick the phones, download all the coughs that have been uploaded onto the server, and we're able to analyze. But we had to provide these participants with smartphones to be able to capture the coughs. I hope I've answered you. Okay, then my second question was, what can be added to the value of cough monitoring to make it possible? Now, this is a work in progress. Right now, what we are adding to this, we found that we had limitations with actually the phone, though it performed to us very well. There's a security bit of it, somebody having a very smart phone and we're giving to a patient. The phone is so expensive than even where the patient is maybe staying. We had some security concerns. But then this is a work in progress to make this more efficient and easy to use. We are moving maybe from phone to something else, maybe a smartwatch. And we shall maybe possibly to have some logistics, have a platform in a health center whereby the health worker is able to monitor every presumptive patient who will come in with coughs, and maybe provide this and see and monitor this person's coughs. When if the person moves to Yumbe or to Golo far away, you're able to monitor this person's coughs online as long as that device is connected on internet. Possibly, thank you.
Okay, thank you, our dear presenters. I think as we come to close this session, let's give them a hand clap. Hello. Good. Thank you also. Give my co-chair and myself, give us a hand clap as well. Good. Okay, bring this session to a close. Back to you, Connors Committee.
Thank you very much, Chair, Co-Chair, and presenters for this very engaging session. I just would like to remind us that there was a QR code on each table. We'd like to get your feedback on the presentations that you've had today, the abstracts that were selected, the content, the capacity building session, the venue, and so many other aspects for us to take note of and note areas that you've appreciated and areas that we also need to improve. So kindly provide your feedback using this form. We've lost a little bit of time, but we are going to have one more session before we break off for lunch. And it might probably be one of the most important. It's about leprosy. Some of us don't get to hear that much about leprosy, as Dr. Kauma mentioned earlier. It's maybe mixed with TB. But before we do that, Beat is going to give us a quick energizer. And as she comes, I'd like to invite our chair and co-chair for the next session, leprosy and zoonotic diseases, Dr. Musinguzi Patrick, and our co-chair, Dr. Kauma Herman. As they come, Beat, just give us a quick energizer. We've been seated for some time so that we can go into our last session before lunch.
Good afternoon, everyone. I'd like us to stand up for a quick energizer. It's one of my favorites. I like to do that because you can do it anywhere and you don't need any equipment. And to remind ourselves where we are, we're at the National Tuberculosis and Leprosy Science Summit. We'll write that with our body parts. So we start easy with national and in our right hand, an advantage for those who write with their right hand. You can do capital letters or small letters, joined or, so I've reached the L. Now, don't do the abbreviation, we do the long one, tuberculosis, so that we remember how to spell it properly. With the left hand, please. Oh, some are very quick. I've not yet reached tuberculosis. I'm there. Now it gets a bit more difficult. Leprosy, we use our right foot. Okay. Okay, I want to see you wobble. Leprosy, L-E-P-R-O-S-Y. Science. The left one. Okay, well done. Science, S-C-I-E-N. That's a bit more wobbly for me, at least. E. I've reached the end. Now you wonder where we do the summit. It's with our hip. Summit. S-U-M-M-I, don't forget the dot, and the T. Thank you. That was the National Tuberculosis Leprosy Science Summit written with our body part. Thank you. Enjoy the next session.
Thank you, Beati. So yes, Dr. Musinguzi Patrick and Dr. Kauma Haman, if you could please come up and introduce or invite the speakers, the oral abstract speakers. They each have 6 minutes, but for the tackling neglected tropical diseases, we'll give it 10 minutes.
Thank you. I greatly appreciate this opportunity to participate in this very important function, especially that it is giving the not so common opportunity to give a hearing, a whole session to leprosy. So I would like to invite Deshan Tadese, if she's there. Then Dr. Rose Kengonzi to join me up here. Then Queen Javira. Then Daniel Akuku. Akuku or Akuku. Semwanga Stephen. Dr. Semwanga is my successor where I started more than 30 years ago. Should sit near me. Near me. One on this side. And is Mr. Moses Kawikizi here? I was told that he will be the one standing in for Lisa Gerving. Okay, the different presenters, when it is your turn, you'll introduce yourselves. So I won't do that, but I will take just a second to introduce myself. I am sitting here with the background of when the first National TB and Leprosy Program was formed, okay, starting from whatever was there. So it is an opportunity to see what has happened over all these years. I was for a time the Deputy Program Manager. I was for a time with the Uganda Stop TB Partnership, with the German Leprosy and TB Relief Association, and on many other fora, but mostly connected with leprosy. So in this session, where we talk about leprosy that was wisely combined with TB, we want to find out what is happening regarding leprosy in Uganda. We know that there are still many new cases of leprosy, not in the same way as they used to present in the past. Like 10 years ago, the concentration of cases has changed, and maybe there are new emerging challenges regarding continuing to care for this neglected tropical disease before we attain zero leprosy with everyone else by 2030. I would ask you kindly to wipe out from your minds for this afternoon the zoonotic part of the earlier documents. We look at leprosy and neglected tropical diseases. So with that introduction, I would like to invite the first speaker, Mr. Moses Kawikizi, who will talk to us about the talking neglected tropical diseases. Mr. Kawikizi, you have 6 minutes. I hope somebody will help me with recording the 6 minutes.
Good afternoon, ladies and gentlemen. I am Kawikizi Moses from Uganda National Alliance Against Leprosy. I'm standing in for Lisa, Head of Humanitarian in JRA. I'm a community-based inclusive coordinator for UNALEP. I one time worked with Dr. Joseph as a social advisor for German Leprosy Association and other activities. So now we are going to talk about Talking NTD project. This project worked in Zombo, and it was a 2-year project. So our project we are talking about is participation of persons with disabilities related to leprosy and lymphatic filariasis. So more than frequent when you see we talk about leprosy, we are talking about diagnosis, treating, and curing, and disability. But the reason is the causes of the effects of the disabilities are what we are going to discuss. So leprosy and lymphatic filariasis affect the poorest people. And Doctor, I think this is a different one. It is not the one for Lisa. Yeah. That one was the Talking NTD project. Yes, that one. Yeah. So in this project in Zombo, we are strengthening the local health systems and community resilience to prevent and address NTDs and related disabilities through gender-sensitive, equitable, and inclusive services in Zombo district West Nile region. So the team of the authors was Lisa Adima, myself, and Dr. Omara Jamem, who is the medical director of Nyapeya Hospital. So we are saying that between September 2021 and August 2023, German Leprosy Relief Association and Uganda National Alliance Against Leprosy, in cooperation with Nyapeya Hospital in Zombo District, implemented a project to address a holistic manner, clinical and social aspects of neglected tropical diseases, especially leprosy and lymphatic filariasis, and related disabilities, including discrimination, poverty, isolation, and it was founded by Austria government through Plan G. So based on the findings which we initiated with the CAP study, with the focus group discussions, the training of curriculum was developed to 348 trainees, community workers in strengthening community aspects of neglected tropical diseases. Community workers were also trained in screening for disabilities in relation to NTDs, especially leprosy and LF, and the GAS mapping was done, and also we handled gender-based violence. We did advocacy activities through developing and forming of support self-help groups, which we have 14, and also 14 self-care groups. And we gave them capacity to build activities which they can do. Like when we talk about self-help, we are talking about livelihood. And when we talk about self-care, we are talking about self-maintenance. Then we also had 30 health workers and 15 laboratory people. We are trained to strengthen medical knowledge and diagnostic capacities. 100 people, but we had a bias of gender sensitivity, and we took 75 female and 25 male in gender-based violence workers as community level. So they were sensitized and we are trained in gender-based violence and reproductive health. And 14 female community workers, community nurses, we are trained to provide reproductive health services and maternal care for the women and girls living with disabilities. 100 younger women living with disabilities were trained in livelihood activities for that period of the project. So the key findings, we find that 19,161 households we have visited for screening and sensitization on neglected tropical diseases, including addressing stigma and discrimination. 3,828 simple assistive devices were produced. These simple devices are produced via appropriate technology, where we normally use local available resources and technology. So we managed to produce 3,828. 2,889 hygiene kits for persons with septic wounds were distributed. These hygiene kits were going along with what we call the hygiene kits, so that we train these people to care for their wounds through community-based rehabilitation, following the home-based concept. The same number was trained in wound care, in relation to self-help care groups and home-based care activities. 14 self-help groups were formed and received the startup capital. So when we are forming these self-help groups, working together with stakeholders to benefit, working together with stakeholders, we give them startup capital to start working their things. Then persons living with NTDs were mapped to follow-up through GIS mapping to get their location. So the implications for the National TB Leprosy Program is that for the National TB Leprosy Response, the project demonstrates possible ways to initiate a holistic response, especially in relation to leprosy. The activities implemented by the project demonstrated that a comprehensive approach can positively influence the local situation in the longer term across economic, ecological, social, and political aspects. So creating synergies with different stakeholders on local, district, regional, and national levels is very important to address the neglected tropical diseases. This holistic care approach and sustainable approach goes beyond immediate health concerns, but cooperation and collaboration with more stakeholders contribute to creation of lasting positive impact. So that when you see that summarized picture, you find that in that one which is on my left, where the ablation is, that was a session of providing starter hygiene kits and then training in, through demonstration of how we do self-care for wound healing. Then you see the group with the very many wounds there. That was is still a very big problem in Zombo. And down is a sample of what we make up as the low-cost assistive devices. The acknowledgement goes to all those who on that slide. Thank you very much.
Thank you very much, Moses. As he comes back to take up his seat, the National TB and Leprosy Program, in the last session, we talked about post-TB lung disease, and this is part of post-leprosy problems. Okay, there are similar, a different kind of problems, but there are situations lasting after, continuing after cure of leprosy. I would now like to invite the person who didn't come up, Didan Yatesa. And Didan Yatesa is going to talk to us about addressing the interaction between leprosy and zoonotic diseases, a One Health approach to Uganda.
Thank you so much, Chair. Good afternoon, ladies and gentlemen. My name is Didan Yatesa, and unlike the rest of the presenters who have been here, I am not affiliated to any organization. So potential employers have somewhere to choose from. I'm a student currently pursuing a master's degree in veterinary preventive medicine. My profession, I'm a doctor by profession. I did veterinary medicine at bachelor's level. I'm here to present to you about addressing the interaction between leprosy and zoonotic diseases, and this was a One Health approach for Uganda. I'm calling it a One Health approach because that was my hypothesis for this conceptual research study. Leprosy, like we all know, that what we are discussing currently are neglected tropical diseases. Now, leprosy is one of the neglected tropical diseases which continue to pose a significant public health challenge in Uganda despite efforts to control it. This relation between chair side we try to avoid talking about the zoonotic diseases. So, okay, thank you so much. This, there is an interaction between leprosy and zoonotic diseases, which present a very complex yet understudied area that requires the attention of us all. If I may, I request to be guided, but from the previous presenters, those who actually addressed themselves, I had a few who talked about themselves being environmental specialists or being veterinarians. Most of them you hear, I'm a doctor working with Mlago, or what I got from it, most of them are human doctors. I didn't hear anyone address themselves as an environmental specialist. So this is giving us a very good way forward, a One Health approach, where we actually need everyone involved to be able to make sure that the number of actually reported leprosy cases decline. In this research, I was able to realize that by 2030, we need reduced leprosy cases. But when you look at the data from NTLOP for the previous 3 years, there was 377. The next year, it was 477. Then the previous financial year, the most recent, it was 489 cases. So are we really reducing the number of cases? Because the goal is to have them reduced by 2030, but I actually observed they're increasing. Now, this conceptual research proposal aims to delve into the interrelation through a One Health approach, focusing on understanding the transmission dynamics, shared risk factors, and implications for human and animal health in Uganda. My specific objective for this study, one, was to investigate the epidemiological linkage between leprosy and zoonotic diseases. Two, examine the implication of zoonotic leprosy on human and animal health. To explore the strategies for addressing the interrelation between leprosy and zoonotic diseases. Then assess the roles of key stakeholders in mitigating the burden of zoonotic leprosy. Why am I calling it zoonotic leprosy? It is the major reason why I'm emphasizing the One Health approach. We are going to see why. The methodology, like I said, it was a conceptual research. I did literature review. Because of time, I'm not going to go through details of everything, but I will be able to share my presentation. It is very detailed. You can read through and understand very well. Where clarification need be, I'm available. Stakeholder interviews and data integration and synthesis, critical analysis, because it was a concept where papers were collected from different sources. So I had to critically analyze the data, interpret, and come up with conclusions. What were my key findings for this study? One, I realized that there are epidemiological linkages. The analysis of the epidemiological data revealed that there is spatial and temporal distribution of leprosy cases within the country. Was also able to notice that the leprosy cases are not, like, you cannot find them in one place. You can find one in Gulu, find the other one in a totally far away district. Then I actually realized that in the reporting system, in the surveillance, how they report their leprosy cases, it is by district of diagnosis, not district of residence. So if we can incorporate in the district of residence, it can be able, because if someone has a leprosy and maybe staying in Impigi, district of diagnosis is Kampala, and we incorporate in the district of Oligin, it can help us to be able to trace the contact cases. Examination of the implications of zoonotic leprosy on human and animal health. Okay, thank you. Then the roles of, I was able to come up with the roles of the key stakeholders, which I will actually summarize in the next few slides. Then my implication of the National TB and Leprosy NTLP, one, we need a One Health education. We need to incorporate in a One Health principle in where we talk, we include the medical human doctors, the medical doctors, the environmental specialists, to be able to address the interconnectedness between the human, animal, and the environmental health. Two, to foster collaboration among the healthcare professionals, veterinarians, environmental scientists, policymakers, and community members. Now, this interdisciplinary collaboration is different from the One Health approach. In the One Health approach, we are looking at the key personnel. Then in the interdisciplinary collaboration, we as well involving the community and policymakers. Remember, policymakers can be from the three key sectors. We need to engage the community. We need to advocate for policies that support One Health initiatives and allocate the resources, as well as put more funds in the research about leprosy. Continue surveillance and monitoring. Now, surveillance is already in existence. We need to strongly to renew the strength and as well as establish new means of surveillance to be able to eradicate these cases. We need to come up with the truth about the prevalence of leprosy in the human and the animal population. We need to address all the environmental factors that enhance transmission of leprosy and zoonotic diseases, such as we've heard about right now. The temperatures are abnormal, and it is not only affecting us, the humans, it is also predisposing us to many conditions, to many diseases. So when you address these conditions that actually lead to global warming, for example, habitat destruction, where we cut down the trees, which we actually know their role in absorbing carbon dioxide, as well as habitat for these animals, we can be able to address the challenge that we have at hand, not only with leprosy, but also as zoonotic diseases. Then in this research, I was able to come up with evidence-based arguments supporting the need to consider the One Health approach, which I will not be able to discuss because of time. And I as well came up with the role of the key players, the health professionals, veterinarians. I will be around to discuss them on a personal basis. I now have run out of time. Then my conclusion is this conceptual research proposal aims to contribute to understanding of the complex interrelationship between leprosy and zoonotic diseases in Uganda and provide insights into effective strategies for addressing the challenge. By adopting a One Health approach, integrating perspective from multiple disciplines, and engaging the key stakeholders, we can work towards mitigating the burden of zoonotic leprosy and improving the health and well-being of both humans and the animal population in Uganda. Now, as I conclude, I doubt whether people got it well why I said zoonotic leprosy. There is evidence, for example, in the USA, where there was transmission, according to these research papers, there was transmission of leprosy from the animals known as amygdaloids to the humans. Two, there was genes. There were genes of it was soil amoeba that were actually detected. Genes of leprosy, of soil amoeba detected, which are actually the same genes found in humans that are actually suffering from leprosy. There was also evidence of transmission of leprosy from the animals, that's the non-human primates and rodents, to the human population. Basing on that, I call it zoonotic leprosy that requires a One Health approach to be able to address it and reduce the cases of leprosy in Uganda. Thank you so much for listening.
Thank you very much, Didan, and once more I will apologize for having a kind of reduced interest in this very important discussion regarding what you have labeled zoonotic leprosy. We'll call our next presenter, Dr. Rose Kengonzi, to talk to us about exploring the pathways of leprosy patients from their communities to a diagnosis in the districts of Mayuge, Yumbe, and Kasese in Uganda. Dr. Rose Kengonzi is a senior medical officer at the National TB Leprosy Program, and she's the focal person for leprosy at the program. Dr. Rose.
Good afternoon to you all. Yes, just as I will not introduce myself, the chair has introduced me ably. And before I present the project, I wanted to just give some summary about leprosy. I'm sure some of us may be hearing about it for the first time. Just to know that leprosy was eliminated as a public health problem about 3 decades ago in the country. We know there have been a lot of efforts and achievements in the fight against leprosy, but we need to increase more efforts so that we can be able to eradicate the disease. So we need as many stakeholders and a strong political will to be able to have the zero leprosy status that we are envisioning as a program. Research is one of the key aspects if we are to be able to eradicate leprosy. With that said, I'm going to briefly describe what our project was. The title of our project was Exploring the Pathways of Leprosy Patients from Their Communities to a Diagnosis in the 3 districts, Mayuge, Yumbe, and Kasese. Next slide. So as a brief introduction, as I said, although Uganda is considered as a low endemic country for leprosy, we still see some regions reporting up to 50% of grade 2 disability, which means that by the time the patients report and the diagnosis is made, they already have disability, which is visible. And this implies that late diagnosis can contribute to continued transmission, of leprosy in the communities. So in this study, we aim to describe patient journeys from their first symptom to a diagnosis and individual as well as community level factors associated with health-seeking behaviors of our leprosy patients. So our specific objectives, we wanted to determine the reason for delay in seeking health care. We wanted to assess the knowledge, attitude, and practice among the members of the communities and healthcare providers in reference to leprosy. We wanted to identify the possible cultural ways of interpreting the signs and symptoms of leprosy, and also be able to describe the differences in behavior and beliefs by leprosy, disability status, and by adult or child leprosy index case. So in summary, the design methods and analysis. It was a mixed method study where we did both qualitative and quantitative approaches. We had about 155 leprosy patients. These were patients that had visible disability, and in the targeted districts of Yumbe, Mayuge, and Kasese. And we did this in close cooperation with the DTLS. And also to ensure efficient use of resources, we also did screening of the contacts during the visits. Key findings, the most common first symptom noticed by the patient was skin lesions. As we know that leprosy presents as a skin lesion. Okay, so in this study we were also able to demonstrate that actually the most common symptom was skin lesions. These are patches or nodules, followed by deformities. So 18% of our patients got a diagnosis when they already had visible disability. To note, the duration of symptoms before diagnosis was made on average was 2 years. But to note that it was a range from 2 months up to 240 months, that's almost 10 years. So some patients actually presented after 10 years having noticed their skin symptoms. And the main reason for delayed seeking medical help were limited knowledge and understanding of leprosy among the participants, fostering common misconceptions. The other main reason was access barriers. So about 63% of the respondents thought that it was difficult to access the health facilities. Looking at the treatment-seeking behavior, we noticed, especially during the focus group discussions, that some participants actually visited multiple health facilities before receiving a proper diagnosis. In point to note, just one of the response from the participant from Kagando Hospital narrated, and I quote, "When my child fell sick, I started from Kagando Hospital, and my child was treated but did not get any positive response, so I had to take him to Wera Hospital, where I was diagnosed to have a fungal infection, was given medicine, but the fungal infection was not healing. Then he was referred to Kansanga Health Center 3, then referred back to Kagando Hospital. At this point, the child had started having wounds on their feet and their hands. So they referred me to Mr. Kaze Jackson, who confirmed leprosy. That was a female caretaker that gave that narrative. Stigma and discrimination was also one of the major findings, mainly in Yumbe. Okay. Also other 2 districts reported, but it was mainly in Yumbe. And important to note that stigma extended not only to the patient, but also to the family members and caregivers, leading to discrimination against them. And the social interactions were negatively impacted due to fear of the people around thinking that they can get leprosy, leading to isolation and loss of relationships. What are the implications for the NTLP response? We see from the project, access barriers and lack of knowledge on symptoms of leprosy, which were mainly misinterpreted, were associated with a delay in the diagnosis. The study showed that we need to increase the knowledge on early symptoms of leprosy among the communities. We also need to promote healthcare worker training in leprosy control activities. As we said, we saw many people who actually visited several health facilities before a diagnosis was made. Yes, that action photo is we want to beat leprosy, okay? Where here we are aiming at zero transmission, zero disability, and zero discrimination, and hoping that as you are selected, you're all stakeholders, and it is possible by 2030 we could actually eradicate leprosy out of Uganda. Thank you so much for listening. Yeah.
Thank you very much, Dr. Rose. I think there are people who have questions. They will ask you afterwards. I would like to invite the next presenter, Queen Javira, to talk to us on capacity building of private health facilities for TB and leprosy testing in Uganda, a case of Kampala metropolitan area. Okay, and try to stick to your time as she's preparing. I remind you, you have had Dr. Ross talking about access barriers, and yesterday afternoon, Dr. Katamba was talking about case detection, delay case detection for TB and access barriers. And many of the challenges he listed are similar to what comes out on the list from the last presentation. It's just to argue for we can do a bit more for leprosy. Okay. Please.
Good
you will
afternoon.
Introduce yourself.
Javira Queen Nalinya is my name. I'm a lab technician. I'm doing private practice with Rocket Health Uganda. It's on that note that I speak about last mile service delivery with passion. The topic is capacity building of private health facilities for TB and leprosy testing. That is specifically for Kampala metropolitan area, Kampala, Wakiso, and Mukono. The introduction is just to show us that TB and leprosy are actually a threat with that very high number of people being infected. And therefore, this research was conducted to assess the preparedness and capacity of community health service facilities to diagnose. Like Dr. Alfred Andama said, diagnosis is the biggest gap we have with management and care of these diseases. And then we also attempt to suggest a more efficient way of improving diagnosis, specifically starting with screening. The design was documentary view. We have a lot of literature that is on the internet that about the activities that have been performed before. We had a randomized physical survey. And the key findings were these, that the first one is the number of health facilities that we have in Uganda. That is a preamble to show us that a very big percentage, about 40%, are private for-profit facilities, and these are majorly low-level medical facilities, medical centers and clinics, and these are actually very community-based. They are the facilities that the common person is going to have easy access to. And those are, the Kampala has a total of 1,458 facilities with 1,371 being private for-profit facilities. Like I said, they are the low-level medical facilities, medical centers and clinics to be specific. There was a randomized survey of where I come from, Busiro East in Wakiso. Only 4 health facilities are able to do testing for TB. You can imagine it's a lot worse for leprosy. So for someone from my village, they would have to go to one of those 4. You can imagine the number of people they would have contacted during the time of their journey. And what this implies is that we need to have a massive capacity building For example, one of the ways we can build capacity is build a working hub system. This is explained here. I borrowed a photo from the hub system of HIV testing. This is the central lab is CPHL, and these are all the other medical centers that are down here in these communities. So health workers are trained to collect or screen these samples, and in case there is any referral to be made, there are hub riders that can move these samples to a central testing facility that could help with the diagnosis and confirmation of disease. So that's one way of building capacity. Then there should be comprehensive training of health workers. I'm very sure now that leprosy, like the speakers were saying, it's one of the neglected diseases. These health workers in the communities would actually need refresher trainings on how to screen. Now, she has just shared a story that a caretaker went and they diagnosed fungal diseases, yet the actual thing was leprosy. So we would need to do refresher trainings for our health workers so that we can have accurate diagnosis and screening programs. Then another implication is development of simpler but effective screening methods. For example, now for leprosy, I know of the lepromin test, but it's not simple. Can we develop things like test strips that can easily be used for even, I don't know, the lab technician down in a medical center somewhere, instead of someone having to move to a health center for? That was the action photo and acknowledgements. Thank you for listening.
Thank you very much for this presentation that is also relating to other presentations. Even earlier today, it is pointing out clearly that there are laboratory challenges for leprosy as well, looking for more appropriate technologies to use that can be countrywide, that can make access to laboratory diagnostics, which are important for finding the most infectious leprosy cases. We depend on the laboratory for this. Thank you very much. Then we call our next presenter, Daniel, he's that way, Akuku, to talk to us about assessing preparedness of lower health facility staff in diagnosing and management of leprosy, and is presenting a case study of Bidi refugee settlement, Yumbe district, West Nile. The rest you'll introduce yourself, Daniel.
Thanks so much, Chair. I'm pleased to be here, and I appreciated the presentation from my fellow epidemiologists, that is Geoffrey and Harriet from Ministry of Health. I appreciated your presentation. My name is Akuku Daniel Amoko. I'm a student pursuing public health, Gulu University. At the same time, I'm working with the International Rescue Committee, IRC Bidi. We're implementing primary health care, community health, reproductive health, etc., not forgetting research and innovation. I'm presenting assessing preparedness of low health facility staff and VSTs in detection, diagnosis, and management of leprosy. This case study was conducted in Bidi refugee settlement, Yumbe district, West Nile. My co-authors are Dr. Akim Kalonji, our health manager Dr. Asip Bazeo Pesens, that is our Deputy Health Manager. Then Dr. Ochil Williams, he is our TB leprosy focal person. And Andamati Sunday Monks is our public health specialist. The brief introduction, leprosy is a neglected tropical disease. Globally, new leprosy cases were estimated to be 127,896 cases in 2020 WHO report. The strategic development goal, sustainable development goal, is to achieve global leprosy elimination strategy by 2030 with a prevalence of less than 1 case per 1,000 population. And Uganda happens to be among the 20 countries with the new leprosy cases. And West Nile carried the biggest burden of new leprosy cases at 80.2%, with Yumbe, Arua, Maracha, Madiokolo district having the highest prevalence. And Yumbe has been rated the third in the last quarter with 18%. And at least 1 case is missed every day at health facility. Our study aimed at assessing the knowledge, competence among low health facility staff, including even VSTs, in identifying, screening, diagnosis, and management of leprosy cases in Bidibidi settlement. We used cross-sectional study design, and we even review record and registers at facility level. We target healthcare staff and VST, and I have not included, but we target around 286 healthcare workers. These include clinicians, TB focal persons per facility, nurses, midwife team, maternity team, and even cleaners, including even askaris. We target around 410 VSTs, but we end up interviewing 392 VSTs for a period of 1 year, January 2023 to December 2023. We assessed the knowledge and competence of the healthcare staffs in screening. We developed questionnaires where we categorize them in terms of screening at the gate, diagnosis, and treatment protocols, where we gave to health team and they work on these questionnaires. Again, for VSTs, we generated some questionnaires on information materials, active case finding at community level, and referral, follow-up of clients at community level. Then we review records of client identified and enrolled on treatment for leprosy. And this data has been analyzed here. Bidibidi settlement has been divided into 5 zones, where in zone 1, at least 74% of healthcare workers are competent and knowledgeable in either in screening, diagnosis, and treatment. 82% in zone 2, 87% in zone 3, 71% in zone 4, and 89% in zone 5. Equally to the VSTs, in zone 1, 33%, zone 2, 24%, zone 3, 41%, zone 4, 53%, zone 5, 33%. Our key finding, overall, we sum up the result in those 5 zones, we realize 80.5% of the healthcare workers and 40.2% of VSTs were knowledgeable in diagnosing and managing leprosy cases, respectively. Additionally, it was found that 30% of the VSTs and 98% of TB focal persons had received training in leprosy diagnosis and management. And from our data that we reviewed, we realized 20% of the leprosy cases were identified by VSTs. The survey result indicates significant increase in leprosy diagnosis competence post-training, suggesting that the training has impact on the knowledge and the skill of the health workers. This highlights the importance of training program in improving leprosy and management in the health system. Further evaluation may be warranted to assessing the long-term effectiveness of the training. From the survey, we realize at least in a facility, there's error there. At least a facility, we shall either receive a suspect, at least 5%. That is error, not prevalence. It's supposed to be at least a suspected leprosy case at least 5% per facility, and the majority being male at 60% compared to females. The leprosy cases we have, we realize the high burden is among the male compared to the females. It is attributed with the psychosocial and behavioral factors. Lastly, there is need for comprehensive training, regular supportive supervision on diagnosis and management of leprosy to VSTs and health facility. We encourage CME at our facility level because we realize trainings are only targeting TB and leprosy focal persons, but when they're done, they are supposed to cascade this training to other cadres. There's need to print and distribute IEC material translating to local language about leprosy, engaging and empowering VST in community engagement. That is the photo. We are taking VST through on the questionnaires. The other side is me taking the health staff through on the research questionnaires. Then this side it is training for TB and leprosy focal person, organized by us IRC with support from IGAD. My appreciation goes to my organization, UNHCR, IGAD, earmarked for TB, Ministry of Health, IDI, and my donor, Core Group Partners Project. Thanks.
Thank you very much, Daniel. Again, an eye-opener. Maybe I shouldn't call it eye-opener, but living in refugee populations is one of the risk factors, not only for TB, also for leprosy, with evidence even from this presentation that we just listened to here. There are a number of activities that are carried out there that can be rolled out elsewhere, and also openings for research, for operational research. Our last presenter is Dr. Semwanga Stephen on the economic burden of leprosy diagnosis and care linkage, a case report from Bluba Leprosy Treatment Center. You're welcome.
Thank you so much, Doctor. Good afternoon, everyone. I will be presenting the economic burden of leprosy diagnosis and linkage, a case study from Buluba Leprosy Treatment Center. And I hope that by the end of the presentation, you shall have a feel of how these patients actually suffer financially to find the right diagnosis and treatment. And I hope you will also note how actually some interventions like a capacity building can be of help to this problem. Okay, Buluba Hospital, having been known in the past for its treatment and rehabilitation in leprosy, up to date, it receives a number of patients with, from scattered regions of this country with leprosy, and majority of them have really wandered around different parts of different health facilities in attempt to receive right diagnosis and treatment. But in this particular case, we are also struck by the experience of this patient. So we thought we would share with you the experience of this one patient. Now globally, today we are about 6 years or 5 to reach 2030, which is the WHO target for elimination of leprosy. But globally, just last year, WHO reported over 170,000 new leprosy cases. Uganda, particularly, detects about 250 new cases every year. That is about, if you are using an average of the last 8 years. And just in 2022, we reported 581. And the majority of these new cases have grade 2 disability at the time of the diagnosis. And remember, one of the targets or one of the goals is actually to have 0 disability. And when somebody or a patient has grade 2 disability, he's really not doing well. And of course, the major contributing factor is delayed diagnosis and the treatment. So we intend to describe the economic experience and the total health care cost incurred before correct diagnosis and linkage to care of leprosy in a patient who presented to Buluba Hospital. It is in eastern Uganda. It is a case study of just an individual, and we used the medical records and the verbal reports from the patient. And particularly, this was a 65-year-old male. He's a livestock farmer from Chiboga. That is about 120 kilometers in the north of Kampala, northwest of Kampala. And of course, he had a typical presentation of leprosy we know today. His case was not different. He just noticed a patch on his skin about 2 years ago, and as a conscious individual went to seek health care. Of course, the story, like many other leprosy patients, he first got skin tubes for his treatment, but determined to get the right diagnosis and treatment, and as his condition was actually worsening, he didn't know that it would actually take him to move to about 5 hospitals, including even going out of the country to Kigali, Rwanda, to also seek help where he couldn't. Actually, to tell you a story of the journey of this patient, to be particular, from Chiboga, he went to Hoima, he went to Fort Portal, then he went to Kigali, then from there he went to Lacho, and then finally ended up in Mulago. And that is where they made the diagnosis and they referred him to Buluba Hospital for initiation of treatment and care. Sorry. Okay, yes. So, Of course, the most debilitating symptoms for this patient was the progressive lower limb weakness and the plantar ulcers that were making him unable to look after his cows. So, determined to get the right treatment, he actually sold over 3/4 of his livestock to get help in this whole saga of moving around within the 2 years, trying to find the right diagnosis. So from that, you actually realize that we analyzed and realized that this patient actually spent over a tune of 14 million Ugandan shillings just in attempt to look for the right diagnosis and treatment, of course including movement, transport, and all the costs, and even his story also included seeking care from traditional healers about a simple problem like leprosy. And of course you realize that delayed diagnosis and treatment was there despite his early treatment, and also you realize healthcare provider knowledge gap. So we think to the fraternity that further research is probably needed to study the quality of life for people living with leprosy after treatment. The previous study presented by Dr. Rose actually also looked at the experience of these patients before they get the right diagnosis. But we do not know that actually these patients, what happens to them after they have gotten treatment, because if the majority of them have grade 2 disability, that some of that disability doesn't come back after treatment. So, for example, this unfortunate individual who had to spend over 14 million, he's now in his 3rd year of treatment, but with the grade 2 disability, you wonder now what will be next for him and his career in livestock farming after treatment with this disability. We don't know. So we are continuing, we think continued treatment, training for healthcare providers regarding the diagnosis and treatment of leprosy through regular workshops, seminars, and short courses. In the Buruba Hospital, we do that, through strengthening referral systems and community education and awareness. That is just a photo of what goes on at Buruba Hospital. We host several individuals and we do capacity building for treatment and diagnosis of leprosy across the country and even visitors from abroad. And I acknowledge the following people. Thank you everyone and God love you.
Thank you very much, Dr. Semwanga. Out of his presentation is something that I think in this forum we have today, many things are high-powered, but there are also some low-lying things. We have had mention in this story of the person who has moved and he spent a lot of money on people who are treating with tubes. I wonder whether capacity building programs are targeting this. A lot of the people with skin conditions, that's where they go. But it's a question that would have been for my chair, who is absent from his chair. He's a dermatologist. He should have helped us in this way. This brings us to the end of our discussions, and because it is past lunchtime, I will accept just two questions from if there are questions to my presenters.
Of course, to Dr. Semwanga, thank you. So, I looked through your presentation and you mentioned about estimating direct medical costs while you're doing the economic burden of leprosy. I wonder which kind of method you used to come up to such an estimate besides the qualitative estimates? I'm Elin Wamanya and I work as a health economist at the IDI.
Is there another one? Yes, there's one there at the back of the room.
Thank you very much, the presenter. I needed clarification. I heard that the case you presented, that is the final presentation, that the patient was actually in the 3rd year of treatment. So I need clarification, was it the rehabilitation phase or the conventional treatment phase? Thank you.
Okay. Both questions are directed to
Thank you. Somebody reminded me that I forgot to introduce myself. I am Dr. Stephen Lodel Semwang. I work as the medical superintendent at Buluba Hospital, and I am also a student of Masters of Health Service Management. That is briefly about me. Now the two questions, I will go first to the last question, that you have observed that patient is in the 3rd year. Actually, either the presentation maybe is wrong or maybe you read it wrong, I need to clarify, but actually I just wanted to mention that the patient currently is in the 3rd month of treatment since the time of diagnosis today, because this case is about, the report is about 3-4 months old, really, not very old. So it is 3rd month of treatment, not 3 years. Just clarity. Thank you. Then the health economist, whose name I've forgotten, asked about the method of analysis of the estimate of the cost of the patient. Actually, I want to really tell you that this was just a simple estimate from the patient's narration of the livestock and animals that he had to sell just to facilitate his movements, as you heard the story and care. But actually, I want to invite you, since you are the specialist, to come and maybe help us actually come up with a more scientific estimate from that case, so that maybe we can inform further fraternities. Thank you.
Thank you very much, my fellow presenters. I think that our session was well placed between many talks and coming ones about TB. But as we close, I would like to say again to you, Uganda still has a burden of new leprosy cases. I would add, if I add the last 3 years backwards, 1,200 in the last 3 years backwards. Uganda has these patients scattered, but a large proportion of them are found in only the northwest of the country, as it were, for reasons that are not very clear. They are speculations. Uganda has a big burden of people who are suffering, who completed the official leprosy treatment, they went off the registers, and they need care. They need care post-treatment for TB. Uganda's zero leprosy strategy is aligned to the WHO zero leprosy strategy. So we would like to reach zero leprosy by 2030, where there will be no leprosy among children. People who are talking about TB in children, TB in leprosy is even more serious. We are using that as one of the indicators of our progress. And we still have a worrying proportion of leprosy among children. Well, there are people who are talking about vaccines for TB. I think I raised an issue about Uganda and BCG and so on against leprosy. Uganda was the example of where it was useful. We don't know whether it is still, but Uganda is going in for preventive treatment among the management of contacts of new cases. New leprosy cases are given preventive treatment as a single dose of rifampicin to prevent contacts of known patients that have been screened and they don't have leprosy from developing leprosy. This is one among many areas that are new in leprosy. Leprosy has many gaping areas for both operational and the detailed scientific research that I would invite you to, that I hope that in the next summit there will be even more from your different areas, the laboratory people, the social science people, the people from the economics and the others, that there are areas for you to study in leprosy alongside what you are doing for TB. Thank you very much for listening to us. Thank you very much, the presenters. And I would like to hand this back to.
Thank you, Dr. Kauma. Thank you very much. You're the perfect advocate for leprosy. So thank you very much, our leprosy panelists. Thank you for taking the time to do this research and coming to share it with us. You may now take your seats. It's now time for lunch. It is 3 o'clock, and we will have lunch in 30 minutes, and then be back here by 3:30. After which we will have 2 sessions, which will be each 45 minutes, because the DG will be coming in to close the meeting at 5 p.m. So we would really like to keep time. So please, 2 announcements as you go out. There's a set of posters. Please pass by and read the other work that was submitted that didn't manage to get into the oral presentations. Secondly, we have an evaluation of these 2 days that we would love for you to fill out for us. The QR code is going to be projected. If you scan that QR code, there's a set of about 10 very short questions. It will take you 5 minutes. Please fill out so that we know how to do better, because we would like to organize this next year, but we would like to do it better. So thank you very much. So please, the QR code is coming up. Scan the QR code, give us your evaluation of the meeting. Go for lunch, please. Pass by the posters. Be back by 3:30. Thank you very much. I will also put a QR code at each table so that when you come in after lunch, you will find it at your table and you can scan it and take part in the survey then. All right, there's also another announcement for our brothers and sisters who are fasting. The hotel is willing to pack your lunch for you, so you can have it at a time that's convenient. Please don't be afraid to ask. The hotel is providing packaging at a small fee, and they're ready to pack your lunch for you. Thank you very much.
and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health. Whenever you cough in a public place, you have to cover your mouth with a handkerchief and open the window if you can. This helps you protect other people close to you from getting whatever infection you may have. For example, cough, flu, and tuberculosis. This message is brought to you by the Ministry of Health.
Good morning or good afternoon, wherever you are. Thank you for having me at the
My name is Dr. Priya Westavia, the Assistant Commissioner in charge of tuberculosis and leprosy control at the Ministry of Health. TB is one of the infectious diseases that our country is dealing with. High burden country specified by the World Health Organization with an estimated incidence of 196. This is a drop from 200 that we have had over the last 3 years. It is this year that we have had a drop of 2.7% in our TB incidence, which translates to about 90,000 Ugandans falling ill with TB every year. As a country, we
So, good afternoon, ladies and gentlemen. Welcome back from lunch. So, we're going to have our second last session, which will be chaired by Dr. Estela Viragwa, who works with the U.S. Department of Defense. And this will be about policies and programmatic implementation. So over to you, Dr. Estela. Ladies and gentlemen, if you're outside, please come in. We are starting our afternoon session. Other presenters in the room. Shamim Nampoye from Uganda Protestant Medical Bureau.
Okay, good afternoon, everyone. As we prepare to get started, I will call up all our presenters for this panel presentation. Shamim Namponye is here, I believe, yes, from UPMB. Kasakaire Joel, is he in the room by any chance? Matende Henry from Kabale Regional Referral Hospital. Samson Omongot from MLI, the Lung Institute. Albert Musinguzi from the Pact Karamoja Project. Gertrude Abo, and Sylvia Namanda. I don't know if we have any of these in the room. We also will have Lillian Tugume, who was supposed to present yesterday on TB and comorbidities, but unfortunately did not get a chance to present. I will ask her to join us up here for the afternoon presentation. Okay, as we get started with the afternoon, allow me to continue to call up our presenters for the next discussion. Shamim is up here already. Henry Matende is well represented. We have Gertrude up here already. And Sylvia. Oh, Lillian. Good to have you here, Lillian. She will be presenting on comorbidities. Is Albert Musinguzi in the room? Do we have Samson Omongot? And Kasakaire Joel. Or I'll just give them 1 or 2 more minutes to walk in. I think I just have one more person not available. This is John. Okay, so we do not have Albert Musinguzi with us. Stella, can you allow me to get started with those who are up here? Jasper and Stella, just allow me to request you to alert Albert when he walks into the room to just join the presenters here at the front. Okay, so good afternoon, everyone. Once again, I welcome you to the afternoon sessions. Often the most difficult sessions because people just had lunch. I may have to ask for an energizer after this session to keep the teams going. I'll introduce myself. My names are Dr. Estella Birabwa. I work with the U.S. Department of Defense, and I'll be chairing this session on policies and programmatic implementation, focusing on the policies on civil society and human rights at large. There will only be one additional presentation on TB and comorbidities by Lillian Tugume in addition to the above. So allow me to get started. I hope that the IT team is ready. We will get started with Shamim Namponye, who will be presenting on improving tuberculosis diagnosis at private not-for-profit TB HIV facilities through strengthening collaborations with the district health teams in the Mid-North Uganda region at the UPMB supported sites.
Yes, thank you so much, Chair Dr. Estella. I greet everyone. Good afternoon, ladies and gentlemen. My name is Shamim Namponye. I do work with the Uganda Protestants Medical Bureau under the project Local Service Delivery for HIV Activity, supported by USAID. And I do work as a laboratory specialist, supporting lab services in the mid-northern region, that is Lango and Acholi sub-regions. We looked at improving tuberculosis at private not-for-profit facilities through strengthening collaborations with district health teams. A case in point, private not-for-profit facilities supported by UPMB in that region. Yeah, you cannot speak to diagnostic services and you don't speak to quality checks or measures put in place to ensure that we have quality results or quality diagnostic services. We have a number of programs to have a check at this, including external quality assessment schemes. Now for TB diagnostics, we have one of the assessments as TB blind rechecking EQA scheme. And by mandate, it is actually spearheaded or led by the district health teams, particularly speaking to district laboratory TB, district laboratory focal persons and TB leprosy supervisors for the different districts, where the DTLSs usually do sample slides from facilities under their districts with the corresponding results. They take these slides to the district laboratory focal persons for a first control, of course blinded from the results as picked from facilities. The DLFPs do the first control and then submit to the second controller, that is usually the National TB Reference Laboratory. So result feedback reports are sent back to the facilities with clear results showing whether you have actually met the standards of testing or not, and so prompt corrective actions. So you realize that it is very important to participate in these schemes because it gives an opportunity to identify or to detect as early as possible any deficiencies and weaknesses in the testing processes or systems at large. So what was the problem? we realized that between July, September, and October, December quarters 2022, we noted a significant drop in the participation of the supported sites in this particular scheme, and it was from 55% to 18%. So yeah, we could not sit back. We needed to investigate this because it would mean a very big impact in case we were having, false positives or false negative diagnosed cases in the TB control efforts. So these were the challenges that were identified following the root cause or the investigation that we did. There was over-reliance on GeneXpert testing. Basically, we all know that including GeneXpert sites, we expect some level of microscopy testing at these sites. So we realized that some sites were actually subjecting all the samples that were even meant for sputum follow-ups to molecular testing. And we also know that even non-GeneXpert sites are supposed to refer samples for molecular testing only after doing microscopy on them. We also had a challenge around scarcity of TB microscopic TB commodities. You may be aware that private non-for-profit facilities are supported by joint medical stores for HIV-TB commodities. Unfortunately, we do not have a vote, particularly for TB microscopic commodities at GEMES. So what is the practice? The practice or the system in place is that we get supported by the district health teams through redistribution from public sites to PNFPs. So this system needed a little more strengthening. We also had gaps in specimen and results transportation network because we know that for the slides sampled from facilities to get to the second controller, that is the National TB Reference Laboratory, of course they go through the specimen and results transportation network, that is the hubs. So at one point we realized that there were delays in conveying these slides to the second controller. Sometimes they even get lost. You cannot find what, like you call the facility, did the detailers reach you? They're like, yes, our slides were sampled. Detailers, did you submit the slides to the hub? Yes, we submitted the slides to the hub. You call NTRL and they were like, no, we haven't received the slides. So they get lost in the middle there. So we needed really tracking and monitoring to make sure there was a proper chain of custody for these slides to ensure that all our sites were rendered participatory or they participate in the AQA program. So to address all these challenges as LSDA, we aimed at strengthening collaboration with the key stakeholders in this program because you realize it is the detailers and DLFPs that are mostly dependent. I mean, they really have a very key role to play in this. They may determine whether your site participates or not one another. So what was our objective for this particular CQI program? We looked at, we wanted to improve the TB EQA participation rate in the supported EDTUs, that is Mid-Northern region, from 18% to 100% by September 2023. This was doable because there are only 22 sites by then that we were under our support. So yeah, specifically speaking to the objectives, of course, we wanted to see...
we have 1 minute to go. Sorry.
Oh. Yeah, what did we do? We really engaged the detailers to the maximum. This meant close communication with the DHTs. We collected all their contacts, email addresses. Like we used all possible communication platforms to engage them. We came up with an activity calendar, of course, to always check on the timelines for the activity. We discussed and agreed upon the expectations from both ends. What do they expect from us as the implementing partner, and what do we expect from them to meet the objective? We implemented strategies of the time sampling and control, but also submission to the second controller. We ensured that there were quarterly support supervisions made to the DTUs to correct any issues or to correct any issues in the testing systems. Yeah, these are the findings. Like we analyzed data, or we tracked the participation rates on a quarterly basis. Like I said, we saw a drop from 55% to 18% between the first 2 quarters. We improved to 77%, then 100% and the subsequent quarters. We believe that we can be able to maintain this, of course, by standardizing the interventions that we used. What does this implicate into the national TB leprosy response? Of course, this registered increase in participation rate definitely reflects a positive progress in the national TB leprosy response in Uganda. Of course, looking at the improved quality in TB diagnosis, enhanced monitoring and surveillance, enhanced confidence in the TB diagnostic services, enhanced sustainability of the interventions. We think this is actually a positive progress in the national TB and leprosy response in Uganda. So we also think that other regions might be suffering the same challenge, and we think this can serve as a model that can be replicated in other regions of the country. But of course, by picking up the lessons learned to inform the future interventions aiming at improving TB diagnostics and informing efforts for TB control. So this achievement underscores the importance of continued efforts to strengthen healthcare systems and enhance TB control efforts at both regional and national levels. This is an action photo. This is basically the Agago team. We see the details. Doing the exercise of sampling, but also the DLFP trying to do a mentorship with the lab team. And down here is a calendar that we invented to support in timelines. So basically, we do acknowledge the listed parties. Thank you so much. Over to you, Chair.
Thank you. Thank you very much, Shamim, for highlighting the way we were able to improve PNFP participation within the TB EQA scheme through engagement of the district health teams. This is a very important aspect of programming, especially as we talk about sustainability, but also the need to ensure that we deliver quality TB results to our patients. So allow me to call up the next presenter, Kasakaire Joel, who will be presenting on using quality improvement initiatives to improve pediatric TB case finding experiences from East Central Uganda region.
Thank you, Chair. Good afternoon, everyone. Joel Kasakaire is my name. I'm the Regional Quality Improvement Officer working with the USAID Local Partner Services in East Central Uganda, being implemented by MJAP. That's Makerere University Joint AIDS Program.
Let's give the IT team a few minutes. They may be experiencing a small technical glitch. IT? Okay. So we'll give it a few minutes.
So basically, as the IT sorts out itself, we are going to discuss a learning from our region about how quality improvement approaches improve TB case identification rates in children and pediatric children. Basically, since morning, everyone has been talking about, children, how innovations are being implemented in that we can increase. So this is just, I think, a reminder to all of us that this category of group in line with case identification is quite challenging, both in TB and maybe also in HIV.
IT, can you just probably give him a laptop in the meantime so he can follow through with the presentation in the interest of saving time if we still have a technical glitch? kindly do share your laptop so he can continue with the presentation. We will follow through the discussion.
Oh,
And,
can I
if
use
you're able
mine?
to put up the screen
I
along
don't
the
know.
way, he will follow through. Thank you. Okay, Joel, over to you now.
Okay, thank you. We are, as Alion said, using quality improvement initiatives to improve pediatric TB case findings in the EC region. Colleagues, as you all know, globally tuberculosis poses a significant threat to children with around 1.12 million new pediatric TB cases annually, leading approximately to 200,000 deaths. That is according to WHO reports. And this diagnosis is hindered by challenges such as difficulty in obtaining respiratory samples, such as obtaining respiratory samples from younger children, atypical symptoms, and also, if you look basically in Uganda, TB case identifications reveals concerning statistics with 67 of cases reported, including 12% among children aged 0 to 14 years. That's according to the Quality TB Service Assessment Report in 2020. So in the EC region, during this quarter, October-December 22, we realized that 18% of TB case notification were reported among children and adolescents in our region. One of the contributing factors were low community awareness, lack of child contact screening, knowledge gap among health workers, in a bit of children to produce sputum, especially those under 5 years. So we implemented some of the innovations, some of the strategies. What we did, we supported the quality improvement team in our health facilities. We did what we call on-site mentorship and training on intensified TB case site findings. Then introduction of simple one-step stool testing via GeneXpert. This was for efficient TB diagnosis in this group. Then also we did what was SMIT process to generate TB line lists for effective community contact tracing. And also what we did what we call regular meetings and data reviews, and also community sensitization campaigns, heighten awareness on pediatric TB, emphasizing early detection and treatment. Next slide. So colleagues, as you can see the graph, quality improvements it's a process. We move step by step. So if you realize, October, December, we did what we call on-site. This is a cumulative data. We did what we call on-site mentorship. So from 21% to 83%, that is October to December 2023. Between October to December 2023, that's when we introduced the simple one-stool GeneXpert test for these children. Next slide. So in conclusion, simple and adaptable quality improvement test changes have a potential of improving TB case identification among children in rural Uganda. We ideally recommend scale-up of some of these interventions in the rest of the country. So I acknowledge the following: PEPFAR, USAID, Uganda Ministry of Health, then other USAID partners, Dr. Fred Semitala, Moses, and also allow me to thank also Dr. Mary Mudiope for the oversight supervision in our region. And tomorrow we are going to be with the team tomorrow in the East region. Thank you.
Thank you very much. So thank you very much, Joel. I like the fact that you've even shared the change package. So the TB program can go with this change package and share it across all implementing partners in the country, so that we can scale up what we know works with fidelity to have national improvement in our pediatric case findings. So thank you very much. Our next presenter is standing in for Henry Matende, but she will introduce herself when she gets up there to the podium. And she will be presenting on leveraging innovations to improve TB screening in intensive care units at Kabale Regional Referral Hospital. So I'll hand it over to you.
Good evening, everyone. Call me Apio Crispa, an ICU nurse from Kabale Regional Referral Hospital. This evening, I'm coming to present to you the topic of leveraging on innovations to improve TB screening in intensive care unit at Kabale Regional Referral Hospital. I thank you all for today. So the reason why we pick up this very topic was because of the first case that we diagnosed. That was in 2022 when we had just started our ICU. Introduction and research objects. Low TB screening at Kabale Regional Referral Hospital led to delayed diagnosis and treatment. Upon realizing this, the team implemented active TB screening to increase case detection through combination of interventions at ICU. The impact of the intervention yielded additional cases detected and initiation to treatment. So you get the first case that we diagnosed was not improving amidst the treatment that we gave, care and other things. So when we diagnosed the patient with the TB and we initiated the patient to treatment, the patient started improving. And that gave us the go-ahead to implement to make sure that all patients that we receive at ICU are screened so that we don't waste time and also to protect others from acquiring the disease. Design, method, and analysis. Customize the intensified TB case finding tools was used for screening all patients admitted to ICU with or without sign and symptom of TB to aid case finding activities. So in ICU, whether these days you come with symptom, whether you're coughing or not, because there are some patients that are not coughing, they're unconscious, it's hard to detect whether they are coughing. So we still screen them and remove sample for testing to be sure that we are safe as well. This was implemented in 1 year, 2023, then evaluated for its effectiveness compared to previous year, 2022. As I said earlier, 2022 was the time that we diagnosed the first patient in ICU with TB. So the whole year of last year, we were fully screening patients, and that gave us a lot of results and made us to actually realize that ICU also is one of the ward that needs serious screening, because some other part of the wards are not screening, or some of the patients are actually coming from not within our hospital. They are coming from far, so they come when they are not yet screened or diagnosed with the TB. All symptomatic patients were subjected to testing for TB with chest X-ray, sputum evaluation using GenExpert, MTB, ultrasound, and then urine TB lab for TB diagnosis and linked to detected cases to treatment. So these are the methods we are using to diagnose TB at ICU, using our physicians, Dr. Anne Marion, who help us so much in diagnosing TB cases and treating them. Implications for the national TB or leprosy response. The total number of TB cases detected during the intervention period were more compared to those in the pre-intervention period. Customization of screening tools aids case finding and reduces chances of missing cases in ICU, hence leading to early detection and linkage to treatment to avert TB-related mortality. So action photos, as you can see there, we are taking a sample that is preservative TB, and then that is the ICF tool that you have been using for screening. I want to take this opportunity to thank Kabale Regional Referral Hospital the NTLP, all funders of this conference, not forgetting our in-charge, Sister Doreen and Matende, plus our physician, Dr. Anne Marion, who were part of the team for this presentation. Thank you.
Thank you very much, Crispa, and a big applaud really to the Kabale Regional Referral Hospital team. I know the TB program has really been advocating for active TB screening at all entry points within our facilities, but seeing it happening at the ICU level is very impressive, and you could see that before and after studies show that there was an increased number of cases detected and linked to treatment. So very good outcomes of your study, and we hope that many of us can learn from this and we can move practice forward and scale it with fidelity. Thank you. Okay, so our next presentation will be coming from Gertrude Abo, and she will be presenting on the description of TB contact follow-up across the care cascade in 4 select regional referral hospitals within Uganda.
Good afternoon, ladies and gentlemen. My name is Gertrude Abo, and I'm a graduate of the Intermediate Field Epidemiology Training Program, and also a current fellow in the Advanced Field Epidemiology Training Program at the Uganda National Institute of Public Health. I will be presenting a group project entitled The Evaluation of the TB Contact Tracing Cascade at 4 selected regional referral hospitals in Uganda in the year 2022. Okay, so as alluded by the previous presenters, I will not really go in detail about our introduction on TB, but we are all aware that a quarter of the population is infected with TB bacteria, according to the World Health Report in 2021. And around the same year, the global TB incidence was approximated at 10.6 million people. And in the same year, Uganda's tuberculosis incidence was at 199 cases per 100,000 population. Okay, so to end TB, the World Health Organization put in place a strategy, that is the NTB strategy, which is targeting a reduction of TB incidence to 10 cases per 100,000 population. Central to this strategy is contact tracing, which involves a systematic evaluation of TB among close contacts of an index TB case, including relatives of the patient's social networks, and this basically aids in early diagnosis and treatment and interrupts the transmission cycle. So when we looked at the TB contact tracing cascade, during contact tracing, for each case that is identified, contact identification and listing must take place. And when these contacts are listed, we expect that the contacts are screened. And when these contacts are screened for TB, children under 5 years of age and persons that are HIV positive are expected to be initiated on TPT. This is a TB preventive therapy. Now, in addition, on the other hand, for those presumed to be for those presumed to have TB, laboratory testing and confirmation is done. And those that are tested positive for TB are later on initiated for treatment. So when we looked at the performance of the contact tracing cascade, we reviewed literature, and in 2021, about 58.5% of TB contacts had been investigated. And of those that were investigated, approximately 85% were screened, which was way below the required 90% national target. So we realized that information about the performance of the steps of the TB contact tracing cascade still remains limited. So we set out to document the performance across the TB contact tracing cascade for 4 selected regional referral hospitals in Uganda in the year 2022. We conducted a cross-sectional study in 4 selected regional referral hospitals. I don't know why my pointer keeps taking some time to reflect. Okay, so these study sites, one would wonder why we chose to concentrate on the 4 selected regional referral hospitals, but these were study sites and operational sites for the study investigators. Hence, we narrowed down to these 4. A picture here shows data abstraction. We basically abstracted data on pulmonary bacteriologically confirmed TB cases and their contacts from the unit TB and contact tracing registers. So in this picture are 2 members of the study team conducting data abstraction. So when we looked at our study variables, we basically collected data using a structured questionnaire embedded in Kobo Collect software. And the information we're interested in were basically the social demographic characteristics and some clinical information on the relationship with the index case, the HIV status, the TPT initiation and completion dates, as well as the treatment outcomes. So we analyzed, we basically summarized our participants' characteristics in using frequencies and proportions. So in our findings, in total, we had a total of 231 cases and 1,215 contacts that were linked to these cases. Most of these cases and contacts were in the age group of 20 years and above, and basically that meant we had a 94% cases and 47% of their contacts were listed. When we looked at the gender, majority of our cases were male and majority of our contacts were females. In terms of the relationship to the TB case, majority of the information that we selected or that we reviewed was basically we basically focused on household members who were primary contacts to the index case. Okay. So upon reviewing the data in these 4 selected regional referral hospitals, we realized that 32% had undocumented, of the contacts that were listed had undocumented HIV status, as shown below. And we also realized that 47% of the TB cases had their contacts listed, and these are some of the missed opportunities that we observed. And among the 491 index TB cases, I mentioned that 47% of these had their contacts listed, but then we also noticed that only 88% were screened.
1 minute ago, Gertrude, thank you.
Okay. So still in our findings, I really have it trouble. Okay. So of those that were screened, 21% were presumed for TB, and 98% of those that were presumed for TB, 98% of these were tested. Okay, thank you. So, so 98% of these were tested. Of those that were tested for TB, 10% turned out to be positive for TB. And of the 10%, 90% of them received treatment. And 37% were cured at the time of data collection. The other 63% were still undergoing treatment at the time of data collection. We also noticed that neither of the eligible clients were initiated on TB. You can see that of the contacts that were screened, those below 5 years and those that were HIV positive, none of these were initiated on TPT, which was really a cause, one of the gaps that we identified on this cascade. So what are the implications for the National TB and Leprosy Program? So we realized that majority of the targets were met across the 4 regional referral hospitals. However, contact listing and initiation still remains a challenge because we realized that less than 50% of the TB cases had their contacts followed up. And this finding is very low compared to the national target of 100% contact follow-up for TB cases. And also, in addition to that, this finding is not far from the 58.5% and 42.7% as revealed by the studies that were conducted in northern and central Uganda by a team of experts in our country. So this could be due to the fact that there is limited funding for TB contact tracing, as evidenced by TB unit in charges during the data collection procedure. We try to interface with the TB unit in charges to find out why this gap is there, and those were some of the few issues that were coming up. So we would really recommend we've recommended to the healthcare workers in these selected regional referral hospitals that they should continuously enroll eligible clients on TPT, but also in addition, for the Ministry of Health and the National TB Leprosy Program and other partners, we really recommend that we engage these health workers a little more in different activities in the field, engaging them and basically with an aim of strengthening contact listing and follow-up, especially in the rural areas and for these selected regional referrals that are up-country. We also think that we conducted a cross-sectional study which may not be detailed enough because one of the limitations of our study was some missing data in most of the unit TB registers. So this means that we couldn't really make a conclusive statement out of this entire study. However, we would be excited to have a little more support to do a more detailed assessment on the patient enrollment on TB preventive therapy. Thank you so much for listening. I acknowledge the following partners.
Thank you. Thank you very much, Gertrude. Thank you. Thank you for that presentation. So I will call up Samson Omongot, who is going to be presenting about a very interesting topic because currently there's a national drive to really focus on improving the health of youth and adolescents. And he will be presenting on strategies to resolve the gap in adolescent tuberculosis care at 4 health facilities within Uganda, the Teen TB Project. We look forward to hearing more. IT, I think we're still having a problem with the remote. If you can help us move it faster, for the teams to move faster. And Samson, we have 6 minutes, so we'll be timing that. Thank you.
Okay. Yes, good afternoon, everyone. Yeah, those are my names, Samson Omongot. I actually work for Makerere University, where I'm attached to the College of Health Science, Department of Medicine, but also a research fellow in the Lung Institute. And so we are going to talk about strategies to resolve the gap in adolescent TB care at 4 health facilities in Uganda, and we called it the Teenagers Pilot Project. So when we looked at the literature, and this study was actually done jointly with the Lung Institute, but also we did the National TB Leprosy Program. And it was a pilot that was supported by Makerere University under the Research and Innovation Fund. So in 2021, we realized that there was a global that outcry of so many cases that came up with TB, like 10.6 million. But above all that, 1.2 million were children. And also, as if that is not enough, 40% of these were aged 5 to 14 years. And in Uganda, for instance, when we looked at the literature, 44% of the adolescents were, with chronic cough of 2 more weeks, did not seek health care. And so we came up with the idea that why don't we come up with some innovation? And so we came up with strategies to try to resolve this gap. And so that is why we piloted this study. So what was our method?
3 minutes to go.
Our method was a before and after design. Yes, so we collected data before the intervention, since it was an interventional study, and then also after. And it was human-centered approach where we involved the adolescents themselves in developing the package. We involved the health workers, the caregivers. So we had a designing company that together with the adolescents designed the package. And so the package was implemented in the 4 health facilities, Iganga, Gombe, Chioko, and Kaolo. Of course, they were purposefully selected given that they had the diagnostic centers and even treatment centers for TB. Then we collected data for social demographics, clinical characteristics, and then, of course, the before and after intervention data that I previously talked about. So these were the findings. Altogether, when we registered the adolescents that turned up that time, we had around 394 adolescents that were enrolled. And then what we realized was that, because the whole idea was, how do we bring the adolescent to the facility? So we realized that in terms of screening, there was almost a twofold after the intervention. And then when we looked at the presumed, there was also like a more than twofold increase. And then the ones that were tested, because they were now following the cascade, there was a more than 3% increase. So despite the fact that we registered a few number of those that were positive, which of course were linked to TB care. So that is the overall graph that tries to show what was actually happening before and then what happened after. And you can clearly see how the intervention impacted the program. Yeah, so in terms of the implication to the national TB, we are saying this human-centered approach could be something that would be bought everywhere, because then we realized it was good when you normally do a program and involve even the people you want to intervene. So adolescent-friendly health services is one of the things that the health workers were trained during the time we were getting into the intervention, and it worked, that whenever the adolescents are received, they can be able to be motivated to go for services. And then we also recommend, this was a pilot study, that we could probably have a robust one where we could assess, because then the challenge was, this was done in 2021, 22, and that time we had COVID, so most of the other interventions that we wanted to run, we were not able to run them because of the restrictions. So you can see that is how the adolescents were engaged, the other picture, and together with the design, the team of the designers, and then you can see also health workers being taken through the training in terms of friendly services for adolescents, but also how to capture the data, because this data was captured and sent to the server that was in MLI. So I really want to appreciate the Minister of Health, the National TB Leprosy Program, Dr. Stavia was one of the investigators, Professor Bruce Chirenga, and then, of course, the rest of my colleagues, Dr. Winters, Irene, Dr. Stavia, myself. So, and then also the facility teams, the health workers, actually the research assistants, the volunteers, all who helped us. And of course, not forgetting Makerere University through the government of Uganda that provided the funding. Thank you so much.
Thank you. Thank you very much. Thank you, Samson. And I think I picked your statement that 76% of your youth were school-going, highlighting the fact that we need to have more school health approaches in the multi-sectoral response to NTB in Uganda. Allow me to invite our last presenter, who is Lillian Tugume, and she is presenting on baseline cytomegalovirus viremia, which is associated with long-term increased incident TB disease and mortality, data from a prospective cohort of 497 Ugandan adults. I'll hand it over to you, Lillian.
Thank you. This is a little divergent from what we've been listening to, but I'll try my best to make it policy-friendly. So I'm Lillian, as introduced, and I'm a physician at the Infectious Diseases Institute, and I'm presenting this work on behalf of a large group of researchers and clinicians who have 2 decades history of looking at patients with advanced HIV disease, and TB is one of the opportunistic infections of interest. So today I'm going to talk about one risk factor that we have identified in our long-term cohort of incident TB disease, and probably that will be an opportunity for prevention in the future. So we know that co-infections are common in advanced HIV, and of course TB is one of the common opportunistic infections, and we've come to know that other infections like Cryptococcus, CMV are all quite common. And there's a hypothesis that people who get CMV, their immune system is activated towards a particular pole, which is type 1 interferon, and this kind of dampens the immune system that is supposed to control TB. That's the type 2 interferons. And so it's a hypothesis that this could be a risk factor for patients with advanced HIV to develop TB when they've had CMV before. So we decided to look at that. We had a cohort of advanced HIV disease, but we used patients with cryptococcal meningitis, because that's the cohort that we could access over about a 10-year period. And patients were followed out for about 2 years, and our outcome of interest was incident TB and all-cause mortality. So we were able to enroll around 497 Ugandan adults, mostly a young population, mean age of 35, and with very low CD4 counts at a median of 18. And of these, 20% developed incident TB during this period of follow-up, and unfortunately 29% died. So getting back to CMV, we found that more than a third, nearly 40%, had concurrent CMV viremia, and it was positively associated with higher HIV viral load. And so participants who had a CMV viral load more than 1,000 had twice the risk of incident TB compared to those with low-level CMV viremia or who did not have CMV. Important to notice that there was no association between the serology test, that is CMV IgG serology, and incident TB or death. So what does this whole CMV mambo-jumbo mean to the TB leprosy response? So TB preventative therapy for hospitalized patients with advanced HIV disease, we believe, should be strengthened, including with those people who come in with opportunistic infections other than TB. In fact, our group is currently implementing a randomized clinical trial called the IMPROVE RCT, where we're basically evaluating 2 strategies for TB preventative therapy among these very sick hospitalized patients who often have so many infections going on, and they have a high medication burden. And so clinicians are usually reluctant to start them on TPT, in addition to the other medications that they have. So we are testing an early strategy of initiating them on TPT within 2 weeks of hospitalization versus initiating them, a delayed strategy, initiating them about 6 weeks later as outpatients. And these results are expected early next year, and also hopefully we'll get a chance to come and present them to this meeting next year. Thank you very much.
Thank you, Lillian. Thank you for that presentation, and indeed showing a very high mortality of about 29%. But thank you all for listening in. We will take a few questions before we close this session. I will ask Jasper to check the online and see whether we have many questions coming through. But over to the audience for more questions, to the whole team of presenters. Thank you for the excellent presentations, and we look forward to hearing from the audience. Okay, so there's a question over there. You can stand up. I don't know if you have a microphone, but we can go ahead.
Yes, thank you, Chair. My name is Paul from Yumbe. My question goes to Shamim. I need to inquire more. You tell us what was the pass rate of EQA TB, because you told us about the uptake, which was really very good. And then two, I am suggesting that don't you think if we innovate a system of also giving certificates, as it's already being done on TB EQA, will it also improve on the uptake of EQA for TB? Thank you.
Thank you so much. I'm James Alenaitre from Mackay University Langa Institute. My question will go to Madame Abo. It's about, she talked about contact tracing of TB index contacts. But the issue of how long do you follow up of these contacts was not kind of clear, because if you follow them up, either the family contacts or social contacts, and they are negative, what do you do next? Do you follow them up for some particular point in time, or do you stop from there? Thanks so much.
Thank you. Any other questions coming through?
So there was just one question online for the team that presented from Kabale Regional Referral Hospital, and I think they were asking for clarification on your results, particularly regarding the numbers.
Okay, thank you, Jasper. So I will ask the team to respond in order of the way the questions were raised. Thank you.
Yes, thank you so much, Paul, for showing some interest in my presentation. Yes, you asked a question about pass rate, that it should have been better if I'd input the pass rates into my presentation. Yeah, but we concentrated on participation first, because we know it all begins with participation, that we are able to identify, any deficiencies or weaknesses with the testing systems that probably inform corrective actions. But it's important, usually maybe next time we shall get an opportunity to present you the pass rates for the region. Then a recommendation around awards in a way to improve as a strategy to improve the participation into the scheme. Yeah, of course, this is information to the policymakers or maybe other stakeholders into the program, that is National TB Leprosy Program. I think it can be a good thing to be taken up. Thank you.
Thank you.
Let me clarify. Out of the numbers that I'm going to give the numbers diagnosed in 2022. We diagnosed 1 out of 56 which were screened. And then last year, 2023, we diagnosed 5 out of 63 which were screened. Thanks.
Thank you. Thank you for that clarification.
Okay, thank you so much for the question on, I think if I got it right, how long do we have to follow up contacts? And on the event that they tested negative, what do you do next? I think basically what my understanding is about the contact tracing cascade is basically contact tracing itself requires physically visiting the homes of some, or households of some of these index TB case patients, and then being able to list all household members that are linked or connected socially to this index case. On the event that you identify any HIV positive persons or individuals within the household, then these individuals need to be initiated on the TB preventive therapy as soon as possible, according to the World Health Guidelines. Also, in addition, if this household involves or includes children under 5 years, these two need to be included and initiated on TPT. However, as I mentioned earlier, this was a cross-sectional study that was that involved retrospective review of records in the year 2022, and basically our focus was on the index patients that were already listed in the unit TB registers, as well as the contacts to these cases. So our main aim for this study was basically to highlight the gaps identified at each step of the cascade. And one of the main gaps was that contact listing and initiation on TPT was a major challenge. So our recommendation at that point to the healthcare workers at the level of the regional referral hospitals, we actually interfaced with the regional TB focal persons and tried to share this information with them. And the challenge had basically been in the area of facilitating some of the contact tracing teams to follow up on some of these cases. So we had cases where contact follow-up was not fully done, and for that reason we had some loss to follow-up cases. But again, as I highlighted earlier, one of the limitations we had was we had a lot of missing data, especially on the contact TB registers. Thank you very much.
Thank you, Gertrude. I'll probably also share my last comment, and it links up to your presentation on contact tracing and follow-up. We all know that contact tracing and follow-up is very important for early case detection, but also interrupting community spread of TB. And when you presented, I thought about how best we can interface with the AIDS control program, especially when the comment on financing came up. I look up to Prosi in this room because she does support the TB program in terms of being a major interface between the TB program and the AIDS control program. We know that the AIDS control program is currently rolling out the integrated community service delivery model. Is it possible for us to advocate Prosi with the AIDS control program to ensure that contact tracing and follow-up is added as an intervention even as they continue the follow-up within the communities? Because we know it is a funded intervention, but just adding this one intervention to the package may actually improve our case finding within the community and improve the quality of those that we serve. So that's one of the comments that I'll make. And thank you so much to the panel here today, the team, for the great presentations. We hope that the best practices that have been showcased and shared will not stay in this room. I look up to Raymond in the corner. But we hope that this will be scaled up because we know what works, and we simply have to scale it up with fidelity to continue to end TB in Uganda. So thank you, everyone, and do have a good afternoon. I hand it over to Jasper to invite the next panel on board. Thank you.
Thank you very much for that very insightful session. Are we ready for the last session? Are we ready? Yeah, I think I can be a pastor. Energizer? Oh, we power through. So we started with a capacity building session on health economics, and we're ending again with health economics. So our last session is on cost effectiveness, costing, and social protection. And this will be chaired by Professor David Chitara, the former chairperson of the Country Coordinating Mechanism Global Fund and lecturer at Gulu University, alongside Dr. Raymond Biaruhanga, who's a senior technical advisor, Global Fund, USAID at the Ministry of Health. I've given a very brief introduction, but before we invite the speakers, you could introduce yourselves a little bit more, and then our speakers get ready for the last session.
Thank you very much. Good afternoon. Good afternoon. Yeah, I know it's late, but I and Raymond will make it very interesting. I'm Professor David Kitara Lagoro. I work with Gulu University now, but formerly chair for the program oversight of the CCM, and also was chairing academia in Uganda. So today it's a great pleasure to discuss this very important subject matter on cost effectiveness, costing, and social protection for TB. But before we proceed, I would like to give the opportunity to my co-chair, Dr. Raymond Biaruhanga, to introduce himself.
Thank you, Chair. Professor David. Dr. Raymond Biaruhanga is my name. Purposefully today and yesterday I was quiet because I was really trying to synthesize and see what needs to be put together so that the TB program can be able to implement. And wow, there's a lot that is out there that we really need to put together. I work with the National TB Program as a senior technical advisor for the Global Fund and US government support. I'm glad to be part of this team and more importantly, to listen in and see what our colleagues on the ground are doing. Thank you very much and thanks for being part of this great work. Chair.
Okay, thank you. So without wasting too much time on this, something caught my attention yesterday. There is a phrase which was put here yesterday. They said, nothing for us without us. Nothing for us without us. This is such a powerful message that as we go to the last part of our presentations, we should be able to think about it, reflect on it, process it, and hopefully at the end of this session, we will have everything for us, for all of us. So with that, I would like to invite the teams that are going to be presenting today. We would like you to come on up here. So may I ask my co-chair to invite the team to come here.
Thank you. We'll start with Bate from MLI. Biate from MLI. We welcome. We also have Patricia. turi muho mahoro. Okay? Okay, Chihumro, my namesake from Mbarara University. Dr. Alan from MJAP, you're welcome. Mary Abuko from Kwam. Mary Abuko from Kwam. And Magomu from Rome. Magomu from Mbuya, reach out to Mbuya. So,
Your namesake is online and you're using
so I'm told Bernard Raymond is online. He will be presenting, and we hope Patricia will join us later. So, Beate, Raymond, Alan, Mary, and the Magomo, you're all welcome. I'll pass it on to the chair to invite the first speaker.
Thank you, co-chair. Thank you very much for this. Without wasting any more time, we would like to welcome Beat Ringwald to present to us very interesting research work conducting gender-responsive TB research in gender and equal world. That is a story, a critical reflection for research teams. Thank you so much.
Thank you very much,
You're welcome.
Chair. I'm presenting on behalf of the LIGHT Consortium, together with my colleague Dr. Windus Mutamba and Dr. Rachel Thompson. We have had a lot in the last few days, yesterday and today, that TB affects more men, but we also had in the recent session, if TB affects more men, that means contact tracing will be involve more women. So sex and gender analysis, highly recommended and often done in research, but more difficult is it to reduce the harmful effects of gender on health and on health research. LIGHT has been introduced earlier. It's a 6-year global health research program with partners in Uganda, Kenya, Malawi, and Nigeria. And today I present our internal reflections on what we have learned from doing gender responsive research in trying to include more men and having ideas for person-centered care models. Here's our journey. It looks linear, but it's a bit more iterative, going back and forth. So at the beginning of the consortium, we set for ourselves gender mainstreaming goals. These were focused on the research, but they were also focused on the consortium, and you will see that in the activities that you did. So we looked both at, we wanted to promote our junior female colleagues in the team to be first authors, to lead on research, to lead on projects, because they don't have often the space in research. But we also looked at who is missing behind in TB treatment. Every partner named a gender focal person, and we had to seriously engage ourselves with gender theories and frameworks and concepts. Although gender, it's not somewhere outside of us, we are part of it. Still, we need the right tools to understand the gendered world we are in, and we strengthened our skills to do gender equality, or to promote gender equality. The next one is probably the most obvious, but if you want to address gender, you have to disaggregate your data. So you have to collect data disaggregated by gender, and also maybe by age and other factors that you think intersect with age, with gender. We did that, and I'll come to that later, but it doesn't happen often enough. It's only about 50% of global health research articles that have gender disaggregated data, and interestingly enough, they are more often co-authored by women than by men. So we have a bit of homework to do that more often. We also assess the state of gender equality in our own institutions, and we are not, as partners in the consortium, we are not very different from other global health institutes that they are led often by men. And then we reviewed our approach to gender mainstreaming regularly. This is a bit of a busy slide. I tried to put everything on one. So what did we learn? First, we learned we work in a gender unequal world in all the 5 countries, including the UK. And depending on which gender indicator or tool we use, we find the differences between countries are bigger or smaller. But none of the countries, including the UK, has achieved gender equality. The next challenge we found is that we work in a very complex institutional policy environment. We do not only have our consortium policies and guidelines, we also have institutional, university, national, and so forth guidelines, and that makes it challenges to drive change on gender equality. There are good news. The Community Rights and Gender at Gender by the Stop TB Partnership and the Global Fund, they drive the need for gendered data and for solutions, so that gives us an opportunity to push this forward. In doing so, we have generated new evidence. I just give a few examples here. The papers are coming out. One is that we better understand the barriers to men's access to care. And we can't think of all men being the same, right? They differ by where men live, how old they are, their work, whether they are migrants, the language barriers that come with that. So there's a lot we learned from that. We tried to translate that into solutions, so we also developed theories of change and interventions that we want to trial. One of them is shown here. That's the IGNITE study that Dr. Jasper is implementing. We also tried new methods that enable us to better capture the realities of what it means to live with TB as a man, as a woman. So you see there a photo voice photo with a caption. And as a consortium, you can see there a commentary we wrote. When we think of TB and gender, it's not only about, it's not binary, it's not women. We cannot only focus on one gender. We need to make it work for all genders. What are the implications that we think are important for the national TB program? The gender norms and stereotypes, they affect everyone, women and men, boys and girls, and people of non-binary gender identities. And the gender inequities, they shape the TB epidemic, but also the health systems and health research, so that we have to look also inwards in the way we organize our own programs. We need an understanding of the gender issues within context. Gender manifests differently in different contexts. We need gender mainstreaming skills. We need a commitment. Maybe that's the most obvious, but it's an extra mile to go to do this kind of research, and that requires commitment, to be reflexive, and to engage with the people we heard about, the human-centered designs, and so on. It's an extra mile to go. And we think it needs multi-sectoral collaboration. It is not only TB. Men with TB also face other challenges, and therefore we need to be thinking of a multi-sectoral approach. Here you see the LIGHT Consortium in action. That was at a consortium meeting in Kampala. And here I would like to acknowledge our partners, funders, And thank you for listening.
Thank you, Beate, for that presentation on the gender responsive TB research. Next is Raymond ready online? Is he ready? So we can have Raymond present Beyond Health, exploring the economic sequelae of TB in southwestern Uganda, a qualitative study. Over to you, Raymond, from Mbarara University School of Science and Technology.
Thank you very much. Thank you very much, Co-Chair. I hope everyone can see my screen.
Yes, we can hear you. Go ahead.
My name is Raymond Bernard Gumoro. I am a volunteer at the AIDS support organization, TASO, Kampala. However, this work was done from Mbarara University of Science and Technology. Our work was basically exploring the economic sequel of tuberculosis from TB survivors in southwestern Uganda, and it was purely qualitative study. For the introduction, over the years, there's been improved TB treatment success rates, and because of this, we have often not put in mind the holistic healthcare management of these patients. Survivors often have issues with residual effects that tend to affect their lives, which could be just beyond the health that we always take care of when we are really managing these patients. So many patients actually tend to lose a lot of income, and these economic hardships tend to persist even after TB management. So we wanted to explore the economic consequences faced by TB survivors after their management in southwestern Uganda. And this was putting in mind that these economic hardships are also related to the ongoing health-related symptoms that these TB patients and TB survivors tend to face when they are having TB. This was a qualitative study which we were doing individual interviews, and we interviewed over 33 TB survivors who had cured from pulmonary disseminated TB. We used the purposive sampling technique, and we used interview guides, structured interview guides. Interview lasted between 30 to 40 minutes, and we collected data until data saturation. This interview was transcribed, coded, and then the data was analyzed thematically, where we got emerging themes. So from the analysis, we found out that the survivors reported increased financial demands, which were coming as a result of getting TB. Most of them reported that they had to change their diet because healthcare workers often advise that they have to eat well and have to step up their diet. Most of them also reported that they found it difficult to access medication and also to travel to the different sites to get medication, which often led to them having to dig deeper into their pockets to afford a cure, to afford management. Others reported that they had destroyed plans because some of them had plans to actually go back to school and pursue further studies for their careers. Others had entrepreneurial goals, but then when they got TB, all these had to be put on hold. And because they had to be put on hold, that means that they actually had issues later on. They didn't actually achieve their dreams, and this actually affected them. Some of the participants reported inability to work and loss of jobs. Many participants claimed that they were, because of the situation, because of them having TB, they had to be relieved of their duties at their workplaces for fear of infecting other people, but also because of the stigma that came with TB. Others reported that because of the disease, they could not actually have the required health status. They didn't feel like they could work because they felt very weak, very lazy, not lazy, very weak, and unable to actually conduct their duties as before. And this led them to not being able to take care of their families because they were not earning, and yet their families had to survive. Then the fourth theme was compromise family care, like similar to the third theme, because survivors could not take care, were not earning actively any active income because of loss of jobs and because of failure to actually meet the standards that are required by their workplaces. They often never had the money that was required to take care of their families. And this led to failure to take care of their basic family needs, and due to the lost income and also the ongoing increased lifestyle expenditure because of them having TB, and which actually have impacted them not only economically but also impacted them mentally, because some of them ended up being depressed because they were worried about the fact that they could not take their children back to school, they could not pay rent for their families, and they couldn't even afford basic meals for their families. So the implications of these findings onto the national TB stroke leprosy response calls for perhaps a need for a better supporting program that does not only focus on TB treatment, but also could include the post-cure support. As I could maybe give an example, one of the other things that came up during the interview is that the participants who reported having gotten some support financially to roll them out through the medication actually say that that was very helpful, and it helped them keep afloat economically and being able to support their families as well as their loved ones. So I believe that this could be a start to just inform and perhaps stimulate better, more research, but also better programs that could focus on holistic care of TB patients in the country. Then also, I believe that this could also stimulate the need of a partnership approach whereby healthcare of TB patients is not only left for only the health facilities or the hospitals that actually give the medication, but we need also to bring on board the different non-government organizations, the CSOs that are actually concerned, are interested in TB, and also the different policy makers that together, when we are working together, we can have and find holistic, everlasting solutions to these economic implications to the people who end up getting TB in the country. There's also need of economic empowerment programs because most of these patients, for example, those who lose their jobs and are not able to, they're not able to take care of their families, or perhaps they afford the increased expenditures due to having TBs. Perhaps we could think of other ways which could be sustainable that empower them economically to be able to generate income beyond the normal or conventional ways that they're used to. So we need to integrate economic and employment assistance into these TB recovery programs, and also perhaps advocate for policy changes to mitigate a long-term economic impacts on TB survivors. I would like to acknowledge and thank, of course, the Impact U team with which we worked with the participants, and my study team that was composed of Dr. Timothy Chinkumaje, who presented our findings yesterday at around 11, Dr. Mike Semusu, Dr. Stella, Dr. Peggy, and Dr. Edwin Mwaju. Thank you very much for listening.
Thank you, Raymond. Thank you for that wonderful presentation. If I may summarize and say, there is need for post-cure support to TB patients. And then secondly, we need an holistic approach to this by having partners joining together to support patients who have been cured of TB. Ladies and gentlemen, let's give a round of applause for his presentation. The next presentation will be the cost comparison of delivery strategies of the 3 HP and 1 HP. Dr. Alan Musingoze, the floor is yours.
Thank you. I'm Alan Musingoze, and there was a little bit of confusion with the title, but the title is Cost Comparison of Delivery Strategies for 3 months of isoniazid rifampicin among people living with HIV, not comparison between 3 HP and 1 HP. And I'm presenting this on behalf of the 3 HP Options Trial team. So the 3 HP Options Trial recently demonstrated greater than 90% completion of 3 HP at among 1,656 participants enrolled in care at the Mulago ISS clinic under the Makerere University Joint AIDS program. This trial employed 3 delivery strategies of 3 HP, including directly observed therapy or DOT, where participants came to the clinic every week to take their treatment, self-administered therapy or SAT, where participants took their first dose from the clinic. We packed for them their next 4 doses, that is dose 2, 3, 4, and 5 to take from home. They came back to the clinic for dose 6 and received the refill for the next 5 doses, doses 7 to 11, and returned to the clinic for the final dose, dose 12. And the third delivery strategy was an informed patient choice between those 2 strategies. However, as we know, we have a limited resource envelope, and therefore the cost is always a major consideration when considering or choosing how to deliver and scale up this TPT, especially in our high burden settings. So our objective was to enumerate and compare the costs of delivering 3 HP across the 3 delivery strategies. So these were the components of our 3 delivery strategies. Across arms, we had standardized pre-treatment counseling. The clinic visits were streamlined. We had dosing reminders for both participants in DOT and SAT. Travel cost reimbursement was provided for all 12 clinic visits for participants in DOT and only for visits 1, 6, and 12 for SAT. We monitored side effects for DOT in person, and for SAT we used a system called 99 Dots, which is a digital adherence technology, and it sent out automated interactive voice response phone calls, which enabled our participants to check in if they were not feeling well. And adherence documentation was it was done by direct observation for DOT, and we used 99 Dots, whereby participants used to call in every week from home to confirm dosing, and a phone call that came through was recorded as a confirmed dose. And for the informed choice, as I said, participants chose between one of the 2. So this was our trial design, which I'm not going to linger so much on. But this is how we collected the data. We collected the costing data from both the patient and health system perspective. So at enrollment, we collected a detailed costing survey for all the 1,656 participants. And at dose 6 or week 6, we conducted a shortened costing survey with a subset of 50 participants per arm to look at how their costs had changed during, during their stay in the study. We conducted time and motion surveys. We logged time requirements for staff, for clinic staff as well as study staff, and also conducted budgetary reviews. These were our results. So the total, we are displaying or illustrating our costs here as stacked bar graphs, which are a little bit hard to see. The first, or the stacked bar chart on the left shows the costs for DOT. The one in the middle shows costs for SAT, and the one on the left, on the right, shows the cost for informed choice. So the total costs, as you can see, if you're looking at the color codes from the bottom, represent cost for study drugs, transport reimbursement, the 99 Dots digital adherence technology platform, costs of human resources, other health system costs such as admin overheads, then participant costs such as wage loss, work cover, and other participant costs such as the costs of food when coming for clinic visits. So the total cost of facilitated 3HP per participant who completed treatment in the directly observed therapy arm was $135. It was $64 per person in the self-administered therapy arm and $117 per person in the choice arm. The health system cost of facilitated 3HP, and in this case we considered the cost of study drugs, transport reimbursement, 99 Dots, human resources, and other health system costs as the health system cost component. So for directly observed therapy, the total cost, health system cost was $107 per person. Self-administered therapy was $56 per person, and choice was $91 per person who completed treatment. The major drivers of these costs, as you can see, the health system costs were transport reimbursement and drug costs, which are significant because these are modifiable, as we don't usually provide transport reimbursement for our patients in the program, in the routine programming, and the cost of 3HP has also since reduced due to increased uptake by national programs. So this means that by now, these costs are even probably much lower. And participant costs, which are highlighted in red there at the top, for directly observed therapy, it cost about $28 per person to complete treatment. For self-administered therapy, it was about $8 per person to complete treatment. And for informed choice, it was about $26 per person to complete treatment. And the higher cost for the directly observed therapy, as I said, was most likely due to the increased clinic visits, because participants in directly observed therapy had to come to the clinic every week to receive their treatment. And the largest cost drivers here were wage loss and work cover for participants. So what are the implications? We found that facilitated self-administered therapy achieved similar outcomes as facilitated directly observed therapy at half the cost. And this difference could even be lower if in clinics which are closer to participants' homes. And we also say that the reductions to the price of 3HP are essential. And when planning for 3HP scale up and delivery, the additional cost of facilitation to achieve high completion should be included in implementation budgets. And we also found that shared decision making, much as it was a little bit more expensive than self-administered therapy, it was feasible to implement at a low cost. These are pictures of the study team. And I'd like to acknowledge the study team here. And this research was funded by the US National Institute of Health, the National Heart, Lung, and Blood Institute. Thank you very much.
Good. Thank you very much, Dr. Alan and the team from MJAP. We can see what it means to provide, different delivery strategies and the economic advantages of some of them, especially the self-administered, drugs. We shall have next is Magomu from Mbuya, reach out to Mbuya, who is going to be talking to us about utilization of the private for-profit facilities to search TB screening, diagnosis, and treatment among the urban population in Nakawa division. Over to you, Magomu.
Thank you. Thank you, Dr. Raymond and the chair. So I'm Dr. Magomu Moniru. I work with Reach Out Mbuya under the Kampala HIV project. So I'll quickly take us through this. I understand we are all very tired. So we are basically looking at the utilization of PFPs to search TB screening, diagnosis, and treatment within the urban population in Nakawa. So the health facility census report within the KCCA divisions showed that within Kampala we have about 1,500 facilities. 94% of those facilities are private for-profit facilities. So within Nakawa division, we have about 297 facilities, of which almost just under 95% are also PFPs. 10% of those actually offer TB HIV services, and we only have one which is accredited as a diagnostic treatment unit within Nakawa. So this actually shows you that TB HIV services within the private facilities are actually at a very low. So the data coming from those facilities actually shows that there's suboptimal TB screening. Most of clients are treated for respiratory tract infections with antibiotics. And then there's suboptimal linkage of HIV positive cases within those private facilities, which is our closest proxy for advanced HIV disease. So we set out to determine prevalence of TB disease at one of the private facilities within Nakawa division that is actually attached to a government facility, and then to also determine the treatment outcomes at that facility. So it was a cross-sectional study, and the methodology, so we basically, like I said, we used UMC Victoria University as our study point, and our target population was the outpatient and inpatient population at the facility. So in our findings, they were able to identify 35 TB cases across from December 2022 to December 2023. 89% of those were bacteriologically confirmed, 2 were clinically diagnosed, and 3 had extrapulmonary TB. We had more males than females. All of them had a documented HIV status. The TSR was unfortunately very low, 76%. You had a loss to follow-up rate of 5%, and a death rate of about 18%. So they had a number of challenges. The figures we're actually seeing here, there's a bit of, they had a time where they had a lag of about 5 months where they were actually not offering these services. So we believe that these numbers are actually higher than these. They have obviously a number of challenges that affect PFPs within our country. So what are the implications on for the national TB and leprosy response? So we realized that there's a high incidence or prevalence of TB amongst the urban population of Nakawa. Obviously, a couple of years ago, with the migration of HIV/TB services from the PFPs, created a very big gap. So you find that at this particular facility, you have, I think they have a weekly average of about 500 plus clients that go through their OPD. So actually, PFPs, based on this data, actually present a very good opportunity for us as a program to increase coverage for TB-related services like screening and treatment monitoring that can feed into TB pandemic control by 2030. So there is urgent need to build and strengthen the public-private partnerships, because there's a subpopulation of people we are ignoring in our quest to end TB by 2030. So I do believe most people here actually go to private for-profit facilities for any medical issues. You realize that most people here, even if you had a cough for more than 2 weeks, very few of you are offered a gene expert test, because the facilities we use actually do not actually have this service. So allow me to acknowledge those groups, or those groups of people to reach out, PEPFAR CDC and NTLP, plus the facility where we conducted this. Thank you very much.
Thank you very much. I'd like to give another round of applause for Dr. Muniru for the wonderful presentation. Ladies and gentlemen, we've come to the end of our presentation in this session. And if I might just summarize the presentations and ask you to ask a few questions, I could do that at the end of this. So those who would like to have some questions, please feel free to raise up your hand and ask the questions. Yes, please. Can we have somebody to give the mic to the gentleman right there? So you have to be very specific, direct it to a specific person, and let it be to the point. It's right there.
Thank you so much, Dr. Jonathan Mulunji. This question is in relation to what Dr. Komagum has said. It's directed towards the co-chair. Now that Dr. Komagum has raised important points about the great need of probably availing anti-TB TB care services to the people who seek care from private facilities, how feasible is it that probably the Ministry of Health partners can be able to avail some of these services, of course, probably with proper training, to some of these private facilities where a bigger percentage of actually people in metropolitan Kampala actually seek services from. Thank you so much.
Thank you. Do we have any other question? Please, if that.
So I have a question to Dr. Musinguzi. My question is, I didn't quite understand what this facilitated choice is, because I thought the facilitated choice then ends up in either self-administered or facility-based. So I didn't understand why it had a whole costing all on its own. Yeah.
Next, please.
Thank you, Session Chair, and I want to thank the presenters. My focus here, I want to thank the only lady who presented about the gender responsiveness. Actually, I'm very excited with this. TB, we have not given a priority to gender sensitivity. I'll give an example. When we are making our key interventions, including the TB cast, there are some of those category of population we need to reach by their clusters or categorically looking at the vulnerability. And some of them, the data really indicates, like the Fisher folk, the vulnerability of TB is too high. And even the LGBT, we don't have the data. We don't know what is happening in that population. But if we could sample and give priority, those categories, the sex workers, it's very critical. I thank the presenter for bringing this out very well. Thank you.
Thank you very much. I think we'll return. We have one more. Yes, please.
Thank you. Mine is also in gratitude to Pete, if I pronounce the name well. It's only asking, maybe I missed it, to how you would take into account the fact that to a large extent TB in Uganda is a men's, it is our concern, more for men than women. How you took this into account in your presentation was not very.
Thank you. I think we've got all the questions. So, is there anyone online who intends to ask a question? Or has raised up to ask a question? If there is none, I think...
I might have a quick question for my colleague from Magum, from Mbuya. You know, some of the, not some, all private for-profit, though they don't want to call themselves for-profit, since this is an economic health-related activity, how do you balance between charging fees for some of these services, including TB, and making sure that when patients go there, they actually access the services that they want to access? Even me, when I go there and you start telling me I'm coughing and you want to take me for a gene expert, it's like you are telling me I have the disease, the poor. That is what many say. Because we have all gone around saying, you know, TB, the poor, they are the ones who don't have. So it becomes difficult for me or the health worker in a private for-profit facility to say, he has some money, he can access any type of care he wants. Now how can I tell him that he has TB? So that is a dilemma. But to quickly answer my brother there, the National TB Program has a deliberate move to reach private for profit. And we have a private partnership, private-public partnership advisor within the National TB Program that is squarely there to make sure that we scale up TB services in the private sector, both private not-for-profit and private for-profit, to make sure that we tap into making, we don't leave anybody behind, even those in the private sector. To the extent that we have been able to make sure that they access diagnostic services, where they have patients, they access drugs within the same facility so that they don't need to move around. Knowing that definitely the patients who go to the private sector, there's a lot of stigma, but also a lot of privacy that we really need to do. Kauma, I don't think it's only Uganda where we have men with TB. It's almost world over. So we really need to hear from Biate. How really can we handle this?
Thank you. So we did deliberately sample men. In some studies, we also sampled women because we wanted to understand where the differences are. And one difference, for example, is that women would talk more about how the virus feels in their body. And for men, they push that they have it somewhere outside their body. That was one observation. So how do we do that when men do not want to allow to associate with the disease? So we did qualitative interviews, we did participatory workshops where we invited healthcare workers together with men who have TB or TB survivors to understand how their journey to the health system was, to be able to identify the barriers and then design interventions. So we have 2 interventions. One we test it's facility-based that we test here in Uganda. It's the IGNITE study where we do targeted community awareness, where we do have male-friendly services, and we do screening at all entry points. And it has shown the intervention, it's a pilot, but we tend to see that we can increase diagnosis among men and women. The second one is a community-based intervention that will be conducted in Nigeria. It also is co-designed with men with TB, and I think that comes back to the human-centered design, and that's in response to what the gentleman said at the end, at the end of the room, that we need to look at different groups of men and different groups of women and how we can reach them. We know if we do door-to-door screening, we will find more women because they're more likely to be at home. So we need to think of strategies that are tailored to different groups of people, and how do we do them. I think Samson said it nicely with the human-centered or participatory co-creation ways of designing interventions. We will get their voices and what would work for them instead of us scratching our heads on how we can do that better for them. We can try to do it with them. Thank you.
Okay. The question about the facilitated choice strategy, what is it and why did it have its own costing? So for facilitated choice, participants could choose between directly observed therapy or self-administered therapy. So that means that the participants who are in that arm had they had both choice and SAT. I don't know whether that makes sense. And participants in that arm would choose. So we randomized participants to 3 arms: directly observed therapy, self-administered therapy, and informed patient choice. The participants in the 3rd arm are still in that arm, but they can take treatment either as directly observed therapy or as self-administered therapy. So when you're costing them, it means that it's an aggregate, because the figures I showed you are averages. Yes? So you have participants in the choice arm who had their treatment as directly observed therapy, and their treatment cost more. And then you have participants who are in the informed choice arm who took their treatment, who chose self-administered therapy, and their treatment cost less. So when you get that average, then that's why it's slightly higher than self-administered therapy, because we had more participants choosing directly observed therapy, and this was mostly because it was around the COVID period when many of our participants had lost their employment, and this participant reimbursement was sort of like an income. So it sort of biased their choices. I hope that makes sense. Thank you.
So, thank you very much. Round of applause for our panelists. Thank you very much. Thank you, participants. I think we've come to the end of these wonderful presentations by our team here. And first, I would like to thank my co-chair, Dr. Raymond, for always being there for the TB teams and also helping in coordinating these activities. I also would like to recognize the team from the Global Fund, the CCM. I am informed there is the chair for the Program Oversight Committee here. You be recognized for that. And I was also told that you represent the TB segment. So thank you. Doctors, thank you. We were able to hear many things. And some of the things we heard were that TB is more common in males. It's a very strong point. And Dr. Beats, I think I'm very impressed about the social aspect of learning a disease. Many times the medical field would like to look at only the biomedical, the clinical. We don't look at the social issues, and those might be one of the areas that we're missing out. And then secondly, I think our sex is in a way associated with these transmission processes. It may not be exactly that there is a typical relationship, but there could be something there which we need to explore. Why is it that we have more males than females? Have we ever thought about it? Okay. Yeah, so that is something that we will have to discuss about this. And of course, we need to do additional research, and research which are focused at identifying the drivers of TBs in our community, and also being able to look at specific gender theories that tend to make females less vulnerable or at risks. Maybe some of these qualitative studies will be able to bring out this. And I like the idea that we need to have gender disaggregation, aggregated data on TB, because that helps us to be able to know exactly where we're dealing with. And of course, the final bit is the multi-sectoral approach to TB management. Gentlemen and ladies, we need all of us to be involved. We need all to be involved in the management of TB patients, right from screening up to post-cure situation. And we learned that most of these TB patients, even after getting cured, they don't spend that long. They end up dying. What's the issue? Have we identified those issues? And maybe the Lung Institute would be able to give us this information. And then, of course, finally, I think the population of Uganda has grown so fast, and we have a very big population, and maybe the growth of our public health facilities are not matching the number of the population that we have. Infectious diseases, the identification should be allowed to take place in the other units like the private sectors. They might be if we help them with facilities, they should be able to help in subsidizing the cost of screening, treatment, investigations of people who have TB. Let us take infectious condition as something very serious, and so it should be a partnership between the government and the different sectors. With this, ladies and gentlemen, I'd like to take this opportunity to thank the National TB Program in the Ministry of Health, the USAID funded projects, and the other implementing partners who've worked tirelessly to make sure that this specific scientific conference or scientific summit is in this form, and we've learned a lot. I would like to take this opportunity again to thank my co-chair for doing a wonderful job, and all of you participants for being very good participants, and up to now you're still active. So finally, we thank the panelists. Thank you very much for the great work. We are closing here. Thank you very much.
Thank you for that. We've come to the end of the day, so what we are left with is the closing ceremony and the closing remarks. I'd like to invite my chair, Dr. Stella, to invite the dignitaries who are going to give us the closing remarks.
Thank you, Jasper. Okay, so we've come to the very end. Thanks for staying with us for 2 full days. We hope you have learned something. We hope you have been motivated. We hope that you've taken away something that will change your practice and something that will enhance your research if you're a researcher. So thank you so much to all our presenters, all our session chairs, all our sponsors. Thank you very much for these 2 days. We will have World TB Day celebrations next week. We hope to see everyone. But for now, this is part of the celebration of all the efforts to end TB, and we are making progress. So thank you. We've come to the end. Now I will invite 3 people to perform the closing ceremony. First, I will invite the chair of the organizing committee of this whole event, Dr. Simon Walusimbi, who was the chair of both the science, the technical, the administrative, all the committees. He was the one chairing and spearheading the organization of this event. Dr. Simon, please come up. I will also like to invite Dr. Paul Isiko, who is the Executive Director of the Uganda Stop TB Partnership, to talk on behalf of the Stop TB Partnership and of the civil society Because everything we do, remember the civil society says nothing with us, nothing for us without us. So everything we do is for the patients. Dr. Paul Isiko, please come up. And then finally, I'd like to invite Dr. Henry Luze, who is speaking on behalf of the Ministry of Health. The Ministry of Health is our guiding body. All our research is designed to make policies, and the Ministry of Health is the one in charge of making those policies and supporting us to implement them. Dr. Paul Isiko, please come and take your seat. Please take your seat. Dr. Simon Walusimbi, please take your seat. Dr. Henry Luze, please take your seat, and let us begin the closing ceremony. Okay. All right, so we also have an abstract book available. All the abstracts that you listened to these past 2 days are available online. They will be sent to your emails, and you will also receive an online address. I think, please, let's put it up, where people can find the abstract book. Second and most important, there is a QR code at your table. Please scan it and give us feedback about the last 2 days. We would like to know how to improve. So please scan that QR code and give us feedback. Please look out for the abstract book. You can refer to it. You can share it with your friends. You can use it to go through the presentations you probably missed, or the ones you had but you'd like to recap. Thank you so much. Dr. Harris.
Thank you, Stella. You invited me to but I'll use the podium, and then Paul, I'll invite you, and maybe invite Henry as well. Really, as chair for this event, I'm so thankful that we've finally seen it arrive. Sorry? No, I'm actually glad that we've come to the end. And I want to thank each one of you that has participated in the event, physically and online, for your participation. Our terms were kind of clear. Well, clear. We went sharpening them along the way. We were asked to set up a platform where we can present and discuss TB science that is generated locally, okay, and for the benefit of Uganda's TB response towards the national commitments for ending TB by 2030, and of course sustaining the leprosy elimination status. And I'm happy to have been a part of this sort of process. Maybe we thank each one of us with a round of applause, if that's fine. Yeah, I think we've achieved this jointly. It's not been a solo effort. I've had a very strong team of ladies and gentlemen that I will later ask to stand up for recognition. But when we were being given our sort of marching orders, we were informed that Uganda has a very high level of visibility in terms of research on the global scene. And it is high time that our patients benefited from participating in this research. And we are starting this today. I hope it is not the last. There was a team from Kenya which posed the question to me asking, is this the first and last? Fortunately, the commissioner was around, and she affirmed that we shall have another edition next year. So we've shown this is feasible and possible, and it should happen as requested by the stakeholders out there. I think we all agree that the quality of the papers that have been submitted is really world class. This is not something we can say it is national level material. We set out to achieve, at least in terms of the scientific products, something that can be showcased even on a global level. And I think you all agree with me that this has been achieved. Thanks to the members of the various committees. We had a very strong steering and advisory committee. Raymond, I missed introducing you on Monday. Raymond was always checking on me every evening. Yes, what is the problem? What do I need to follow up? So thank you for your availability. And your support, of course, has come to be showcased today. I see Paul and Henry are also here. In fact, every member of the committee, if you are around, I don't want to make the same mistake, Mary. So I see Mary out there. I see Jeff. Please stand up, at least for a hand of applause and recognition. Yes. So these are the ladies and gentlemen that have been behind this, and I'm thankful for having been at their front. My prayer on behalf of the organizing committee is that, of course, we have this next year, but we escalate it down to the regions, Raymond and Henry and Paul. If we can have this pushed down to the regional levels, so that we cultivate a culture of really doing this science at the sub-national levels to inform health programming. So that is my prayer to the steering committee, to have this materialize at the sub-national level. On a personal note, I look forward to the second edition of the summit, and I hope we shall all be available, produce quality scientific products as Stella summarized in her presentation, so that I don't know if this has happened in any other country, Raymond. Normally Uganda we always set the pace, but somewhere. Sorry? Yes, that's the problem. I hope we shall break that culture. But as far as I know, this is the first national TB program and leprosy-led science summit, at least on the African continent. So we have done it, and we should keep doing it. And I think everything should be possible given the blueprint that we have set up. I want to end there, of course, with a remark of thanks to every one of you. But at this juncture, I wish to invite Dr. Paul Isiko, who is the Executive Director of the Uganda Stop TB Partnership, and who has been behind the resource mobilization, of course, together with the program, to have us sitting here. Paul, if you can come to the podium. Thank you very much.
Yeah, thank you so much, Dr. Simon Walusembi. I call him Doctor, not by mistake. You know, many of us are doctors, but for him he has a PhD, so those who get PhD, they are called doctors. So since he was a doctor before, I add on another doctor. Yeah, ladies and gentlemen, we have come to the end of our 2 days of this summit. And in your different capacities, without really mentioning the different titles, because each of you has a title. And I'll leave it at ladies and gentlemen. My name's Dr. Isiko Kawanguzi Paul. I'm the Executive Director of Uganda Stop TB Partnership. Allow me to thank all of you for honoring our invitation to come in large numbers. We got 100% participation, which is at a very short notice. We are really very sorry that the notice was so short, but I think we had already given a hint that we would have this symposium or this summit. At least you were aware, but we had not given you the venue, but eventually it came to pass. So thank you so much. Allow me to thank. Actually, I'm going to do more thanking than anything else. You know, yesterday Dr. Oraros told us that when we were in Paris, I remember, I think I missed out in that meeting, there was always a Ugandan caucus during the Union conference. And this was conceptualized that we should have our summit. And I see it really having a resemblance of the Union conference. Can we clap for the organizers? And I want to actually clap in a special way for Dr. Stavia, because she believes and she energizes us. She makes us believe that we can do it. And you know, with Dr. Evelyn, I don't know whether Dr. Evelyn is around. Yeah, she really gave us the move, and thank you, Dr. Simon, for accepting to take the lead, because we didn't know how to handle it, but with all your exposure and what, you were able to take the lead, and thank you so much. This gentleman here, his energies in the last 2 months, I can't define them. Actually, on Sunday, he literally slept in this room, making sure that everything is right. And give him a special clap. Thank you so much, Dr. Simon Wallace. Jeff, are you there? Yes. Can you give Jeff stand up? Jeff was sending out all the mails, all the communications, and reminders, the minutes, working together with the Queen on a daily basis, and the calendar invites. You can sit down. Thank you so much for giving us the energy. There was a lean team that prepared all this. I may not exhaust the names, but for those, you know I'm very poor at names, but allow me to thank Dr. Mary. Dr. Mary, stand up in a special way. Dr. Stella, where is Dr. Stella? Jasper. Wow. Oh, of course, Dr. Henry up here, Dr. Raymond there, the USAID team. Really, the team has, I think, Dr. Walusimbi has already introduced the whole team. Allow me at this juncture thank the without Global Fund, we wouldn't have had this wonderful venue. Madam Sentongo, can you, Harriet, stand up? That lady, I was calling her every minute, where is my venue? And she delivered. Clap for her. She is from TASO. TASO is our principal recipient for Global Fund, and they secured for this wonderful venue, and we are quite very grateful. The project coordinator, Jackie, had actually promised to be here today, but I think she got caught up, but she's ably represented. You pass over our regards to her, Dr. Gesa. We kept calling him every minute, and really, and the procurement team. We kept calling them even at midnight, but they delivered and we are quite grateful. The IT team, you've done a wonderful job. You've actually surpassed my expectation. And thank you for the people who recommended you to us. I think, to me, you've done a wonderful job. I've been always going online to see what's happening there, YouTube, and everything is very clear. I believe you all believe in me on that. Okay, having said all that, and having enjoyed these last 2 days, I hope all of you have registered very well on our attendance lists. And Zahara, stand up. That lady has done a wonderful job. All the mails you are receiving were from Zahara. All the SMSs from her. Thank you so much. She's been leading that team there. So please, as I end, I hope you have registered well. I know that, there was a cost to your coming here and your stay here. Please, your facilitation will be received through mobile money in the next few days. Thank you for listening to me. Okay, I've been given another role. I hope I can fit in the shoes. The chief guest for us this evening is Dr. Henry Luze, who is the deputy to the program manager, who is still engaged somewhere. And Dr. Luze, it's my humble we had expected actually the Director General to be here, and had actually confirmed, but he has been caught up with a few things, and his sense is sincere. I believe he will deliver that. So Dr. Luze Henry, please, you are welcome to the podium, representing the Director General, to deliver his remarks. Maybe deliver your own remarks as from the program, then deliver his remarks and close the summit. Thank you.
Thank you very much, Dr. Paul Isco, for ushering me in. It feels like an afternoon of a Friday, but it's actually Tuesday. I've been reminded. First of all, my name, for those of you who are not so familiar with me, I'm Dr. Henry Luze, Assistant Manager with the National TB and Leprosy Program. I want to, first of all, bring apologies from the Director General of Health Services. He was actually supposed to be here to do this closure, and initially we had communicated 4 p.m. But as you can see, it was not possible for us to finalize the program by 4 p.m. So we said 5. Then at 5, he had been engaged into another meeting and he couldn't come. So he sent his apologies. Then our manager, Dr. Stavia, some of you have already noted that he's been away in Mbarara on the inauguration of the Mbarara Regional Referral Hospital Board as one of the board members. So she also could not be here. They sent apologies, but they didn't send me any words to say. So these are going to be my words of wisdom. To all our partners and stakeholders, I want to specifically mention World Health Organization, USAID, CDC, among others, the civil society organization, Makerere Lung Institute, and all the academic institutions that are here, the TB survivors, implementing partners, colleagues from the Ministry of Health, notably the TB and leprosy program, colleagues from all organizations. I cannot mention each and every organization, but you know yourselves, and we know some of you. And I don't want to forget the media. I want to, first of all, appreciate you for the different contributions that you've made to the successful work symposium that you've all witnessed. We need to clap for ourselves. As a TB program, we feel so energized by all the enthusiasm that you have shown. From the call, the time we called for this symposium, you saw the number of abstracts that came in. They were double those that you could take in. Not that they were not good, but mainly because of the time that we had. Even for those that we selected, we found that even time caught with us. We thank you so much for showing that enthusiasm. I really, as a program, we like it. And we talked about everything started when we were in Paris last year for the Union Conference. We were coming across a number of people from Uganda who actually were presenting in the Union. And you were asking, where are you from? I'm from this organization. What are you presenting? And they had very good presentations. But somehow, we had not had a chance to interact or to listen to quite a number of those presentations that were made outside the borders of the country. So actually, this gives us a very good opportunity for us to be here and interact and be the first ones to hear what is being said, than hearing it, or even not hearing it ourselves, but then in Europe and in the US. So we should be the first one to get this information, because it is actually generated here in the country, and it's supposed to help the program to get policies that are going to help the Ugandans first and foremost before they go beyond. But allow me to thank you again for that. I think we all agree that we have really had very quality presentations, and I want to thank the committee, and in particular the committee that selected these presentations. Most of them have been talked about. I don't want to bother them again, but my own Professor Mwenge, she's there. You really did very good work in can you, people want to see you. So she's very good in analyzing the situations and advising in this kind of issues. So thank you so much, Pros. And as you've heard, this is just the beginning. We'll think that even next year, we strongly think that even next year, we will really participate in this same activity. So as a program, we were able to organize together with the committee the presentation is the different pillars where the program is working. So we had the pillar of epidemiology and surveillance, which is very key in disease detection and surveilling for drug-resistant TB and leprosy patients. We had about TB prevention, and something that not usually comes up are the issues concerning the prospects of the vaccines. That is very exciting. The TB and comorbidities, issues on case detection, on TB screening, and the laboratory, how they are supporting the program in detecting the TB cases. Then the social protections. This is something that is coming up very strongly, and I want to thank the team and other colleagues from other sectors that are working with the Ministry of Health to make sure that we have social protection packages in different forms to help the TB survivors and the TB patients. Then I want to thank the gender issues, gender and equity issues, and I thank the persons who are here presenting about the gender and equity issues. That is a very big pillar as far as TB and the other infectious conditions is concerned. Now, just a moment. Okay. So, other than the presentations, we have been able to do networking. I think we have networked in many ways with the different organizations, with the different persons that have been here. And I hope the networking, first and foremost, is for TB and leprosy issues, but it doesn't limit beyond, doesn't limit going beyond the TB, issues. So an opportunity has to be taken as it avails itself. I want to thank so much the Stop TB Partnership, TASO, and Global Fund for the logistical support for this symposium. Really, everything was organized in a short period of time, but we cannot even see any gaps. So thank you so much. If I was awarding, if I was grading, I would have given them more than 100%. I also want to thank Stop TB Partnership in Geneva, Walim, Michael Langer Institute, the Professor Puris Wine Group, again TASO, for the fundraising efforts for this forum. They all contributed in different ways, but to make sure that we have all the logistical support that we need to make this a success. Future plans from here as we go. I think we had rapporteurs, and you have also filled that form, that survey form, which has very important information. That information is going to be summarized, and it will be available to all of us. And it will really help in the way we are going to conduct future symposiums like this. So I think this is the beginning, but also it's a learning lesson to quite a number of us. So I hope that you filled that survey, and also the rapporteurs have captured quite very good information, which will help us to prepare well for the next symposium. Then we have a research forum, which we, as a program, there is a research forum which meets every last Friday, the first Friday of the month, and we encourage all of you researchers. This information that you've given us, we don't look only at the finished work, but we look at the proposal in their development so that we can also contribute one or two small things. We look at the progress of the work, we look at the finished product, and we look at the policy briefs. So we encourage you to register. I think, Stella, you make sure that the research forum, we get these participants. Since we get most of their emails, those who are not already on the forum, we invite them to participate. It is both physical and online. So please make sure that you join the research forum that meets every first Friday of the month. And Stella, you need to to follow this up. So, ladies and gentlemen, I don't want to delay you here very much. I just want to once again thank you so much. Thank the organizing committee, the technical and scientific committee, all of you for being here up to this time. Since I have no one else to invite, allow me to close this symposium and wish you all the best. And also to just inform you that next week we will be in Isingiro on the 27th of March for the World TB Day commemoration. And for us, we combine the TB and leprosy together so that we move as one, as the integration also concept goes. So, ladies and gentlemen, I once again thank you so much and wish you the best as you go home. And we hope next year we shall meet again for this kind of activity in a place that the Lord will take us. Thank you so much, and I wish you the best for God and my country.
Thank you very much, Dr. Luze. I shouldn't be talking after the meeting has been closed, but just to remind everyone that the abstract, the Union Conference is accepting abstracts, and the abstract close on the April 8th. Please submit an abstract so that you can come to the Union and we can meet at the Union. Remember, this started at the Union. Let us meet at the Union and continue to share. Yes, and there's also another science conference in July. You will be getting the communications. So there are many opportunities for us to keep meeting and sharing our science. Please stay in touch. All right, that said, thank you everyone for coming and safe journey home.